Check, testing. Check. Check, testing.
விழாவின் முதற்படி விருந்தோம்பல். நம் ரத்தத்தில் கலந்த பண்பாடு. மரியாதை கொஞ்சம், அன்பு கொஞ்சம், பணிவு கொஞ்சம், குதூகலம் கொஞ்சம், ஒன்றோடு ஒன்று கலந்தபடி விருந்தினர் உள்ளம் மகிழும்படி, விழா மேடை களை கட்டும்படி, இனிமையான துவக்கம் அரங்கேறும்படி, கரை ஒலிகள் விண்ணை எட்டும்படி, உபசரிப்பின் உயரபடி தொட்டபடி ஆற்றிடும் வரவேற்புரையே விழாவின் முதற்படி. இவ்விழாவிற்கு வருகை தந்துள்ள மேன்மை பொருந்திய சிறப்பு விருந்தினர் அனைவரையும் விடியலை வரவேற்கும் புன்னகை பூக்களாகவும், வான்மழையை வரவேற்க குலுங்கி சிரிக்கும் மயில்களாகவும், கானம் புரிய காற்றை வரவேற்கும் குயில்களாகவும், அழகலை வரவேற்க காத்திருக்கும் கரைகளாகவும் வரவேற்கிறோம். பேரன்பிற்கும் பெருமதிப்பிற்கும் உரிய இவ்விழா நாயகர்களான மருத்துவர்களை நிலவை வரவேற்க பலபலவென மின்னி வந்த நட்சத்திர கூட்டங்களாய் நாங்கள் புடைசூழ வரவேற்கிறோம்.
Good afternoon, ladies and gentlemen. A warm and hearty welcome to each and every one of you to this most awaited occasion, the first Indian International Conference on Focused Ultrasound, FIICU, organized by Royal Care Super Speciality Hospital and Focused Ultrasound Association of India, FUSAI. It is indeed a privilege to have all of you here as we embark on a journey of knowledge, collaboration, and innovation in the field of ultrasound.
To set the ball rolling, we are moving to the scientific session. Ladies and gentlemen, it is now to begin one of the most anticipated moments of the conference, the keynote address. And to deliver this, we are honored to have with us a true pioneer in the field of focused ultrasound, a visionary whose contributions are shaping the future of neurosurgery and psychiatric treatment, and who has 15 years of experience in MRG affairs and completed more than 600 procedures. It is a great honor that we invite Professor Jin Woo Chang to the stage to deliver the keynote address. Please join me in welcoming him with a huge round of applause.
Thank you for your kind introduction, and it's my great honor to have a presentation at the first inaugural meeting of the Indian International Conference of the Focused Sound Surgery. And in this presentation, I want to talk about thermal abrasion for movement disorders because of time limitation. And my disclosures, I'm currently undergoing several clinical trials, but it's not related with the thermal abrasion, SPBB opening, and neuromodulation. As I'll briefly mention it later on. As you well recognize, Dr. Lin and colleagues report the first in the studies in animal in 1942, and Fry brothers underwent first clinical trial with the support of the neurosurgeon Russell Mayer in the 1960s. However, they need to do open craniotomy, and it eventually disappeared. But year 2009, jury group first underwent incisionless emergency surgery for chronic pain, and I was involving into the international IC trial for essential tremor, and I also underwent the world first the capsulotomy for patients with obsessive compulsive disorders. I treated my first patient in March of the year 2012, and most recently I published 10-year follow-up result of the emergent first lesion for obsessive compulsive disorders. As you well recognize, there are many different mechanisms of the focused sound surgery. Today, I'm going to talk about thermal abrasion, but as I mentioned, in the near future, we will use BB opening or neuromodulation technique for the treatment of the many degenerative brain disorders. I briefly show the video clip of my patient I treated many years ago. We all well recognize that essential tremor is well controlled with focused sound, and patient family were pretty much satisfied about outcome for their returning to normal life. However, I underwent these procedures more than 14 years, and I treat almost 400 cases of the essential tremor. We encountered many problem cases, and also we need to make troubleshooting So I just mentioned about the challenging issues of the MRG first neuroabrasion for movement disorder. The first one is, what is the optimal lesion volume and where is the best target, so-called where is the sweet spot to show the best benefit, and what does it mean skull density lesion? I firstly reported the volume changes after the thalamotomy in 2015. As you can see, the lesion volume usually maximized 1 month after the lesioning, but at the last follow-up, lesion shrunk to very tiny lesion. Dr. Cosgrove showed in the similar pattern. Sometimes we can see the lesion, but sometimes we cannot see any visible lesion. But it doesn't make any problem for the patient tremor control. Also, still, we are trying to find the best target and also not to make any complication for our patient with the essential tremor. I'm combining the DTI image to find the best target, but as you well recognize, DTI images is not always correct. So intraoperative cross monitoring of the patient condition is also very important not to make any complication. I briefly mentioned about this recent survey. I was involved into this survey, and this survey compared the target XYZ coordinate in year 2019 and year 2021. But compared to the year 2019, many groups want to make a lesion above the ACPC line. It's because of the potential complication by the making a lesion in the level of the mid-commissural ACPC line. However, it's still debatable issue. Long time ago, I suggested the concept of the skull density ratio. I don't want to mention about in the detailed one, but concept of this one is if the patient has higher STR above than 0.4, usually we need to give the low energy and easily to make a thermal lesion in the brain. However, in this paper, I didn't mention that low STR patient has the failure of the treatment. We can treat the patient with low STR, but compared to the good STR, this is the patient with STR more than 0.4, usually making a thermal lesion in the VIM and didn't show any additional the lesion in the nearby structures. But if we treat the patient with low STR, sometimes because of the delivering the high energy can expand to the adjacent structures, can make an abnormal shaped lesion like this. Dr. Cosgrove also mentioned the similar finding. Most important thing is we can treat the patient with low STR, but if we treat the patient with low STR, should be more careful to make a thermal lesion in the target. Another important thing is that in our clinical survey, we found that many of the Korean patients has low STR. About 32% of the Korean population has STR lower than 0.4. Another very important thing is the skull volume, skull thickness, and skull shapes are also important for the successful treatment. I have many failure cases with high STR with a very thick skull. If the patient has very thick skull, also make a difficulty of the energy delivery. Also, the shape is also very important. Many of the Korean patients has flat occipital bone compared to the Caucasian people. In this situation, we need to give high energy because of the increased incidence angle. Also, if the patient has abnormal shape, we also need to be cautious about the thermal lesion in the brain. It's because it's not, the lesion is only related with the mathematical calculation of the CT images. It's not exactly the measurement of the target. Anyway, to overcome these obstacles, Insighted and I underwent very interesting clinical trial, so-called autofocusing echo imaging techniques. We measure the echo bounce in the each transducers Thus, we can adjust the ultrasound, the focus based on this echo bounds. By using this technique, we can make very discrete lesion in the target, and I can treat very low STR, even 0.29. We published these papers many years ago. Another interesting thing I found during my second clinical trial for Parkinson's disease is this. I select the 10 patients with high STR, but 2 patients with high STR has difficulty of the thermal lesion in the pallidum. And I assume that it's because of the laterality of the pallidal target compared to the thalamic target. And to justify this concept, we measure the eligible transducer in the centers and the lateral part of the skull. And we noticed that the central part has more eligible transducers within 25 degrees incident beam angle, like we experience for essential tremors and Parkinson's disease. I think the second topic is no more in the controversial issues. When we first underwent the bilateral procedures, we were worrying about the potential complications like speech problems or other complications. But we all noticed that these bilateral procedures are very safe if we have enough time for the second procedures. For this 60-year-old lady, I treat the right side year 2017, and I treat the second side about 6 years later, and the patient showed remarkable improvement of the bilateral tremor. This is another cases of the bilateral procedures. This is the video clip after the left beam lesioning. The patient only had the left side tremor. After the second treatment, the 1 year after the first procedures, the patient has complete control of the tremor in either side, like this. And this is the report from the North American group by the Dr. Caffrey. And they also noticed that even though some patients showed the mild dysarthria or the minor complication, but most of the complications or most of the side effects was mild and acceptable, and much better than the RF, the lesioning procedures. And also, people have doubt about the long-term benefit, especially as I showed in the volume changes. Most of the lesion disappeared 6 months or the 1 year after the sonication. We published the 1 year follow-up result at NEJM and 2 year result at the Neurology and 4 year result in the movement disorders. And in 4 years result, this is my own series. All patients showed a stable benefit of these all scores. And most recently, we published the 5 year follow-up result to the Journal of Neurosurgery. And patients still showed the significant benefit compared to the pre-sonication status. However, as we experienced in RF lesioning and DBS, some patients showed the recurrence, not exactly recurrence, it's kind of the disease progression or the combination of disease progression and recurrence. Even in the series of the 4 year follow-up, some patients showed the recurrence at 3 years or 4 years after the first sonication. In that situation, I underwent and repeat the sonication. This patient has left side thalamotomy about 13 years ago. The 10 years, the patient was completely free of the right hand tremor. But the patient started to show the tremor in the right hand. I believe it's not the recurrence, it's kind of the disease progression. And we underwent the second procedures, and the patient was free from the tremor. This is another cases. I treat the first site in year 2018, and immediately after the treatment, the patient showed a remarkable improvement of tremor. And this is before the upper image is before the first treatment. And 4 years later, the patient had recurrence of the tremor in the right side, but the recurrence is not as severe than the first operation. And we underwent the second sonications, and now the patient become free from the tremor. And also, this is also another debating issues. Most recently, the gamma knife surgeon published the result, and they argued that the gamma knife showed a similar benefit with less complication than focused ultrasound, but I don't trust this result. And I have a chance to compare my own series of the DBS and RF lesioning. We showed the similar benefit and the less complication with focused ultrasound. I think this topic is one of the most important the debatable issues among our audience. We are now having interest about the new target and the new modality and the new indications. As you will recognize, the PD tremor is also well controlled with this focal ultrasound like essential tremor. And after my first the pilot studies, we underwent RC trial for the Parkinson's disease by making the pallidal lesioning. But as I showed, many of the Asian patients has skull density problem and had some difficulty of the thermal lesioning, especially for the proper benefit. We need to make a bigger lesion in the pallidum. Sometimes it's not easy to make a bigger lesion in the pallidum as we made by the RF lesioning. Another important issue is even for tremor, there are many different types. For example, some patient has very severe proximal tremor, or some patient has tremor in voice, head, jaw, and other part, or some patient has dystonic tremor. Those tremors show the different benefit with focused sound treatment. Thus, as we did for the severe essential tremor or dystonic tremor, we combined the thalamic and subthalamic DBS, and I published this one about 12 years ago, and recently Drummond published in the similar PSA lesioning to control the severe, the essential tremor. Especially if we combine the dual lesion in Thalamus and PSA, can show the additional benefit. However, chance of the complication also increased. And I treat many patients with severe the essential tremor by combination of the PSA lesioning or by making a bigger lesion in the thalamus. But those patients suffer even though those complications are not permanent, many patients showed the potential complications with these combined procedures. But when you look at the mechanism of the tremogenesis, we believe that essential tremor is based on the cerebellar mechanisms, and Parkinson tremor is based on the motor pathway. But I think many of the essential tremor in a Parkinson patient has combined the pathology of the motor pathway and cerebellar pathway as we experience with the dystonic tremor. Thus, if we combine those two reasons, sometimes it can give additional benefit. This is my hypothesis, and we underwent the very interesting clinical trial. We all know that the pallidothalamic tract lesioning is not the new one, but making the pallidothalamic lesioning with the thermal with the sonication is much easier than making a lesion in pallidum because of the tight pathway in the mammillothalamic tract and subthalamic nucleus. This is my patient with dystonic tremor. The patient has very severe dystonic tremor like this, and 2 weeks after the treatment, the patient showed remarkable improvement, but still showed some remaining symptoms. But interestingly, like other dystonia, 6 months later, the patient showed completely disappearance of the dystonic tremor of the right hand like this. I combined the beam lesioning with PTT lesioning in the left side. This is another cases of the combination of the VO thalamotomy and PTT lesioning. The patient has the writer's cramp in the left hand, and after the 1 month, the patient has almost completely free of the writer's cramp of the left hand like this. This is my most recent cases. The patient has lingual dystonia, but the patient feels more severe symptom in the right side of the tongue. So I made a lesion in the left PTT, and immediately after the sonication, the patient mentioned that his symptoms almost the 60 to 70% disappeared. Maybe I can combine the additional PTT or the pallidal lesioning about in the year later. Maybe patient get 100% the recovery of the lingual dystonia. I think that this is one of the most important experience for my patient with the Parkinson's disease. The patient has very severe symptoms, but the body weight of this patient is only 35 kilogram, and the general condition of the patient was not good for the ST and DBS, and we decided to combine the PTT lesioning and the VIM lesioning because the patient has tremors and severe dyskinesia of the right hand. But 6 months after the sonication, the patient showed remarkable improvement like this. The patient was so happy, and we submit our papers, and papers almost accept to the brain stimulation. This is another the very interesting cases I experienced. The patient very severe the tremor. Long time ago, I made a lesion. Sometimes I combine the PSA lesion, but for this patient, I combine the PSA lesions, and the patient tremors completely gone like this. And this is one final topic, and I think many people ask about whether we can do these procedures after the first cranial operation. This is a report of the other group. They underwent the sonication after the aneurysm creep. I have very interesting cases. The patient has aneurysm surgery and had the bone cement on the operation side, but I couldn't make a dermal lesion in the VM nucleus without making any problem. And this is another very interesting cases. The patient has hemicoria and DBS in the United States, but I couldn't make a dermal lesion in the PTT, and the patient showed remarkable improvement after the PTT lesion. This is my last slide. I think dermal abrasion is available in many movement disorders, and now we are applying this technique for the psychiatric disorders and for other diseases. But in the future, we can combine the BB opening and neuromodulation for many of the other neurological disorders. The year ago, we made the Asian Pacific Society for Transcranial Focus on Society in Seoul, Korea, and the second meeting will be held in Shanghai end of this year. And we will make Asian DBS Forum in September of this year. And the focus sound is also a very important topic for this meeting. Please join this meeting. Thank you.
Thank you, Professor Jin. It's time to felicitate the speaker. I'm pleased to invite Dr. K. Madheshwaran, Chairman, Royal Care Super Speciality Hospital, and Dr. Arul Selvan, President of FIICU, to felicitate Professor Jin with a memento. Now the session is open for discussion.
Professor, you mentioned about lingual dystonia. How did you choose the site? Was it unilateral or bilateral? And the second question is regarding the lesioning after DBS electrode placement. Was the electrode explanted or was the electrode in situ during the lesion?
I didn't hear your first.
First question is lingual dystonia. How did you choose the side? Was it unilateral or bilateral?
I think for the focus sound, the bilateral procedure, the ones can be dangerous for patient. So at this moment, we are only treating patient with unilateral severe symptoms. For example, the dystonic tremor or even lingual dystonia, the patient has more severe symptom in the right side. But later on, maybe we can do the bilateral procedures at once, as we did many years ago for the pallidotomy with RF lesioning. But the guideline in our country is still prohibited to do the bilateral procedures at once. Yeah.
The one with the DBS electrode, was the electrode explanted before lesioning? One with the DBS electrode in situ, was it explanted before lesioning or was it?
Yeah, right. The case I didn't explain in detail, but this is the experience, but world first experience of the focus on treatment, even with DBS implantation. But fortunately, the patient has the Medtronic Percept electrode, which is enabled to do the MR imaging during the procedures. But we had some difficulty with making a thermal lesion. But we found that this treatment can be feasible. And after my first experience nowadays in the United States, many groups underwent the similar procedures with DBS implantation. But the only issue is if the system should be MR compatible. Yeah. Okay.
Thank you, Professor, for the talk and especially for your pioneering work in the field that has helped the others to move forward. I have two questions. The first is, do you know if there is in the PTT, there is any somatotropy in terms of upper limb or lower limb, like in the basal ganglia, because that would maybe help us to individualize treatment depending on the clinical presentation. And the other question is, have you evaluated the topography of the PTT lesions to see whether they spread or extend to other structures like the subthalamic nucleus, or because I spoke with Michael Kaplit a few months ago, and he mentioned that part of the PTT effect might be related to a ventral spreading to the STM, but this has not been proven. So have you analyzed the topography of those lesions? Thank you.
Yeah, it's very important and a very fascinating field we need to do in the future. But unfortunately, we couldn't analyze carefully about which part is controlling the upper limb or which part is the lower limb. So I showed one case is the writer's cramp. I combined the VO lesioning and PTT, and some doctors asked, the PTT's fibers are going to the VO, why you are making the both lesions together? Because we don't know. Even though we are trying to make a PTT lesion, sometimes we can miss some part of the PTT. If we make another lesion, the VO, maybe we can cover the empty part. So this is very interesting field. But I didn't show my cases. If we make a bigger lesion in the PTT, sometimes patients show the transient, even though it's a transient, show the significant complication like somnolence or gait problems. So I don't know which one is good, but in the future, that is also a very interesting field we need to search.
Thank you.
Yeah.
We are not allowed to do the bilateral lesion in India also. We have recently encountered a patient who had a severe cervical dystonia. And we have done only one side, the PTT, and then he showed a remarkable improvement on the other side also. Our experience also says that although you target on the unilateral side, the improvement has been seen on the bilateral also sometimes. Is it a similar experience you had?
Yeah, I think the other groups showed a similar benefit. Dr. Horisawa showed the remarkable benefit with one side. For example, About 15 years ago, I published one paper regarding the ST and DEBS after the implantation of bilateral procedures. At the time, we used Activa SC or the Kinetra or other thing. If we do bilateral procedures and then if the patient has infection in one side, we should remove it. But many of the patients showed sustained benefit, even removal with one side. So I think it's quite interesting. But the patients who showed remarkable the benefit, about 70 or 80%, the patient usually want to have, some of my patients already asked me to have second operation because I started this PT lesioning from a year ago. So I'm ready to start the second lesion, but I'm still worrying about the potential side effect of the bilateral PT lesioning. Thank you.
Thank you, Professor Chang, for such an enlightening and inspiring keynote address. Your groundbreaking work in focused ultrasound is truly shaping the future of neurosurgery and neurological treatment. We deeply appreciate your time, expertise, and vision in advancing these fields. Let's give him another big round of applause.
கதிராக்கவியல் மற்றும் இமேஜிங் அறிவியல் துறையில் ஒரு சிறந்த நிபுணரை வரவேற்பதில் நாங்கள் பெருமிதம் கொள்கிறோம். As we continue with our scientific sessions, it is our privilege to welcome a distinguished expert in the field of radiology and imaging sciences. With 12 years of experience in radiology practice, Dr. Senthil Kumar has dedicated his career to advanced medical imaging. Holding an MD in medicine and prestigious fellowships in musculoskeletal ultrasound from the USA and Spain, he has made significant contributions in the field of diagnostic imaging. We please welcome him with a huge round of applause.
Thank you. Good afternoon, everyone. At the outset, I would like to thank our visionary chairman for getting us a platform to present our things. The talk is about Hindustani SDR. Hindustani SDR, the word coined by Dr. Vijayan sir, and earlier in the olden days, Hindustani refers to the people originating from the Indian subcontinent. So that's how. So today's our topic will briefly cover about the MRGFUS, some brief history. Already some things were discussed by our Professor Jim, and the ultrasound and skull and the skull density ratio, which is very important, and some conclusion. As you all know, MR-guided focused ultrasound is a treatment option for patients with essential tremors or Parkinson's disease who haven't responded to medication or are not willing to have invasive surgery. The procedure uses focused beams of ultrasonic energy guided by MRI to target areas deep in the brain with no incisions or permanent implants. Some of the early developments, especially the 1954, the first HIFU device developed for neurosurgery, but faced limitations due to the need for open skull procedures. With the advent of ultrasound phased array transducers and the development of MR thermometry in the mid-1990s, the MR-guided focused ultrasound machine by the Insightec was launched in 2001. Similarly, after clinical trials in 2016, Insightec's Exablate Neuro device approved to treat essential tremors in the US and Canada, and subsequently for the tremor-dominant Parkinson's disease. And additional thing, in 2021, it got the approval for the treatment of patients with advanced Parkinson's disease suffering with mobility, rigidity, or dyskinesia symptoms. This is our 3 Tesla unit integrated with the Insightec Exablate Neuro system. And you can see the helmet-shaped transducer with the phased array 1024 elements, which operates at a mean frequency of 650 kilohertz. And with the advanced focusing algorithms, we can make a precise focal spot of 2 to 5 mm. The ultrasound pulses ranges from 5 to 60 seconds duration, delivered to ablate target areas by multiple sonications. This is the patient positioned. Skull density ratio is defined as the ratio of cortical bone density to trabecular bone density measured in Hounsfield units using CT imaging. It's a crucial metric in MRGFES, particularly for procedures targeting deep brain structures, such as the WIM nucleus for tremor and PTT for Parkinson's. SDR is used to assess the ability of ultrasound waves to penetrate the skull effectively while minimizing energy loss and unwanted skull heating. It helps in predicting the success of the procedure and ensuring patient safety. As you all know, the human skull is composed of 3 layers. The outer cortical one, which is dense and causes high attenuation to the ultrasound waves. The middle trabecular cancellous bone is porous and it has got lower density. And the inner cortical bone is something similar to the outer cortical bone. So ultrasound waves must pass through these layers to reach deep brain targets. Skull is an important barrier for ultrasound traversing into the brain. Skull distorts the ultrasound waves, absorbs energy, leading to skull heating and attenuates the ultrasound beam. So a dense cortical bone with less porous trabecular bone allows better energy transmission, whereas a highly porous skull can scatter and absorb more energy. So the normal SDR range is from 0.4 to 0.7. And we have treated patients with a SDR of 0.28 to maximum of 0.78. So higher SDR, which is more than 0.4, has good ultrasound transmission, and patients with lower SDR, there is a chance of poor transmission, risk of excessive skull heating. The 3 important factors related to skull penetration of ultrasound includes the skull density ratio, skull volume, and the incidence angle of the acoustic rays against the skull surface. This is a 2-dimensional schematic of a hemispherical phased array transducer showing multiple beams converging at a geometric focus. SDR is influenced by several key parameters. These parameters are critical for patient selection, treatment planning, and outcome prediction in MR-guided focused ultrasound. The key parameters include the cortical bone density, the density of the outer layer of the skull bone measured in Hounsfield units. It ranges from 1200 to 1800 Hounsfield units. How it impacts on the SDR, higher cortical bone density, higher SDR, better ultrasound penetration. And if it is a lower cortical bone density, there's a chance of lower SDR and increased ultrasound attenuation. The second key parameter is trabecular bone density, the density of the inner porous trabecular cancellous bone of the skull, which is also measured in Hounsfield units. It typically ranges from 100 to 400 Hounsfield units. And this also impacts, make a thing on SDR, lower trabecular bone density, there's a higher SDR for better ultrasound transmission. The skull thickness also makes a key parameter. The combined thickness of the cortical and trabecular bone layers are measured in millimeters. Typically it ranges from 3 to 10 mm. Thinner skulls with 3 to 6 mm, there is a better ultrasound transmission. Thicker skulls, more than 8 mm, more ultrasound absorption, there is a risk of heating. So thick skulls require high ultrasound power. And then the other parameter is skull porosity, the percentage of trabecular bone within the skull. More porosity, that is higher trabecular bone density, more ultrasound scattering, and effectively there is a lower SDR. And if it is a lower porosity, less trabecular bone density, better energy penetration, and it leads to higher SDR. There is one more point, it's the skull attenuation coefficient, the rate at which the ultrasound energy is absorbed or scattered by the skull. It's measured in decibels per centimeter. Typically it ranges from 8 to 12 decibels per centimeter. And lower attenuation coefficient of less than 8 has less energy loss, and there is a efficient lesion formation. If there is a higher coefficient, significant energy loss is there, and there is a insufficient lesioning is there. So how do you calculate the SDR? We use the CT scanner, preferably 1 mm slice thickness. The Hounsfield units of cortical and trabecular bone are measured at multiple points. The mean cortical HU value is divided by the mean trabecular Hounsfield unit value to obtain the SCR. We use a 128 slice CT scanner with scanning parameters of peak X-ray tube voltage of 120 kVp and a tube current of 500 MAs and a helical full scan time which does it in less than 1 second. So and then we use a high pass filter like Bone Plus in a GE scanner supplied to the reconstructed CT images to enhance the dynamic range of the skull while suppressing that of the other parts in the images. So we use a 512 by 512 matrix, and with a specified bone enhanced filter, we get a high spatial resolution volumetric data set of 0.625 mm thickness. And then the acquired images are fed to the Exablate Neuro platform, and this shows like the planning one, we take the ACPC and mid-sagittal points are defined on the system, and we use the built-in tool named target by ACPC in the Exablate Neuro system to simulate a target, and the spatial position of a simulated MRGFS transducer helmet was then adjusted to align the ultrasound transducer focus and the simulated target of each patient. In the next treatment setting, we'll be able to do the transducer and take the SDR values, where in this patient you can see the out of the 1024 thing, the 947 elements are on, and the skull area of 313 centimeter square and an SDR of 0.62. The preferable range is, as I said earlier, it's 0.4 to 0.7. This is how the image looks with a low SDR and a skull image with the high SDR. So interpretation is more than 0.5, excellent ultrasound penetration, SDR 0.4 to 0.5, good penetration, and there is a moderate penetration in 0.3 to 0.4. Longer heating times are needed, and SDRs with less than 0.3, there is a poor penetration and high risk of skull heating. So even though low SDR, meaning less than 0.4, and skull volume of more than 330 centimeter cube are not contraindications to MRGFUS, higher energy, sonication power, duration, and the number of sonications may be required to achieve a therapeutic temperature above 52 degrees to make a permanent thermal lesion. Patients with higher SDR values require less ultrasound energy to achieve therapeutic temperatures of 55 degrees at the target site. So higher the SDR, less joule energy is required to make a lesion. For example, within 5000 joules, we will be able to make a lesion. With low SDR patients, they may experience ultrasound attenuation necessitating higher power, leading to increased skull heating. So lower the SDR, higher energy joules are required to make a lesion. It can go up to 50,000 joules. Effect on treatment outcomes. For higher SDR, more efficient energy transmission, faster and more effective lesion formation happens. In lower SDR patients, less energy penetration and less predictable outcomes. So SDR influences treatment duration, number of sonications, and the risk of side effects. And optimizing MRGFS patients with low SDR can use individualized ultrasound power settings, extended sonication durations at lower power. Some words about the intra and post-op procedure imaging. We generally use the T2 weighted imaging, which is the most useful sequence for visualizing the ablation outcome. Sonications produce heat at region of interest that causes necrosis at the center, which is followed by concentric rims of cytotoxic and vasogenic edema. And these findings persist for a few months, followed by complete loss in T2 weighted imaging. This is an example showing central necrosis and concentric edema around it. 3 zones of lesion will not be present at all the time during intra-procedural imaging. This one post-procedure, day 1, you can see the central necrosis followed by cytotoxic and outer vasogenic edema. And this is one imaging follow-up which shows it completely gets lost by 6 months. And what you see here is only at the 6 month in the susceptibility weighted imaging, there is a focus. Lesion size, generally it increases in immediate post-procedure imaging, but on further follow-up, the lesion starts shrinking. And finally, this can be characterized only in SWA as a small hypointense blooming artifact. And one word which we have not encountered, but there are with low SDR patients with repeated thalamic lesion and there are multiple marrow lesions with maybe infarctions in marrow space, which we have never encountered. And these are the research and regulatory approvals of each and every body system. In neurological things, a lot of things are happening, and already there is an approval for the obsessive compulsive disorder and depressions, and likewise there are many more things happening throughout the world with a lot of trials happening. And to conclude, this is our mean value, median SDR of 0.56. That's how the Indian thing has happened. So we have got patients from Kashmir to Kanyakumari and from Calcutta to Jaipur, and we have audited everything, and then to put it into perspective, the skull density ratio, the mean SDR of 0.56 is there, and as you can see in the second thing, with the low SDR, the joules, delivered joules went up to 58,000 joules with a patient of 0.28, and we were successfully able to do the procedure. And this is our team, and thank you so much for the patient listening.
Thank you, Dr. Sendil. It's now time to felicitate the speaker. I am pleased to invite Dr. Madheshwaran and Dr. Arul Selvan to felicitate the speaker with memento.
Now the discussion is open for question.
Thank you for your nice summary of the concept of the STR. I think this topic is very important. The kind of the practitioner, especially you had one patient with low STR like 0.3. You gave almost
58,000 joules.
I want to know the progress of the patients. The patient is okay.
The patient is doing good, sir. We were able to do it perfectly well. But that was one kind of patient with 0.28. But rest of the thing, other patients are really with higher SDRs, we are able to do properly.
And also, they want to know your tactics about managing your patient. Is sometimes if the patient has high STR, the temperature can increase
Very quickly. Yes.
How many times do you make the thermal lesion above 54, 55 degrees Celsius? 2 or 3 times, or 5 or 6 times? Or
Generally, it is less, sir. For the patients with the align and verify phase itself, we try to negotiate how much the temperature is getting added. And in the low treatment phase, we will be able to complete it. And we are getting good results in that. We generally don't cross beyond 54 degrees, sir.
Did you have any cases of the abnormal increase of the size with high STR?
Yes.
Okay.
Sendil, is there any way we can alter the SDR therapeutically? For example, lower SDR, you give vitamin calcium supplementations or vitamin
I don't
D.
know whether the studies have been going on in this. It should be a new trial. Maybe we can start up treating patients with the.
That's nice, interesting, because when you have a low SDR, you can give vitamin D supplementation or calcium.
Maybe Professor Jim has done a lot of volume on this aspect, whether he has encountered, because the Korean population of 32% is having only 0.3 SDR. So do you have any? Or Raul?
Anyone can.
Yeah. Could you tell me again?
I asked, is there any way we could change the SDR value from the lower SDR value to a higher one by giving therapeutically, for example, calcium supplementation or vitamin D, so that the SDR value could increase, the porous skull becomes more thicker?
I think a long time ago, I usually treat a patient with high STR, above 0.4, but nowadays I treat even STR like 0.35, 0.33. But the another important factor is that we must select a patient with good skull thickness. If the patient has average thickness less than
3,
less than 7, usually it's fine to make a thermal lesion. But we must cautious about the region volume, because if we give high energies it's because of the accumulation of the energy. Sometimes region can expand to the internal capsule or the sensory thalamus, so can make a damage of the adjacent structures. But nowadays we treat patient less than 0.35 or 0.33 is our low limit. But I never treat a patient with SL 0.3. Sometimes if we give energy more than 50,000 joule or 60,000 joule, maybe you also suffer the abnormal shape of the lesion or some kind of a side effect.
Right. Thank you, sir.
There's just a comment on increasing the SDR. There are some papers which show that if you supplement bisphosphonates and calcitonin in a patient with adequate vitamin D, it is possible to raise the SDR.
Yeah. Okay.
But our problem is more with high SDRs. So we've started off as low as 500 joules in certain patients with 500 joules, and we've finished lesioning with 5,000 joules. Total joules itself 5,000. We had a patient with 0.77. The first side we did not have problems. When we did the other side, he had a severe ataxia. I think I spoke about this to Rahul, and Rahul told me, apply the mask regularly for all these patients. So the problem we face when applying the mask is the lesion becomes elongated. And it goes grossly beneath the ACPC plane, sometimes ending up with severe ataxia. But I must say that even that patient with severe ataxia, after 3 months, is now walking without support.
Thank you, sir.
Do you think it's only the STR values determine the high frequency ultrasound energy? Because we had two patients, you may be well remembering that, both two patients. Both of them had a low STR. One is at 0.28, another one is 0.3. The 0.28 patient we have done extremely well.
Well, yes.
Because we could able to deliver the joules as we expected, and the lesion has happened and she's doing well. At the same time, the same SDR patient we struggled. We started at 7 o'clock, we ended up at early morning 1 o'clock because the energy has not been sufficient. The SDR value alone is important, or some other factors?
Maybe the skull thickness also, as Professor Jim said, with less than 7, it emanates for the procedure, and then if it is more thicker thing, we might finding it difficult, even though the low SDR values are there.
So the skull shape and the incident angle of the waves also is very important. We've seen the skull shape to be very important and the incident angle to be very important in determining the lesion.
Thank you, Dr. Enns, for such an insightful and enlightening session. Your expertise in radiology and advanced imaging has truly broadened our understanding of the vital field. Thank you, sir. The summer has started and it's high time to cool down with the coolest session. Yeah, you heard it right. He's so cool, even ice cubes are jealous. இவர் நரம்பியல் அறுவை சிகிச்சை பராமரிப்பை மேம்படுத்துவதில் முக்கிய பங்காற்றுகிறார். அவரது நிபுணத்துவம், அர்ப்பணிப்பு மற்றும் நோயாளிகளின் நல்வாழ்வுக்கான உறுதிப்பாட்டின் மூலம் பலரின் மனதை ஈர்த்தவர். அவரது மதிப்புமிக்க நுண்ணறிவுகள் மற்றும் நிபுணத்துவத்தை பகிர்ந்து கொள்ள அன்போடு அழைக்கிறோம்.
As we move forward with our scientific session, it is an honor to welcome a distinguished expert in the field of neurosurgery, Dr. Raghuraja Prakash. Dr. Raghuraja Prakash serves as a consultant neurosurgeon at Royal Care Super Speciality Hospital, where he has been instrumental in advancing neurosurgical care. With his expertise, dedication, and commitment to patient well-being, he had made a significant impact in the field of neurosurgery. We are privileged to have him here today to share his valuable insights and experts. Ladies and gentlemen, please join with me in welcoming Dr. Raghuraj Prakash to the stage with a big round of applause.
Thank you for the nice introduction. I'm happy to welcome you all. I'm happy to be one among this conference, this first Indian focused ultrasound conference, where we could see the emerging is transforming, which is a new technology, innovative technology, which is transforming entire neurosurgical practice. Initially, it started as a crude surgical techniques, followed by precision techniques, and later non-invasive techniques. We think this MRGF is started, actually it started only for essential tremor. It stands for flagship platform for essential tremor, but later on it was found that not only for essential tremors, Parkinsonism disease, psychiatric disease, OCD, dystonias, depressive disorders. Apart from this, many neurological disease, dementias, Alzheimer's disease, and at present tumors also has been taken over, treated by this MRGFES. So we think after 10 years period, this innovative technologies is going to change the neurosurgical practice and neurological practice from a precision to a non-invasive perfect position, where we call it as a Buddha's knife. Actually, Buddha's knife terms precision without knife, a knife which is going to give a cure and healing without any side effects. So I'm going to take you through a journey of lesioning of brain surgeries from past, present, and futures. For centuries, brain is being huge for different techniques. Surgical techniques, initially it was very crude. Later it was converted by pioneer neurosurgeons into a precise surgical techniques. And at present we use focused ultrasound, where there is no knife, no incision, only focused ultrasound, where we make a lesion within the brain. So to introduce lesioning surgery in the past, it was used with the crude techniques. Initially, there was a trepanation of the bone. After that, they did procedure. It was an early technique with huge side effects. We should thank them, because by crude techniques, though they had many difficulties, more side effects, but based on these fundamentals only, our at present neurosurgical practice has evolved to a great techniques, refined techniques. A lesioning surgery is a surgical technique where specific brain regions are intentionally ablated to treat neurological and psychiatric disorder at present. At present, it is used for essential tremors, Parkinson's disease, chronic neuropathic pain, epilepsies, and psychiatric disorders. Originally, as I said, it was an invasive procedure. At present, it has evolved to become a lesioning into a precise, minimally invasive, and even non-invasive procedure. So here, what we mean to say with the Buddha's knife is, it actually represents wisdom, precision, a tool that's going to heal rather than harms. The same tool was handled by the early neurosurgeons, though they had difficulties. Those basic steps now transformed into a precision tool. So it is a modern lesioning technique by the MRGFES to treat neurological conditions without incisions. So in the past, as I said, early they used trepanations over the skull. After it's making a hole in the brain itself very difficult during early times. It took hours to make a hole in the brain. And to locate the lesion is also very, very difficult. So early trepanations was there, a crude technique. It was in between the ancient civilizations. So earliest recorded neurosurgical practice, where they drilled holes in the skulls, they used it for epilepsies, head trauma, and psychiatric disorders. So during evolution in the 20th century, this techniques has transformed. As I said, after trepanation, during trepanation, the ultrasound was delivered to the brain by making holes in the brain. But the issues was to localize the lesion within the brain, the ultrasound will scatter within the brain. So initial stages, though we focused ultrasound in the brain through the holes, it can make a lesion within the brain, but it will also make a lesion along the site structures, along structures nearby, which are more vital structures. So it will have more side effects. So we have termed the crude method with more side effects. During evolution, from the in-focus ultrasound, phased array techniques came, where the lesion will be targeted precisely without making without harming the adjacent structures. Here in 20th century, we have ablation techniques. In 1990s, they evolved with the help of Harsey-Clarke's stereotactic frame. They used initially for schizophrenia and severe depression, and later radiofrequency ablation came in 1940s and 1970s. Even till now, we use the radioablation techniques. They used electrodes to heat and destroy targeted brain structures. They apply for Parkinson's disease, essential tremor, and dystonia. So in 1950s, in 1980s, the pallidotomy, thyroidotomy came into functioning. Here also, as I said, we have huge difficulties by, because while making a lesion, surrounding structures are also damaged, namely internal capsule and mammillothalamic tract, and also the midbrain structures. Patient may have ataxia, ataxia, walking difficulties, memory disturbances, all issues were there. These surgeries were highly effective, but there was an irreversible damage and associated with significant risk. So limitation, as I said, they were the open surgeries, craniotomies, risk of complications, bleeding, infection, and cognitive impairment. Irreversibility is limited widespread of use due to that. So at present, we come to the rise of an MRGPS. As I said, it's an innovative technology, non-invasive. It is a create a precise lesion within the brain. It's guided by real-time MR thermometry, eliminates the need for incision, reduces risk and recovery time. Actually, patients wears a frame to keep the head stable. We fix it, the frame, and focus ultrasound waves pass through the skull, converge at a specific target. With the help of thermometry, ensures controlled, accurate heating, which we will be seeing in the live streaming. Yeah. The advantages over traditional lesioning. Older techniques have more side effects, as I said. This MRGPS technique, it's a non-invasive technique, no incision, no risk of infection. It has a real-time monitoring. MR guidance ensures precise targeting. Real-time monitoring, we can monitor the temperature of internal capsule. We can monitor the temperature of mammillothalamic tract. We can monitor the temperature of adjacent structures wherever we want. And also we can monitor the lesion temperature. And patient has quick recovery, often returns home on the same day. We have high precision, avoid damaging nearby brain structures. High precision, it means 0.001 precision will be there. There is no radiation exposure, unlike radius surgeries. So clinical applications of MRGFES. So as I said, it's a flagship indications for MRGFES, initially for essential tremor. Later on, following essential tremor, we have started treating Parkinson's disease and psychiatric disease as well. So at present, MRGFES thalamotomy is a FDA approved procedure. It provides significant and immediate tremor reduction. It's going to replace the DBS procedure in future, though there is role for DBS at present. With respect to Parkinson's disease, it was the second flagship indications by MRGFES. So we have few targets like WIM nucleus, pallido-thalamic tracts. There are also few targets like medial targets, lateral targets, and extended lesioning procedures, which will effectively control the tremor, rigidity, and dyskinesias as well. Bilateral lesioning is being explored. So far, we have not done bilateral lesioning at the same time. So other emerging procedures, I can say chronic pain procedures for chronic neuropathic pain, chronic trigeminal neuralgic pain. We can target the thalamus or the cingulate cortex or CLT nucleus. And also for epilepsy surgeries, we have targets like we can also target the pallido-thalamic tract and also the hypothalamus structures, amygdala can be targeted. Studies or investigations are going on for ablating these areas. With respect to psychiatric disorders, we already have approval, FDA approval to treat the depression, OCDs, and addictive patients. So as I said, these are the emerging psychiatric disorders, OCD and depression, where we make a lesion in the anterior limb of internal capsules. You can see there are two lesions in the anterior limb of internal capsules. It is approved procedure. It is going to give a good cure for obsessive compulsive disorders and depressive patients. So as I said, with respect to epilepsy, here you could see they are targeting the hippocampus regions. With respect to updates, I can tell you one thing. In focused ultrasound, we make a lesion in the optimal dose. So we make a lesion around 50 to 54 degrees centigrade. While performing epilepsy surgeries with MRGFES, they found that as the targets are more lateral, they could not make a lesion with the ablative dose. So what happened is subablative dose was delivered. So around 46, 48 degree was delivered. But what happened was patient did not made a lesion within the brain, but still patient improved. So they found out how the patient improved. So even they did not make a lesion with this ablative dose of 50 to 58 degree. They made a suboptimal dose of lesion, which is not seen in MRI. And what happened is it made a change in the brain. Neuromodulation starts happening. So instead of making a lesion, this MRGFE is starting to give a new way of treatment by neuromodulation. So by neuromodulation, those patients, especially this patient, got rid of epilepsies. So this is the newer technology in MRGFES. Instead of making ablative procedures, future updates will be neuromodulation in MRGFES. So key techniques and targets in MRGFES at present we follow are the WIM nucleus lesioning techniques. There are different techniques. We use US techniques, which is image guided, Thyras technique, we use Japan pioneer in MRGFES, and also we have special royal cut target by ourselves. We modified ourselves. We usually follow the WIM line technique as well. This is a new target method for improved precision and safety. With respect to PTT lesioning for Parkinson's disease, we have medial and lateral targeting strategies for optimal symptom control. Depending upon the dystonia, dyskinesias, rigidity, and tremors, we lesion both targets. So future, as I said, in MRGFES, we are thinking of lesioning procedures. In future, is going to be making a neuromodulation. So this past, present, and future. In future is going to be, initially we made a crude lesion, precise lesion. At present, focused lesion, targeted, and future, without lesion, only neuromodulation will be there. In MRGFES future, we will be targeting with suboptimal dose by neuromodulation and regeneration of neural circuits. So advancement in MRGFES is going to be personalized treatment based on AI-driven algorithm to enhance target selection. At the same way, customized lesioning based on individual brain anatomy. And bilateral treatment, as I said, at present we go on unilateral only. Currently, MRGF is mostly unilateral. So in future, maybe bilateral lesioning will be done safely. So repeated procedure and adjustability, potential for stage lesioning to fine-tune effect over time. So beyond MRGFES, the future of lesion and neuromodulation. So non-lesion focused ultrasound, instead of creating lesions, ultrasound waves are used to modulate brain activity, as I said before, being studied for depression, chronic pain, and epilepsies. And gene therapy and regenerative approaches are future. Can lesion be combined with stem cell therapy to regenerate lost neural function? And also, future will be brain-computer interfaces and cognitive enhancement. Like this, neurosurgery is going to fit in. Future neurotechnology include BCI and AI-driven interventions. So few words about blood-brain barrier opening. In MRGFES, we use HIFU energy and low intensity also. Here we use low intensity energies. First, we inject the microbubbles into the patient and we deliver focused ultrasound. These microbubbles will move around the vessel walls and disrupt the endothelial wall. By disrupting the endothelial wall, there will be opening in the vessel wall so that any drugs we deliver to the patient will be delivered into the brain. It was more successful for Alzheimer's disease, for example. So initially, when they opened the blood-brain barrier for Alzheimer's disease, just they opened alone, they could see changes in the patient's cognitive impairment. They just said, even without delivering drugs, by just opening the blood-brain barrier itself, there will be movement of plaques, amyloid proteins, everything. The patient will have some changes by improvement cognitive impairment. This blood-brain barrier opening will last for few hours only, which can be used to treat brain tumors with chemotherapeutic drugs, and you can use to deliver viral vectors in many diseases. So this is how the blood-brain barrier is opened. By passing the ultrasound, endothelial wall will disrupt. It will give way to other vectors to get inside. It can be used for gene therapy as well. In future, for Parkinson's disease, gene therapy will be there, where it will augment the MRGFES. In gene therapy, which is going to be a permanent and will give a promising results for Parkinson's disease, which is under the pipeline actually. So I could tell our 2 years experience in MRGFES, our evolution for the past 2 years. So initially we made a small lesion, and at present we are happy to make a good lesion, bigger lesions also. Initially we made a lesion for essential tremors along the WIM nucleus, and we extended our lesion like involving the WIM vivo nucleus, and later we started treating Parkinson's disease patient. From making a single lesion, we started making dual lesions, one in the WIM nucleus and another one in the pareidothalamic tract. Here you could see the extended lesioning, which is one in the medial pareidothalamic tract, one in the lateral pareidothalamic tract, and also huge WIM vivo complex lesioning. So at present, we also make a lesion in the GPA as well. So this is our evolution in making a brain lesion in past 2 years. So to conclude, listening surgery has evolved from crude primitive techniques to highly precise non-invasive intervention. This MRGFUS is a revolutionary functional neurosurgery offering a safe, effective, and incisionless alternative. Future innovations may further refine neuromodulation, personalized treatment, and regenerative therapies. A final thought for this my talk, Buddha's knife, which is a perfect balance between power and gentleness, a tool that reshapes the brain without cutting it. This transformation is just beginning of a new era of neurosurgery. Thank you.
Thank you, Dr. Prakash. It's time to felicitate the speaker. I'm pleased to invite Dr. Madheshwaran and Dr. Vijayan to felicitate the speaker with a memento. It's very nice to see the mentor, Dr. Madheshwaran, honoring his student.
தன்னை மிஞ்சி நின்றாலும் இவன் என் பிள்ளை என கர்வம் கொள்ளும் குருவும், நான் இவர் மகன் மாணவன் என பெருமிதம் கொள்ளும் சீடரும் காண கிடைத்த அழகிய தருணம் இது. Ladies and gentlemen, let's try to shoot the coolest with their questions. Thank you, sir. It's a wonderful session. Let's give him a great round of applause.
Ladies and gentlemen, it is an absolute honor to welcome a distinguished expert in neurology and movement disorders, Dr. Raul Martins Fernandez, who's gonna give a fusée oration unlocking the mysteries of Thalamus and its connections. With extensive experience across leading institutions in Spain, UK, and France, Dr. Fernandez has made groundbreaking contributions to Parkinson's disease treatment, deep brain stimulation, and high-intensity focused ultrasound. As the coordinator of the focused ultrasound program at HM Sinac Hospital, his research has been featured in top medical journals, earning him we are privileged to have him here today to share his expertise. Please join me in welcoming Dr. Fernandez with a big round.
Well, good afternoon. Thank you for the introduction. I'm very happy to be here in India. This is my third time in India. It's a country that fascinates me, so thank you to the organizers for the invitation. And I'm very honored of sharing panel with the speakers today. I have been asked to speak about the thalamus and the mysteries of the thalamus because indeed the thalamus is a quite complicated structure, both anatomically and functionally. It involves several nuclei, as you can see here, which drive different functions. By the way, it has been made available quite recently. You can find a Memorial Atlas human thalamus in the Montreal space, voxelized in the Montreal space, and this is publicly available in this website. So you can use it for either research or also for targeting. So it's a very good tool to take into consideration. I was saying that the thalamus is complex anatomically, but if it is complex in terms of number of nuclei, let alone the number of connections. This is just a diagram of the connections of the anterior thalamic nuclei in the mice. So this, again, a very complicated structure to explain. For this reason, and considering the context, instead of giving a lecture about the mysteries of the thalamus, which would be very ambitious and even pretentious, what I'll try to do is to explain the connections of the thalamus through the experience that we have gathered over the last few years using focused ultrasound. And if we are going to talk about focused ultrasound, functional neurosurgery, we need a context. This is an old field. This has been already explained today. These are some of the most important figures in the field that in the 40s create and open the path to start treating patients who had either psychiatric conditions or movement disorders with ablative neurosurgery. These were invasive interventions that require skull incisions, but they were effective. Those treatments were effective. I wanted to include Narabayashi because Westerners tend to think that everything happens in Western countries, in America or in Europe, but it was worldwide. The development of this field occurred worldwide in the 40s and 50s of the last century. The first target to be considered was the pallidum. In fact, the first acknowledged intervention, was performed by Spiegel and Wysis in a patient with Huntington disease in the late 40s, and this patient received a pallidotomy to treat chorea. But very soon, and according to some findings in pathology studies, it was shown that those patients who had improved the most tremor, instead of having the lesion focus on the pallidus, it affected also the thalamus. So it was the striking effect on tremor of thalamotomy, of the lesion enlarging in the thalamus, that made the thalamus become the preferred target to treat movement disorders at that time. And over the years, several techniques have been used: radiofrequency lesion, focus ultrasound with skull opening, radiosurgery with gamma knife, of course, deep brain stimulation in the 90s, and today we have another tool. We have a relatively new or not so new tool, which is focus ultrasound. The first indication attempted with the modern equipment of focus ultrasound was neuropathic pain. This was a case, a small open-label case series by the Swiss group in Zurich, I believe, and they target the medial thalamic nuclei to treat patients with different kinds of neuropathic pain. They target the medial thalamic nuclei and particularly the central-lateral nucleus. And why did they target this nuclei of the thalamus to treat neuropathic pain? Because according to some classical findings, it seems that neuropathic pain could be driven by abnormal bursting in the central-lateral nucleus of the thalamus. This abnormal bursting creates an imbalance in the sensory thalamic nuclei and leads to the manifestation of neuropathic pain. So by abolishing this abnormal bursting with a lesion or with a stimulation, the system restores the balance and the neuropathic pain improves. In fact, it has been further explored with focus ultrasound after this 2009 study. This is a small randomized control study by the Virginia group. I think it's 10 patients only, but unfortunately it was negative. Neither patients in the sham arm nor patients in the active treatment group improved neuropathic pain. This doesn't mean that this is not good indications. This study is small. We have to take the negative results with caution. And I believe that we have to keep exploring this indication. But by large, the main indication for essential tremor, for focus ultrasound is essential tremor. These are relatively typical patient, a BK symmetrical, but this patient has essential tremor. And the first milestone in the field was this paper that you all know, that Professor Chang has already shown, in which they treated in a randomized controlled double-blinded manner a group of patients with real active unilateral thalamotomy and a group of patients with a sham procedure. And as expected, there was an improvement in the real treated patient 3 months after the treatment, which keep sustained for 12 months. And in my opinion, even more important, it's not only tremor that improves, it's this tremor-related disability, because I believe that we are not treating tremor. What we are treating, from the patient's perspective, is the disability related to tremor. If a patient does not have disability, in my view, is not a good candidate for even a minimally but an invasive treatment such as this. So we have a good outcome in terms of patient satisfaction is the outcome that leads the patient to a normal life with a complete functionality in daily life activities. And why are we targeting the VIM, the thalamus, to treat essential tremor? Because the pathways involved in essential tremor pathogenesis are mainly 2, or at least we know 2 of them. One is in this scheme, the Guillen-Moyaret triangle that goes from the dentite nucleus of the cerebellum to the red nucleus, It goes back here to the olive and goes back to the dentate nucleus of the cerebellum. So that would be one of the circuits involved in the genesis of essential tremor. And the other is the probably most well-known cerebello-thalamo-cortical circuit that from the cerebellum again goes through the VIM, the thalamic VIM, and projects to the cortex. So the mechanism underlying the improvement of tremor with a lesion or stimulation in the VIM is the interruption of this circuit. And many people have tried to show this with a biomarker, with a test. The first study in focus ultrasound trying to show this mechanism was by the Professor Chang's group. This is a functional MRI study with graph theory. And essentially what they show is that after, in essential tremor patients treated with unilateral thalamotomy, after thalamotomy, 3 months after thalamotomy, there was a reduction in the connectivity of motor-related areas. Also intrathalamic, as expected, because you're doing a lesion in the thalamus, and also in the connection between the substantia nigra and the GPE. Interestingly, there was also a transient, a temporary increase in global brain connectivity, which means that initially after the lesion, there is like a global reconfiguration of the network of the brain. It has been replicated, or it has been studied by others afterwards. These are 3 of the most recent studies. There are a few more, but essentially they show the same, or they try to do the same. They define a tremor-related network, and they show how it changes after the treatment. In general, what they show is that somatosensory circuit is the one that is mostly interrupted, and the change in this circuit, the change in the activity of this circuit correlates with the improvement of tremor. In the Japanese study, the last one, they proposed this diagram in which they explain that tremor, essential tremor, might be related to hyperactivity in the cerebellothalamic or hyperconnectivity in the cerebellothalamic circuit, while there's hypoconnectivity, a decrease in connectivity in cortical structures. So again, we have the cerebellothalamic circuit involved in tremor. And in fact, it has been shown more recently that impacting on the cerebellothalamic circuit is what would be underlying the improvement on tremor in this functional MRI study as well. In fact, they even show that after the treatment, in those patients who have improved the most in hand tremor, the configuration of the activity on their motor circuit of the hand is similar to that of healthy controls. This is a controlled study, and they compare the patients after the treatment. So in those patients who are good responders, the activity on this motor network is quite similar or has a trend towards the activity of healthy subjects. We can also show the impact not only with functional MRI or with activity, but also with the DTI tractography. This is one study from our group, essential tremor patients treated with unilateral thalamotomy, and what we saw is that the improvement of tremor correlates with the microstructural changes on the tract, on the cerebellothalamic tract. So this change, this functional change would be associated to a microstructural change along this pathway. This has been replicated by others, and in this study, for instance, with a 7 Tesla MRI, they show that the overlap on the cerebellothalamic tract would be more correlated to tremor improvement in essential tremor than the overlap of the VIM. That has led some groups to propose not the VIM as the target, but the cerebellothalamic tract as the direct target to treat essential tremor. However, it has been not replicated by all the groups. This is a study by the Italian group, and they did not find a correlation between the impact on the cerebellothalamic tract and improvement of tremor. What do I think, or what our group thinks? I don't think that impacting directly to the cerebellothalamic tract might be the best option, especially because, as shown in our study as well, the impact on the CTT is also related to imbalance, to a side effect of imbalance. Therefore, we have to be more careful there. I'm going to say something, and I apologize in advance because it's not very scientifically accurate, but the evidence shows that all this region, from the dorsal VIM, thalamic VIM, to the posterior subthalamic area, in all this region, there is chance of improving tremor if we impact or place an electrode there. What is the best option for an individual patient? We really don't know. Anything we do in this region improves tremor, but we don't know which is the sweet spot. Probably the sweet spot is patient related and also condition dependent. So depending on what is the cause of the tremor, there would be a specific region for a higher improvement, and so far we don't know. Okay, other tremors have been treated with focused ultrasound, dystonic tremor, X-fragile associated tremor. We have a few patients treated with X-fragile, and the outcome is good. You have to be careful with ataxia. Spinocerebellar ataxia tremor has also been treated with focused ultrasound thalamotomy. Multiple sclerosis associated tremor, we have 2 patients. Again, you have to be careful because the compensatory mechanisms of the brain of these patients is not as good as is in essential tremor, and therefore you are more likely to have permanent side effects. But the efficacy is high in these patients as well. Atypical Parkinsonism, SMA, Lewy body dementia. Again, be careful. The brain of these patients is more fragile. And in the end, why tremor of these conditions improves as well with a VIM thalamotomy? Because the cerebellothalamic circuit is again involved. Professor Chang has showed this paper, this review that I recommend you to read because it's a very thorough review on tremor, the physiopathology, and how to explore it properly with EMG, also clinically. And in the end, the CTT is always involved in, I would say, all kinds of tremor, but I mean, it's too much. Maybe I would say most kinds of tremor. And by interrupting the CTT, the cerebellothalamic tract, you can have a benefit on tremor. What about other movement disorders? Dystonia. Well, you probably know this paper by the Japanese group, by Horisawa. They produced a ventrooral thalamotomy, a nucleus which is anterior to the VIM. And they found in a series of 10 patients that there was an improvement on focal dystonia, although 3 patients were cured, but you could find an improvement of dystonia by targeting the ventrooral nucleus in this case. And why is that? Because the ventrooral is the input of the fibers that come from the pallidum, the pallidothalamic tract, is the thalamic input of those fibers. So by impacting there, you might have a pallidotomy-like effect, and the pallidum is an excellent target for hyperkinesia, for dystonia or for dyskinesia. We can also take advantage of the lessons from deep brain stimulation, and this study shows us that the sweet spot for improvement, this is the stimulation field, the sweet spot for improvement in dystonic tremor is more anterior than the sweet spot for improvement in essential tremor. The dystonic tremor improves better with impact with the stimulation of the VO, which is more anterior, and the essential tremor improves higher with the stimulation of the VIM. And in fact, it can also be found with connectivity, while the sweet spot for tremor is related to changes in more prefrontal and premotor areas, in case of dystonic tremor. In essential tremor, is more related to the cortex of the sensory motor circuit. Again, as I said, we need to understand the connection of the thalamus also to found or to understand which is the best target for a given patient. One thing that, in my opinion, is very tricky is that, okay, you can improve dystonia with a thalamic lesion, but a thalamic lesion can also induce dystonia. We have seen it with DBS, with radiofrequency lesions, and we are seeing this now with focused ultrasound lesions. What is the mechanism of that? It's not known. Some suggest that there might be an imbalance between the cerebellothalamic circuit and the motor circuit coming from the basal ganglia, and that imbalance might induce dystonia. What I can say is that we have had a few patients with dystonia after a lesion, both in the thalamus and the PTT and the STN, and it's a complication which is quite difficult to treat, and it's painful for the patients. Some of them require botulinum toxin. So I think we have to understand better why this happens and try to avoid it, because it sort of impairs the benefit that we achieve therapeutically speaking. Focal dystonia has also been approached with a PTT lesion. The PTT has also been explained by Professor Chang. This is a paper by Professor Hamora. In this paper, they treated a rare condition, at least in Europe, of X-linked dystonia Parkinsonism successfully. And it has also, the PTT has also been applied to treat cervical dystonia by the Japanese group, but there's also ongoing a trial by the Australian group. And why the PTT might be a good target for dystonia? I already explained that. The PTT is formed after the subthalamic nucleus by the conjunction, the convergence of the lenticular fasciculus and the ansa lenticularis. Both come from the pallidum. They converge in the fields of Forel and they project to the thalamus. So, as I mentioned, impacting on this projection from the pallidum to the thalamus is associated to a pallidotomy-like effect, and the pallidum is a great target for hyperkinesia. The PTT is, in fact, a classical target for PD as well. It was used in the early days of focused ultrasound 70 years ago, and there is some experience with the PTT, some published experience with the PTT in Parkinson's disease. It was, well, the first experiences were by the Swiss group, the first formal experiences. And currently there is a trial ongoing of bilateral paleothalamic tractotomy to treat Parkinson's disease that will probably publish this year. We have started talking about Parkinson's disease, and I want to go back to the thalamus. You all know this study that was the pivotal or the randomized controlled study of thalamotomy to treat tremor-dominant Parkinson's disease. It showed an improvement of more than 60% in the patients who were treated, and other groups have shown that the effect of thalamotomy is sustained. There is a benefit on tremor which is sustained for at least 12 months. That is a paper from the Japanese. However, in the community, in the field, there is a growing concern is that thalamotomies are associated to a high rate of relapse in PD. In fact, you can see in this paper by the Australian group that they treated patients with a thalamotomy, essential tremor patients, dystonic tremor patients, and Parkinson's disease patients. And all improve, and the effect is improved, except those with Parkinson's disease. So they had higher rate of relapses in the Parkinson's disease patients. Why is that? Some have suggested that it might be related, and this is what I personally believe, it might be related to targeting. In this paper, they show that the higher improvement in PD tremor-dominant patients is related to lesions extending anteriorly to the ventrooral nucleus of the thalamus. And why is that? Because that is the projection of the PTT, that is a pallidothalamic projection, and therefore the pallidum, which is a good target for Parkinson's disease, would have higher effect than only targeting the VIM, while the VIM is a better target for essential tremor. So in the end, it's a matter of targeting. It's not that the thalamus is not a good target for PD tremor, it's that we have to target differently than we do with essential tremor patients. We ourselves have had a higher number of relapses in thalamotomy for PD. These are our data, which is not published. 50% of our patients treated with a thalamotomy had at least a partial relapse, and we analyzed the topography of those lesions. What we saw is that the responders, those patients who had responded better, who had not relapsed, had lesions located more ventrally. Those lesions were not impacting the VIM itself, but were impacting, on the one hand, the zona incerta, and on the other, the dorsal part of the STN. Therefore, there were no real thalamotomies, or at least there were no VIM thalamotomies. So again, in the end, it's a matter of targeting. But these two studies show here, the published one and our data are different, right? Because one talks about the ventrooral, and we're talking about the subthalamic nucleus. Well, why is that? It has been a proposition of the pathogenesis of Parkinsonian tremor since long ago, 15 years ago, and it shows that there might be two mechanisms or two circuits involved in the pathogenesis of essential tremor. One is, again, the cerebellothalamic tract. The CTT would driven amplitude and maintenance of Parkinsonian tremor. On the other hand, we have the motor basal ganglia circuit, which is sort of the trigger of the tremor. I mean, the origin to say so, of the tremor would be in the motor circuit of the basal ganglia. The maintenance and manifestation of the tremor, the amplitude of the tremor, is mediated by the CTT. Therefore, only impacting on the CTT through a VIM thalamotomy would not be enough to treat Parkinsonian tremor. This is a study that we recently published, and we extend this proposition of the pathogenesis of PD tremor. The dopaminergic denervation in the motor basal ganglia circuit would lead to some imbalance in the connections between the STN and the globus pallidus externum. And this imbalance would not be mediated by the CTT, but is mediated by the basal ganglia motor circuit. So in the end, it seems that by only impacting the cerebellothalamic tract would not be enough to treat tremor, because PD tremor is more complex than essential tremor. So we need to approach it differently to try to impact on both circuits. In fact, we compare our results of the STN patients treated versus the VIM patients treated for PD. And what we have, this is a collaborative study of our center together with Kiel, the center of Gunther Deutschel. And what we saw is that, well, in the two cases, in the STN patients, treated patients and the VIM treated patients, there is a significant improvement of tremor after 4 months. At 12 months, the effect remains significant, but there is a significant difference between the STN and the VIM treated patients. The STN would be superior to the VIM to improve Parkinsonian tremor. In fact, if we look at the responders, we can see that by 12 months, 50% of patients treated on the STN, on the subthalamic nucleus, are full responders, almost 50%, while only 8% in the VIM. And if we see the insufficient responders or non-responders, almost 50% of those, of the VIM-treated patients are insufficient responders. So again, I want to stress that it is not that the VIM is not a good nucleus for tremor, it's that we have to do it differently. And there would be patients who would be good tremor-dominant PD patients who would be excellent candidates for PD tremor, for VIM thalamotomy, and better candidates for VIM thalamotomy than for STN thalamotomy. But we have to know which ones are the best ones and to know how to do it better. Why? Because it has not been mentioned so far, but I showed that we treat patients on the subthalamic nucleus. And why do we do that? First, because the STN is related, I'm talking about Parkinson's disease. The STN has a key role, a pivotal role in the pathogenesis on PD. The hyperactivity of the STN is mediating part of the clinical presentation of PD, the hyperactivity in the basal ganglia. Second, because the STN is visible. You can see it on the MRI and it's easy to target with focused ultrasound. And third, because both for DBS and for radiofrequency lesions, it has been shown to be an effective target to treat Parkinsonism. In fact, it's the worldwide preferred target for deep brain stimulation, the subthalamic nucleus, without a doubt. So, for this reason, we started our path of developing focused ultrasound subthalamotomy. We started with an open-label study of 10 patients in 2018 or 17, and we continue with a randomized control trial. We're going to see here a video of one of the patients that we treated. This unilateral treatment, we tend to treat very asymmetrical patients. This patient is not as asymmetrical as those that we treat, but she's still asymmetrical. She did not tolerate dopaminergic drugs because of ICD. She developed xylotipia, very severe ICD, and she was reluctant to undergo deep brain stimulation, so we performed focused ultrasound on the most affected side, and 2 years afterwards on the other side because it progressed. And this is the patient 3 years after the first lesion, 1 year after the second lesion. This is off medication. This patient has a very good result. UPDRS of, I think it was 9 or 10, off medication after 9 years of disease. She's part of a clinical trial that we conducted with 6 patients treated bilaterally in a staged manner, but this is not an approved indication. You can only do that in Europe. You can do subthalamotomies, but unilateral. To do bilateral subthalamotomies, it has to be done in an experimental setting. Out of the 6 patients treated, 3 are like her. I mean, they're good effect, but be careful with bilaterality because, as Professor Chang has mentioned, it's associated to higher rate of side effects. So again, we have to understand better how to do both the first and the second, not only the second, but also the first lesion. As I was mentioning, we performed this randomized control trial. This patient was part of this as well. I mean, she was included in the randomized and then in the bilateral trial. And of course, active treatment was superior to a sham procedure to improve Parkinsonism. Very important, it did not only improve tremor, but it improved also bradykinesia and rigidity. A thalamic lesion can improve rigidity as well. It has been described. We have seen it in our patients, but it's not a good target to improve bradykinesia. Even though the improvement in bradykinesia is relatively low, only 33%, but it is in line with what happens with deep brain stimulation. The sign that improved the least is bradykinesia, but we wanted to improve that. We wanted to know why bradykinesia improved less. So, gathering all the evidence that we have, that we had with over 200 treated patients, we made this analysis that has been published recently, and we saw that the sweet spots of improvement for bradykinesia, tremor, and rigidity were not exactly located at the same place within the motor STN. This has also been shown with deep brain stimulation. The sweet spot for improvement of bradykinesia is more anteromedial, always within the motor STN, right? The sweet spot for tremor is more posterolateral, and the sweet spot for rigidity will lie in between. So that helps us to first individualize patients, treatment to a patient, depending on whether rigidity is more severe or bradykinesia is more severe than tremor. And second, to have a strategy when we treat the STN. We have defined a sort of a strategy going first from the bradykinesia area, more anterior, and afterwards we move posterior to the posterolateral region of the motor STN in order to improve tremor. We also do a lesion dorsally, trying to impact on the PTT for one reason, because STN lesions can be associated to dyskinesia. In our experience, that is not a major problem. We can manage, usually they are mild to moderate, and they can be easily managed and vanish over the weeks, but you always have to try to impact there to avoid hemivalism. I want to give just a few words about the safety of the STN, because we were quite criticized on the randomized trial, because the rate of side effect was high, as it is in general in focused ultrasound, but as it is in general with focused ultrasound, most of them were mild or transient. If you look carefully at the paper, you see that after 12 months, only 13% of patients have neurological complications from the STN lesion, which is equivalent to the VIM or the GPI. The STN is more complex. We have to acknowledge that. You need experience to treat the STN. Most of you have high experience, so you could do that. But it theoretically would not be, if it's well done, would not be associated to higher rate of side effects, of permanent side effects. We are happy to see that we have formed a sort of school in Spain of STN lesioning, because these are recent publications by the Pamplona group, Valencia group, and also a group from Japan, that they have shown their positive experience in treating patients with the STN. So, my summary statements are that the thalamus is a complex structure, you have seen it. But thalamic ablation is effective. It requires refinement for some indications like PD, but is effective for tremor and other movement disorders. The mechanism is the change in an abnormal condition-related nerve work after the lesion, and we can consider other targets depending on the patient and depending on the condition. Thank you very much to my team, of course, and also to the organizers for their kind invitation.
Thank you, Dr. Fernandez. I'm honored to invite Dr. Madheshwaran, Dr. Aral Selvan, Dr. Vijayan to felicitate Dr. Fernandez with a memento.
Thank you, Dr. Fernandez, for your enlightening and thought-provoking keynote address. Your expertise and groundbreaking contribution to the neurology and movement disorder have been truly inspiring. We sincerely appreciate your time and valuable insights. Let's give him another round of applause.
Moving to the next session, it is our privilege to welcome a highly esteemed expert in radiology, Dr. Deepak Patkar, past chairman of Indian College of Radiology and Imaging, to present on fascinating topic of radioanatomy of basal ganglia. With over 35 years of experience, Dr. Deepak Patkar has made remarkable contributions to the field of radiology. Beyond his clinical practice, he is committed to patient education and holistic care, ensuring the best outcomes to his patients. We are honored to have him with us today to share his knowledge. Please join me in welcoming Dr. Deepak Patkar.
Thank you, madam, for the kind introduction. In next 20 minutes, we'll look at the imaging anatomy and its relevance in Parkinson and other Parkinson-related disorders. Before I do that, I must acknowledge his contribution to this talk from my colleagues in the department and everybody from Focused Ultrasound Association of India for having me here, especially Srinivas. What we'll do in next 20 minutes is try and introduce the concept of radioanatomy of basal ganglia and midbrain and how they are interconnected and how we can demonstrate that on MR. The changes that happen in basal ganglia and in midbrain in movement disorders, there are different types. The current imaging and reporting protocol that is followed across the world in terms of classic Parkinson disease, atypical Parkinsonian disorders, amyotrophic lateral sclerosis, what is happening currently and in future as far as the imaging is concerned in Parkinson-related disorders, and then summarize my talk. A little bit about history and evolution of how Parkinson has moved. 2 centuries ago, James Parkinson wrote an essay on shaking palsy, described a handful of patients who showed tremors at rest and bradykinesia. About 20 years later, it was called as Parkinson's disease. There are several milestones and changes that have happened in terms of management and understanding the Parkinson's disease. The major ones from radiological point of view are: 1, deep brain stimulus coming in about 1995, and the focused ultrasound getting FDA approval in 2021. And that's where the whole imaging changed. So in imaging, we have now moved completely from no role of imaging in Parkinson and Parkinson-related disorders to imaging being critical in management of movement disorders. And Dr. Senthil before me showed a lot about it. It not only has a tremendous role in detecting and localizing the lesions, but it is also useful in prognostication, guiding interventions, and follow-ups in cases with Parkinson and Parkinson-related disorders. If you see the current American College of Radiology appropriateness criteria guidelines, MR without IV contrast is the most important investigation in patients with Parkinson-related disorders. With DBS happening MR guided, things moved quite dramatically in last decade or so. We know that there are progressive movement disorders are broadly divided into voluntary and involuntary movements, and there are several other non-motor manifestations which include depression, memory loss, sleep disturbances, and autonomic and genitourinary dysfunctions, which cause a lot of mental damage to the patients. What we are going to look at is Parkinson's disease, atypical Parkinsonian disorders, secondary Parkinsonism, AML a little bit, and NBAI. Hyperkinetic disorders we are not going to talk about. If you see, Parkinson is the second most prevalent neurodegenerative disorder after Alzheimer's, and neuroimaging in early stages can differentiate PD from PD mimics, and that's what I'm going to show you in next few slides. The causes all of us know: aging, genetic mutation, and environmental factors which lead to Parkinson. What we look for on imaging is what happens in Parkinson. The loss of dopaminergic neurons which project from substantia nigra to putamen and caudate nuclei, these projections get reduced and puttamina get affected earlier. So the changes that we look for are the swallowtail signs and changes in puttamina and globus pallidi. Typically, about 40 to 60% neurons, dopaminergic neurons, have to get lost before patient gets symptomatic. And then on high resolution MRI, it is very easy to detect and diagnose these changes. The role of imaging is to help exclude the mimics like subdural hematomas or other mimics of Parkinson, characterize each patient into a specific subcategory, Parkinson and Parkinson plus syndromes, also to monitor the disease progression and to guide the interventions like DBS implantation and ultrasound guided therapies. The basic imaging protocol includes a simple axial T1, T2 and a 3D Bravo or SPGR, which is a 3D sequence, 1 millimeter thin sequence, which gives anatomic and volumetric details of the brain and the relevant areas. SWAN is called as the sequence in Parkinson, and typically we do 0.8 to 1 millimeter thin sequence, a 3D sequence, to look at the midbrain and basal ganglia. A lot of researchers also use, and we saw examples of these, DTI to look at detection of nigrostriatal structural disruption by looking at FA values in this region. Arterial spin labeling, which is like a perfusion in that particular portion of brain, and sagittal T2 or CSF flow analysis if there are Parkinson plus syndromes like NPH. What we as radiologists and you as neurosurgeons should know for looking at changes on MRI in Parkinson-related disorders. The sign which we use today is called as swallowtail sign. Then we look at midbrain contour. We look at midbrain anteroposterior diameter, midbrain to pons ratio, which is called as MR Parkinson Index, MRPI. And there's a new version which has come up 4 years back, which is called as MRPI version 2. We'll try and understand this in details. Let's start with classic Parkinson disease and its MR manifestations. So what we look for is progressive degeneration of dopaminergic neurons in substantia nigra. And that's what the sign is all about. The classic sign of classic Parkinson is loss of swallowtail. There are two tails of this bird, which is called as swallow, and this gets phased out as the Parkinson progresses. This happens because of loss of the central nigral hyperintensity, which happens because of iron deposition associated with dopaminergic neuronal loss. Asymmetry in nigrosomal involvement is almost always correlated with MR finding of asymmetric deposition of iron on one side of swallowtail. There are several studies which have happened, and the meta-analysis of these studies talks about specificity and sensitivity of almost 95% using a HWI sequence on 3T MRI. So that's the power of MRI. MR divides swallowtail signs into 4 subcategories. Definitely normal is where you can see both the tails of the bird surrounding the normal hyperintensity. As you get deposition of iron in this area, you start getting a little bit of blurring of the tail, which is called as probably normal. Then you have probably abnormal, where the tail is getting almost completely disappeared and becoming a single tail. And definitely abnormal, the 4th category, is where you don't see any difference between the 2 parts of tail. With strength of MRI getting stronger and stronger, this is a borrowed image on a 7 Tesla magnet. This tail gets more organized and better delineated. And as patient starts getting Parkinson, this white area between the 2 parts of tail starts getting darker, and then it gets merged into one. If you see the normal healthy control versus PD, see the sharpness of 2 tails, which has got completely disappeared. Same thing happens in PSP and MSAP, and there's overall thinning of the tail in MSAP. Moving on to atypical types of Parkinson's or Parkinson plus syndromes, you have 3 or 4 subcategories: MSA, C and P, progressive supranuclear palsy, and cortico-basal degeneration. In MSAP, there is putaminal involvement, and in MSAC, there is cerebellar and brainstem involvement, and we'll see how radiologically they are different. What we look for in MSA type C is what is called as hot cross bun sign, pontine atrophy, and reduced FDG uptake in the cerebellum. So if you see these two patients, pons is markedly atrophic. Again, the same two patients, advanced MSA-C and not so advanced MSA-C. If you see hot cross bun here, marked atrophy of pons, the contour is lost, and there's a lot of cerebellar atrophy. Here, you can barely see the hot cross bun. Atrophy is not so much. Cerebellar atrophy has advanced more in this particular patient. In MSA type P, you have what is called as peripheral slit sign, where you get hypointensity in putamen compared to the rest of the basal ganglia and red nuclei. There is disproportionate atrophy of the putamen, and on gradient echo images, you get what is called as slit sign, and I'll show you example of that. On FDG PET, there is reduced uptake in the entire basal ganglia. So this is an example of peripheral slit sign. At the periphery of pons, you get hyperintensity on T2 and gradient echo images, and this is what is called as hypointensity on gradient echo and T2 images compared to the globus pallidi and red nuclei. Also, there is marked atrophy of putamen in this particular patient. Compared to these two entities, progressive supranuclear palsy is more accurately diagnosed on MR, and there are several features of PSP which we look for. On your left hand side, you have normal patient, and on your right hand side, you have patient with PSP. If you look at the profile of midbrain in this patient, you get what is called as hummingbird sign. The tip or face of the bird is pointing upwards. Here it is pointing in front, and there is marked atrophy of the midbrain. Based on that, there are certain ratios which we look for. So this is a person with normal midbrain and pons ratio, and this is person with relatively maintained pons but marked atrophy of midbrain. The other sign that we look for is what is called as morning glory sign, that happens because of atrophy of the dorsal portion of midbrain with prominence of ambient and perimesencephalic cisterns. There are certain important measurements in PSP that we do manually, and a lot of now new apps have come which do it on AI-based models. So if the ratio is more than 0.24, that means 24% should be the size of midbrain compared to pons. That is considered normal. In this particular patient, it is 18%. So anything less than 24 is considered as abnormal and suggestive of PSP. Then you measure the middle cerebellar peduncle diameter, the maximum middle cerebellar peduncle diameter, and maximum superior cerebellar peduncle diameter. Also, you measure the anteroposterior diameter of midbrain in its center passing through the cerebral aqueduct. It should be more than 12. In this particular patient, it is 13.7. In patients with PSP, it drops to under 10. Putting all these measurements together, you get a ratio where what you do is you do pons upon midbrain ratio and multiply that by middle cerebellar peduncle upon superior cerebellar peduncle ratio, and normally it should be less than 13.55. If it is more, it is considered as abnormal. The basic concept is pons remains large and midbrain undergoes atrophy. With that, superior cerebellar peduncle undergoes atrophy and middle cerebellar peduncle maintains its diameter. There's a new version which has come up in 2018, which talks about the second version of MRPI, where in addition to calculating the MRPI that we saw, you add and multiply the third ventricular width at its maximum level and frontal horn width at its maximum level. So you multiply the MRPI by third ventricular width upon frontal horn width, and if this ratio is more than 2.18, it is considered as normal. If it is less than that, it is considered as diagnostic of PSP variants. There's a new paper which has come up in 2022, 4 years after MRPI 2 came in, which talks about it being less beneficial in certain group of patients, the MSA-P and PSP-P types, and hence a lot of people have now reverted back to version 1 of MRPI. Moving on to the next entity that is called as cortico-basal degeneration. What we look for on imaging is asymmetrical frontoparietal atrophy and atrophy of basal ganglia, especially the caudate nuclei. If you see here, there's a lot of atrophy on the right side, left side being relatively spared. AI has come up in the last 3 or 4 years, and which has really helped us in measuring these diameters and volumes that we look for. For an experienced radiologist, it takes up to 15-20 minutes to actually draw and make sure that what we are drawing is correct. With AI, that happens in a matter of few seconds. We just need to confirm what has been drawn by the AI apps is proper or not. And we are using it for the last 3 to 4 years, and we have found them fairly accurate. That really reduces your reporting time and probably makes it more accurate, especially at the end of the day. So how we report patients with Parkinson plus syndromes. So we talk about the routine findings. We talk about if there are any signs that I showed are present or not. Then put all the ratios in a table format, so it becomes easy for neurologist and neurosurgeon to make out what we are talking about. Put the normal ratios and put the given patient's ratios, and then put it in the impression together to give a comprehensive report along with a picture which is given on a colored page. There are certain new MR techniques which are coming up and which will probably take over what we learned just now in next 4 to 5 years. The most promising amongst them is neuromelanin sensitive MRI. It's a heavily T1 weighted sequence which looks at the degeneration of the neurosynaptics at the midbrain and hypothalamic level, and how this is healthy individual. This is patients with PD, PSP and MSA, and how the iron gets deposited and the T1 brightness disappears using this neuromelanin sensitive sequence. Another sequence that is coming up is quantitative iron mapping. The sequence is same, it's the HWI sequence, but the echo that we use is almost 0 degrees. And looking at that, you can actually generate from the phase and magnitude data of the HWI sequence to objectively quantify the iron deposition in the midbrain and basal ganglia as the patient's age. It also shows iron deposition in the cerebellum. This is healthy individual and this is person with Parkinson. Both these slides are borrowed. ASL is also coming up in a big way to look at the functional part of PD. So if you see reduced perfusion in the parieto-occipital cortex and basal ganglia and conserved sensory motor areas, then you have PD. If the sensory motor areas are not conserved, you are probably dealing with PD with dementia. DTI, we saw some pictures in the previous talk, also talks about how you can differentiate pure PD from PD with MCI, where there's a reduction in FA values, not only in the substantia nigra, but also in the diffuse white matter areas. So predicting what you're dealing with in addition to Parkinson will get easier over next few years. A little bit about role of nuclear medicine. It's a different topic altogether, but what I would like to sort of put across is imaging pattern of striatal involvement in all stressors is similar in PD. This is a borrowed image which talks about how PD, MSA, PSP, and CBD have different types of reduction in uptake in different patients. To sort of summarize the nuclear medicine, in PD, you get decreased asymmetric activity in rostrocaudal gradient, typically starting with caudal putamen, then ventral putamen, and then caudate nucleus. In MSA, there is decreased activity in the ventral and caudal putamen together. In PSP, there is decreased activity involving entire basal ganglia simultaneously. And in CBS, there is asymmetric involvement of putamen, the affected side getting involved and unaffected side not getting involved. So to conclude, establishing the correct diagnosis of movement disorder can be extremely difficult because of the variable and complex features of these conditions. A combination of imaging technique is often needed for complete evaluation of the patient and to help establish most likely diagnosis. One hand, you have structural imaging. On the other hand, you have functional imaging. On structural imaging, you have to look at patterns of atrophy, parenchymal abnormalities, abnormal substance deposition, we're talking about iron here, and exclude alternative diagnosis. On functional side, you have DTI, MTR, functional volumetric segmentation techniques, and neuronavigation, which open new avenues in evaluation of microstructural changes that happen in Parkinson-related conditions. So to conclude, clinical history along with radiological features are very important to classify Parkinson and Parkinson-related disorders. MRI is clearly the choice of modality. Ratios and measurements are essential to determine various Parkinson plus syndromes. AI would revolutionize the way we look at these patients' details, and newer techniques such as DOTA-PET are the tools which will solidify the diagnosis. This is my last slide, and I thank you for your attention.
Thank you, Dr. Patkar. I request Dr. Raguraj Prakash, Dr. Sendil Kumar to felicitate the speaker with a moment. Now the session is open for Q&A.
I'm the odd man out, so I think the questions, I'm amongst neurosurgeons and neurologists, so I don't think I'll have too many questions, but I'll be happy to answer if there are any. If they were radiologists, there would be many questions.
It's okay, sir. Sir, in the early stages of PSP, is there any way that we can differentiate, finding some trouble in very early stages of PSP? Is there some way that we can, by imaging alone, of course including DOPA-PET, FDG, and MRI, is there any way to diagnose?
Very early PSP is extremely difficult. Actually, my father suffered from PSP and it was diagnosed almost 2 years later. We thought it was post-stroke Parkinson and got treated 2 years for that. Of course, he passed away in 2.5, 3 years. It can be extremely challenging. So most of the times, unless there is 80-90% affection and the atrophy sets in, it's extremely difficult. People used to not image these patients with Parkinson or Parkinson plus. Now with the new science coming in, things have become easier. The MRPA index that I showed you. DOTA-PET probably would have, as things get more refined now, would be probably able to detect and at least suggest the diagnosis of PSP in an easier or earlier way.
Regarding the split putamen sign that you told us.
Yeah.
Now, what is this exactly?
So there is deposition of iron in putamen in MSAP type. You get putamina getting affected. So they shrink in size And at the periphery, so there is iron deposition in the entire putamen. Then glasses sets in. So glasses sets in the center and periphery remains dark. So what we see as split putamen sign is center is gliosis, which is bright on T2, and the periphery is, it's kind of staining of these glasses by iron. And of course the atrophy.
Hello, thank you for your talk.
Hello.
I'm a neurologist, so I deal with this kind of patients.
Every day.
So my question is, there have been papers showing that DTI values can be used to differentiate between these conditions since 15 years, but still it is not formally implemented in the diagnosis of these conditions, or at least we don't use it. I mean, regularly we perform MRI, of course, but we don't calculate DTI values to see whether it's PSP or generally speaking. So why do you think this happens?
Right. So I'll tell you the problem of DTI. Most of these patients are unable to lie down in the machine for a long time. The DTI that we typically do is 36 directions or 32 directions. Most of the machines are capable of doing DTI up to 256, even 512. Some machines have, on 5 Tesla and 7 Tesla, you have 1,000 plus directions. The time taken for DTI for one sequence can vary from 4 minutes to 16 minutes. And typically radiologists at a busy commercial center would choose to do the 4-minute sequence instead of doing 16, 18 minutes sequence. Other problem with that sequence is patient being not able to move for those 16 minutes can be quite challenging. So if done well, and if you look at the FA values very accurately, and if you have normal controls, then DTI could be a very good tool.
Okay, so if you could overcome these practicalities, then you think that it would be a good tool.
Yes.
Okay, thank you.
Thank you. Thank you.
Thank you very much, Dr. Patkar, for your insightful and informative session on the radio anatomy of basal ganglia. Your expertise and valuable perspectives have truly enriched our understanding of this complex topic.
சுடர்விட்டு கிடக்கும் சிந்தனை, சொற்களில் சிக்காமல் செல்லும் தூண்வழி, பூக்கடைக்கு விளம்பரம் தேவையா, புதிராய் விளங்கும் இவரது விடைகள், சிரிக்கும் கண்கள், செருக்கும் வார்த்தை, கண்மணி போல பிரகாசிக்கும், அழியாத அறிவின் அசைவுகள், அறிவார் தமக்கே அரிய பொக்கிஷம். இவரது பரந்த அனுபவம் நோயாளிகளின் நலனுக்காக இவரது ஆழ்ந்த அர்ப்பணிப்புடன் இணைந்து இவரை நரம்பியல் துறையில் முக்கிய நபராக நிலைநிறுத்தியுள்ளது. டாக்டர் கிருஷ்ணன் விஜயன் அவர்களை ஒரு பெரிய கைத்தட்டுடன் வரவேற்பதில் பெருமகிழ்ச்சி கொள்கிறோம்.
It is my utmost pleasure to introduce to you a remarkable individual whose expertise, leadership, and commitment to excellence have made a lasting field of medicine. He is the one, super one. I would like to add a little bit of cinematic touch for his arrival. There is a majestic dialogue which states, Madhurada engalukku adayalum, Maduraike naanga da adayalum. Parallelly, Coimbatore da ivaroda adayalum, Coimbatore ivarda adayalum. And he is our one and only Dr. Krishnan Vijayan.
Thank you. Thank you for those nice words. Please believe me, I did not write those. This is the first team in India that did the first focused ultrasound treatment for Parkinson's, for essential tremor. And the center is our professor, Professor K. Srinivasan, who guided us through 2 treatment sessions on 8/8/2022 and 9/8/2022. That was when we started focused ultrasound lesioning for essential tremor, and the second patient was Professor's patient, a case of tremor-dominant Parkinson's disease. And this is how the lesion is made. You can make multiple small lesions or one large lesions. There was some discussion on lesion volume and what is the adequate lesion volume, and there was some discussion also on minimizing lesion volumes in Parkinson's disease and in essential tremor, so that you can minimize the side effects at the same time, get adequate benefits out of these procedures. Without much ado, this has been discussed already, so I'll skip these images. But I want to show you that the ultrasound penetrates. This is a 360-degree view from all angles, and this is the importance of the incident angle and the skull shape and size. And this is how the ultrasound waves penetrate and hit the target exactly with sub-millimeter precision. This is for the people who are not initiated to focused ultrasound in the auditorium here. And this is again in the coronal view, how the ultrasound waves penetrate and hit the target with sub-millimeter precision. Now, this was all discussed already. I'm not going to go through all this, but I would like to tell you certain things, that we don't just do thermal ablation. Though we measure temperatures, we measure the CEM, cumulative equivalent minutes, on an MR thermography. It is not just thermal ablation. There is some effect of cavitation also. Brain is 80% water and less than 20% matter. So, when ultrasound passes through water-filled bodies, it generates gaseous bubbles. These gaseous bubbles, they are created, they collapse, they created, collapse, and they sometimes join together and produce shock waves. So there is a mechanistic damage also occurring here. Apart from a thermal damage, there is a mechanistic damage also. And more than that, there is something called as neuromodulation. There is a neuromodulating effect also, not only at the level of the lesion, but in the surrounding structures, which also gives the benefit. So it is thermal, it is mechanical, and there is some neuromodulation also in creating the lesion. Now, this is how we make calculations. We make various calculations, but as the topic says, it is not just science, it's more than science, it's also an art in targeting the brain. As the chairman is very fond of telling, it is not you who decide the lesion, the final lesion is decided by the patient, because he guides you to the final lesion, because we keep on making clinical examinations now and then. Not only clinical examinations, we look for improvement, we also look for side effects of the lesions. Now, based on the knowledge of our anatomy, so we move the targets in X, Y, Z directions differently. Suppose the patient complains of weakness, we move the target a little more medially. If the patient complains of burning pain or numbness in the cheek, we move the target a little more anteriorly. If it is for focal dystonia, we move it more and more anteriorly. And if it is abdominal tremor or jaw tremor that is not coming under control, we have moved it a little more medially also to get the lesion. So it is more an art than just science. Though we've seen medicine itself is more of an art than science. And when we make these targets, this is how we plan the PTT. A lot of discussion on pallidothalamic tract. Now that is a final common outflow from the globus pallidus interna. The globus pallidus interna itself, you can't make a single lesion, because multiple areas from the globus pallidus interna, the fibers emerge, course into the thalamus through the H2, H and the H1 fields of Furrell. Now, these areas to target, it is better to target a white matter area rather than a gray matter. So here, the pallidothalamic, we had some wonderful results with pallidothalamic tract lesioning, and we make two lesions in the pallidothalamic tract, both a medial lesion and a lateral lesion, because technically it streams dorsally and laterally, that is superiorly and laterally, and then it goes into the thalamus. And this is how I'll show you some of the lesions which we make. Now, this is how we make the lesions initially. This is the MR thermography, which shows that there is a target here, and the MR thermography shows you where the lesion is made, where the lesion will be made. And then we go out to the next phase where we increase the temperature slightly. The patient develops the improvement in the symptoms, and also at the same time he complains of side effects also. At least we had two patients who were complaining of severe burning in the back. Then that means we've gone somatotopically, we've gone a little more posteriorly. And there, in this case, we go slightly anteriorly, 1 millimeter, 2 millimeter anteriorly. Again, go back to the alignment phase. Again, go back to the verification phase. So sometimes it takes a long time to fix the lesion in the VIM. The VIM is not a location. One, we should understand that VIM is not a location, but it is a volume. So you have a large area to be targeted. So you make multiple small lesions across where you think actually the VIM is. And again, depending upon the clinical symptomatology of the patient, again, we change the targets. If the patient has a drug-resistant tremor, a severe tremor, then we make always 2 lesions. We make one in the VIM, multiple small lesions in the VIM, and of course nowadays we are also including the posterior subthalamic area, which is somewhere near what we call the zona incerta. So this post-2 lesions, we are always making dual lesions nowadays. If it is a drug-resistant tremor or a very severe tremor, we not satisfied only with the VIM, but we also make a posterior subthalamic area lesioning. And we found out of late with small experience that it's not causing any major side effects, but for a mild ataxia, which all improve in 2 days to 2 weeks. Maximum is 3 months. And we've not had any single case telling that the ataxia is persistent beyond 3 months. We've been following up all these cases regularly, and most of them, the minor side effects resolve over a period of 3 months. Very, very rarely only when we go very posteriorly in the VIM, we've seen numbness persisting in the chin, in the buccal area, sometimes in the hand also, the numbness persisting beyond 3 months. This is how, and we follow this Hasler's calcification, and this is how the brain is represented somatotopically. The homunculi are represented, and we've found some usefulness with this representation, with this topographical representation of the homunculus in the thalamus. Yes, of course, we've had a few cases of abdominal tremor. I'll show you some videos of abdominal tremor. This is a case of young onset PD with cervical dystonia. This was LRRK2 mutation positive, treated with MRGFUS. She and a sister, she's the elder one, she had severe cervical dystonia associated with tremors. The sister had only tremors. So genotypically same, phenotypically different. Now, this is the severe cervical dystonia she had. Of course, responded to medication not adequately, very high, always the head tilted to the right side. So we chose to ablate the GPI and the medial PTT. Now, when I say, I'll show you how we target the medial PTT. And nowadays, for most of the Parkinson's disease, we start with medial PTT, go to the lateral PTT, grow the lesion dorsally. If we are satisfied, we stop there, or else we come a little more in the dorsally in the thalamus. We also make a VIM vivo lesion. We don't just make a VIM lesion, we make a VIM vivo lesion, the region straddling both the VIM nucleus and the ventralis oralis posterior. And this is how it was marked. This is in the coronal, and that's the optic tract. It's very close to the lesion there, you can see. We did a lot of sonications, but we couldn't get a thermal lesion there, or at least we couldn't see the thermal lesion. So what we did was we chose the medial palatothalamic tract also. We lesioned it, and 2 lesions were made. This is what I call the Nehru technique, where we, in cervical dystonia, very difficult for us to examine the patient. In tremor, you can examine the patient, you can make the patient write, you can make the patient draw. We have had singers whom we have made the patient sing during the procedure. Now, in this case, we have to palpate the cervical muscles to see how taut they are or how loosened they get. This name I borrowed from the Malayalam movie Nehru, which sees touch and feel. Basically, it's touch and feel. And so we keep touching, close our eyes, and touch the patient's neck and feel for the tautness. All of us do it. And this is the post procedure. We were successful in getting a GPI lesion, and we were also successful in getting a medial palatothalamic tract lesion. And this is the post procedure, and she's improved remarkably in the post procedure. And no further, this is off drugs, totally off drugs. Of course, she is requiring medication even now, but very little as compared to what she was taking previously. And this is post procedure. 1 month later. Almost normal, no cervical dystonia. Of course, she's on medication. Most of these patients have to be on medication. We don't cure the disease, we only treat the symptoms. There is no more pulling, cervical dystonia totally gone. We had a recent patient with only purely cervical dystonia. Again, the target was GPI and medial PTT, and he has done very well. And these are the Forel's fields, the the H2, H and H1 fields of Forel. And this is how we select the plane. We sit together, select the plane. We take the inferior most plane. And this is how we mark the AC and the PC. This is how we mark the thermal boundaries for the internal capsule. This is, we mark the mammillothalamic tract. We mark the STN. And then we mark the lateral target for the PTT, 6.5 millimeter to 8.5 millimeter from the lateral border of the third ventricle. We respect this distance more than this distance. This distance, this is the internal capsule. We keep it 2 to 1.5 millimeter away from the internal capsule, but this distance we respect most. This is the mammillothalamic tract. Here we at least have 3 to 4 millimeter difference. The minimum is 3 millimeter difference between this. Once we have targeted this, it is 1.5 millimeter inferior, 1.5 millimeter posterior, and 1.5 millimeter medial. You get the medial PTT. We mark the medial target of the PTT, and nowadays we always begin with the medial target for the PTT. We had some discussion with Raul initially regarding, and he told me inadvertently you're hitting the STN and not the PTT, and I told him inadvertently you may be hitting the PTT and not the STN. But of course, they are very close by, hardly 1 millimeter, 2 millimeter in difference. And we, of course, after the interaction with Raul in Finland, we now are also making lesions in the dorsal and the lateral part of that is a motor STN, the superior most part of the STN. Of course, we are now making lesions. We've not found out any side effects because of these lesioning. But of course, there is some ataxia that all resolves in a period of few weeks, maximum 2 weeks to 3 months. This is how we target the coordinates for Vim Vivo. Again, we mark multiple targets here. In Parkinson's disease, we tend to go more anterior. Now, because the Vim is not visualized on a 3 Tesla MRI, we have to make multiple. I told you the Vim is a volume and not a location. We make multiple targeting. We follow various things. Of course, this is a Vim line target. There is a calculation by Professor Thaira, and we have our own Royal Care targets. We have 2 Royal Care targets, RC1 and RC2. We've named them RC1 and RC2. And depending upon the patient's anatomy, it varies. Most often we found that we start off with the Royal Care target 2. In some patients, we start off with the Royal Care target 1. And based on these targets only, based on the initial response to these targets, then we proceed to make the final lesion. So it's more of an art. Again, when we make the planning, most of the time we mark the coordinates, and when I finally finished marking and I'm going to place the target, Raghu catches hold of my hands and says, "Sir, 1 millimeter inferior." Then I ask, "Why, Raghu?" He says, "I feel so." Because neurologists, we are more tuned to seeing pixels, the slices. Neurosurgeons are more tuned to see and imagine the brain as a 3D structure. So that's very important that both neurologists and neurosurgeons sit together and plan the target. So sometimes he feels so and is intuitively right. And so when we change the target slightly inferior, we get a better results. This is one abdominal tremor, very rarely reported in literature. This presented only with abdominal tremor. and of course with severe dyskinesias, L-DOPA-induced dyskinesias, and this patient also had mild tremor and rigidity in the right upper limb. So we decided to focus on the left PTT and the left Vim Vivo. This is during the procedure, and once we are done with it, the tremor is totally gone. The abdominal tremor is totally gone. In this case, again, we decided to focus a little more medially based upon the homunculus anatomy. End of the procedure, and it's totally gone. I think, to my knowledge, only a very few cases of abdominal tremor presenting as PTT has been described in literature. This case was only abdominal tremor as the first symptom of Parkinson's disease. This is a follow-up 1 month later. With this, I would like to end my talk. Thank you for the opportunity.
Thank you, Dr. Vijayan. Now it's time to honor Dr. Vijayan. I request Dr. Madheshwaran and Professor Ganeshan, retired neurologist from Tirunelveli Medical College, to felicitate the speaker with a moment.
தம்மின் தம்மக்கள் தொழிலென்க கல்வி அம்மா எனப்படுவதொன்று, which means a teacher's greatest pride is when a student's knowledge becomes their identity, just as a mother is known through her child. It is our pleasure to watch this crucial moment of Guru and his Talaimagan.
Thank you, Dr. Vijayan, for your insightful and thought-provoking speech on the
Just one
science and arts
correction.
of targeting the brain.
My professor is yet not retired. He's still 80 and he's still going strong.
Now it's open for Q&A. Thank you, sir.
Thank you, Dr. Vijayan. It's an absolute honor to welcome a distinguished expert whose work is transforming the landscape of neurological care. Dr. Kevin Tsai is a renowned neurologist from Changbingsho Chuan Memorial Hospital, Taiwan, with extensive expertise in magnetic resonance guided focused ultrasound for the treatment of essential tremor and other neurological disorders. Dr. Tsai is a respected expert in the field, and we are privileged to have him with us today to share his in-depth knowledge and insights into MR-guided focused ultrasound, a cutting-edge technology revolutioning the treatment of various neurological and psychiatric conditions. It's our pleasure to request Dr. Tsai to the stage with a big round of applause.
Thank you, Dr. Madheshwaran, sir, and Royal Care Hospital, to allow me to share with you some technical aspect of focused ultrasound. So today I changed my title a little bit. So the title of my presentation today is the low SDR treatment best practice. As so many physicians and doctors already share, SDR is one of the important key to ensure the successful treatment of focused ultrasound. Essentially, SDR related with the energy efficiency of the thermal ablation with focused ultrasound. Of course, we, just like Dr. Thinsia, sir, mentioned that the population of the SDR in India seems quite good, prefer for the focused ultrasound treatment, but in general in Asia, we tend to see a low SDR treatment here. So that's part of the reason why I would like to share this topic with you. For those who don't know me, I'm Kevin Tsai. I'm currently working in SciTech as a clinical application manager of APEC. Okay, so here's some background. So esophageal neural system integrate two key important modality. One is a high-intensity focused ultrasound together with MRI to provide a non-invasive acoustic surgery platform to treat neurologic disorder through an intact skull. So which means the focused ultrasound energy need to penetrate through the skull and arrive to the target. Physically, we know the skull absorbs the energy 50 times higher than soft tissue, as you can see the figure at the right side. When the focused ultrasound, so here is the depth of the focused ultrasound beam, and here is the related intensity of focused ultrasound. When the focused ultrasound penetrates through the skull, as you can see, the intensity dramatically reduced after he completely penetrates through the skull, and we essentially only use roughly 10% of energy to arrive the target and complete the thermal ablation. So again, over 90% of energy is lost during the skull penetration. So one of the father of SDR, Professor Jing Zhang, is sitting downstairs. So in order to measure the measurement to characterize the variability of the bone density of the skull is called SDR skull density ratio. And particularly, SDR is a ratio between the marrow bone and the inner and outer cortical bone. As you can see here, this is the equation. So to be more specific, here's the outer cortical bone, inner outer cortical bone, and this is a marrow bone or trabecular bone. So when focused ultrasound ray penetrates through the skull, reach the target, so the focused ultrasound ray will reach these three layers as mentioned here. And this figure shows the profile of the CT intensity. So the cortical bone, inner and outer cortical bone intensity in Hounsfield units will higher than trabecular bone. We calculate the SDR of each individual focused ultrasound ray. So practically on our platform, we got a single numerical number of SDR, which is come from the average SDR from 1,024 focused ultrasound element. This is the data when we submit when the InsightTech submit the data to the US FDA for the approval. This data shows the relationship between the maximum temperature required for maximum energy required to achieve the therapeutic temperature versus SDR. As you can see here in this figure, the higher the SDR, the lower the energy required to achieve the therapeutic temperature. So by that time, back to 2013, InsightTech proposed to add the exclusion criteria for the patient with the SDR lower than 0.4 in the US FDA labeling. So recently, back last year, we, based on the accumulated lesson we learned and the publication the other site published, the exclusion criteria is been reduced to 0.3 for essential tremor patient. But importantly, this exclusion criteria of SDR is still preserved as 0.4 for PDGPI treatment. So the purpose of this presentation is, first, we would like to summarize the literatures regarding the safety and efficacy of the low SDR treatment based on the fact that low SDR patient is usually being identified as a challenging case. And secondly, we would like to demonstrate the technical data comparison between the low and the high SDR treatment. And last, even though it's still not perfect, we would like to suggest the best practice of the low SDR treatment based on the accumulated lessons we learned. So I would like to start from the clinical evidence. So here is the paper published in 2020. This is the data with a patient of 189. So the idea of the key message of this publication showing that MR-guided-focused ultrasound to ET treatment can be effectively and safely performed with a patient of the SDR lower than 0.4. So as you can see here, so of course, physically we know SDR has a linear negative correlation with the energy efficiency, as you can see here. However, with the adequate treatment strategy, the low SDR treatment can be safely done, can be effectively done with a long-term follow-up, which is a 1-year follow-up after the treatment. So as you can see here, actually the efficacy between the high SDR group and low SDR group is not that different. But of course, in this paper, it also revealed that the chance, probability of the side effect in low SDR group seemingly lower than the high SDR group. This is another paper suggests that there's no significant difference in prognosis between the low and high SDR group in any follow-up time point, as you can see in this figure. So this figure shows a 1-year follow-up for the ET essential tremor treatment between SDR group, SDR lower or higher than 0.45. So in this figure, it shows that even after the 1-year follow-up, the efficacy of these two groups did not show any significant differences. And in this paper, it also shows that the SDR only correlated with the focal energy is required during the treatment. This is another paper suggests that there's no significant difference in clinical outcome and adverse effects between the high and low SDR group. As you can see here in this paper, the blue one is the low SDR group. The orange one is, the group one is the highest SDR group, and the orange one is the low SDR group. So they examined the efficacy and safety in 3 months and 12 months, and in this analysis, they did not see any statistical significance between the low SDR and high SDR group in terms of safety and efficacy. So from the aforementioned literature, we know that, okay, so low SDR patient and high SDR patient did not show a difference in terms of safety and efficacy. However, in the following 2 slides, I would like to share with the 2 publications suggesting that first, the headache and the incidence of stop sonication are related with SDR. So in this paper published in 2021, it seemed that the patient with a low SDR, seemingly has a higher chance to have a moderate or severe headache compared with a high SDR group. Of course, in this paper, it's also suggested in addition to SDR, the skull thickness also have a correlation with the incidence of the headache. And also, in this paper, it's also revealed that the incidence of the patient to press the stop sonication due to the headache is seemingly higher in the low SDR group compared with the high SDR group. This is another paper suggests that the intensity of pain varies across the skull SDR. So as you can see in this figure, it shows that in the focused ultrasound treatment, the severity of the pain, level, diffuse pain seemingly is stronger than localized pain. And this figure shows that for the patient with low SDR, it seemingly have a more chance to have a diffuse pain compared with the patient with the patient with low SDR seemingly has a higher chance to have a more diffuse pain compared with the localized pain. So it suggests that the low SDR patient seemingly have a more strong headache during the procedure. So based on the previous literature review, we know, first of all, low SDR patient can be safely and effectively be treated with focused ultrasound compared with a high SDR group. However, we need to be aware that a headache might be another one side effect and need to be keep an eye on during the treatment. So how can we practically treat the low SDR patient? This is the case report published in 2022. So this patient has a low SDR of 0.38. The patient also have a hyperostosis. So in this case report, they try to use even up to 61 kilojoule, but still cannot reach to 50 degrees Celsius. So this is the figure in this paper. So you can see this obvious hyperostosis of this patient. And even after multiple sonication, they can only identify very mild lesion in the VIM. So as a comparison, this paper also shows 4 cases with a similar SDR, but without the hyperostosis, this team, even with a low SDR, they can still reach to a therapeutic temperature. So this is another paper published in 2020. So in order to achieve the therapeutic temperature, so this paper suggests to minimize the temperature rise during the alignment and verification stage. So just a quick recap. During the focused ultrasound treatment, we need to go through several stages, starting from mechanical alignment, verify, and the treatment stage. The purpose of the alignment stage is to ensure the focal area is aligned with the target physician design on the workstation. And later, once we ensure the good alignment between the real focal area with the target, the user is instructed to increase the temperature in order to transiently test the patient's outcome. And later, once we ensure the clinical outcome, and then we can dive into the next stage, which is the therapeutic temperature, which is the lesion temperature. So we know for low SDR patient, it's always challenging to reach the therapeutic temperature. So in order to still have a chance to reach to a therapeutic temperature, this paper suggests that we need to keep the temperature in alignment and stage as reasonable low as possible, and all of a sudden increase the temperature. This is another paper suggests that in their 39 patient group with SDR 0.36 across different years from 2015 to 2021, they noticed that there's a negative relationship between the sonication number and the average temperature they can achieve, which indicate that in order to able to treat a patient with low SDR, to minimize the sonication in one procedure, it may be a good strategy to still achieve the therapeutic temperature. So this is another paper suggests in case we know for this patient, with no matter what we do, we cannot achieve a lesion temperature which is more than 55, how should we do? So in these 2 papers in journal, they suggest a repetition of suboptimal temperature in order to still see a good clinical outcome. In this paper is a 1-year follow-up, and yeah. So which means if you cannot manage to achieve therapeutic temperature by having a repetition of suboptimal temperature, for example, 4 to 5 repetition, or in this paper suggests 1 to 3 repetition per right target, still can manage to control the clinical tremor. This paper suggests that the relationship between the working frequency and the focused ultrasound intensity. So in this paper, it suggests that lower the working frequency, it seems that the focused ultrasound might have a higher intensity ratio after penetrate through those catavascular. So we know the esophageal neural system has a working frequency between 620 to 720 kilohertz, which fall into this region. So even though the working frequency of esophageal neural system can be adjusted is limited, but it seems that by reducing the working frequency, we might have a chance to increase the focused ultrasound penetration efficiency. So again, just I mentioned at the beginning, even though it's still not perfect, we are still learning from all the sites. So here we would like to provide some of the best practice to deal with the low SDR treatment. So based on the previous review paper, we know that for the patient with hyperosmosis and together with low SDR, we need to be cautious. Again, because majority of focused ultrasound energy is being absorbed by the skull, and in combination of the hyperosmosis and the low SDR might indicate a less successful treatment. Secondly, before the treatment, we know that for the low STR patient, we intend to use a higher energy. And in esophageal neural system, we have an automatic calculation regarding the cooling time. So in case we use the high energy, the cooling time can be higher up to 15 minutes, for example. So in general, the table time can be more than 4 hours, depends on the technical and clinical outcome. So before the treatment, the patient education is also important to let the patient aware that if the patient has a low SDR, the table time might be longer compared with a high SDR group. During the treatment, as previous literature suggests, we might still be able to reach the therapeutic temperature by limiting the number of sonication and increase the parameter more aggressively. So here, the right figure is an example from during the treatment. As you can see here, they perform the alignment phase with the minimum energy, and all of a sudden increase the energy to the next stage for the verification, and all of a sudden, for the next sonication, they increase the increase the energy dramatically in order to achieve the lesion temperature. So this example is the patient with the SDR 0.33. So we know key of the success of MR-guided focused ultrasound is to make a lesion at the target. So even though sometimes for the low STR patient, we might not be able to achieve the ideal therapeutic temperature. So again, with a repetition, with repeated sonication with suboptimal temperature, we can still manage to have a good clinical outcome. And practically, esophageal neural system provides thermal dose as an indicator to show you if the repetition is enough or not. If the repetition is enough, then our system can calculate, can show you the thermal dose. So lastly, in case all the workaround is not working well, then one of the options in our system that you can still lower the working frequency in order to hopefully increase the energy penetration, energy efficiency for the focused ultrasound. So here is the summary of the best practice we can provide so far, and I'm looking forward to hear from you for if you have any other comment. So I will not read all these words to you, And I will stop, my presentation will stop here. Thank you very much.
Thank you, Dr. Kevin Sai. Now it's time to honor Dr. Kevin Sai. I am pleased to invite Dr. Arul Selvan, Dr. Vijayan to felicitate the speaker with a memento. Session is open for Q&A.
Doctor, I have a comment. Thanks for the talk, very informative. I have a comment and a question. The comment is that, as I see it, the SDR, you show well that the SDR is not associated to higher rate of side effects or more serious side effects. So in the end, as I see it, the SDR is just one of the factors that we have to consider in the decision-making process. You show that higher energies require longer cooling time. So if you have a patient who's too frail, maybe too old, the SDR, a low SDR has more impact than in a more young patient, strength patient. So this is how I see it. There are very few absolute contraindications for ultrasound treatments. And the SDR has to be put in the context of the general balance of the patient.
Right.
And
yeah, I totally agree. I mean, side effects, according to my understanding, the information from that paper is just showing that due to the fact that the low SDR patient might not be able to achieve the temperature easily compared with the high SDR patient. So I think that side effects more or less refer to that because of the accidentally increase of a high temperature or accidentally to invade to the other sensitive area, for example, internal capsule, the other thing. But of course, agree, side effects is a very big picture, and SDR is only one factor that might contribute to that side, yeah.
And my question is that we can increase energy with power and temperature, right? And we have always been told by by increasing time instead of power, we have more widespread lesions at the same level of energy. We have more widespread lesions with more edema. But I have looked after this in the literature, and I have not been able to find any paper showing that at the same level of energy, increasing time produces more widespread lesions. Is there any evidence on that? Are you aware of this?
Based on what we learned, and physically, not really physically based, but based on what we learned, that with the same energy level, if you increase the power and keep the short time, it's just a regular radio frequency, you just poke and short shot, single shot. But if you keep the low power but increase the duration, it's more like you're cooking, gradually cooking, and you see the temperature increase or reduced by the focused ultrasound will not keep there. My understanding, it will spread. So that might be the reason why you will see a wider spread lesion or the thermometry by using the longer duration and shorter.
Okay, this is what I thought, but yeah. I have not been able to find a paper or a clinical patient. Okay.
So I can comment a little bit. There's a history, because when I first started this clinical trial, the system has automatically stopped when the energy reached 35,000 joule. But nowadays, we can increase up to 60,000 joule. But as we discussed, if we deliver high energy, we don't know the energy delivery in the target. Sometimes make a big problem. Right. But you must keep in mind that I think the Caucasian people usually don't make any problem with low SDR, because in the Caucasian people has less thick skull than Asian. the Far Eastern, Indian peoples are similar with Caucasian people. But the Korean and Japanese people, even though the Japanese people published many papers that they showed a good outcome, but when we had a meeting, they personally mentioned that they have many cases of the serious complication by making the adjacent lesion because of the energy delivery. So it is very important in the we must consider both. If the patient has low STR, if the patient has thin skull, we usually have good outcome. But if the patient has thick skull with low STR, we must be very cautious. But it's totally different from Caucasian people and Far Eastern Asian people.
Right. Thank you, Professor.
Indians are brown Caucasians by race. Indians are brown Caucasians by race. So we, in spite of low SDRs, we are still able to make a lesion because of thinner skulls and also more uniform skulls, the shape of the skull also. So we are able to get a better lesion. That's why in some cases with low SDR, we are easily able to achieve it. But with the skull being very ununiform, even with 0.4 to 0.5, we are not able to achieve it. So I feel not only the SDR, it's more than that. Yes. And that, of course, SDR is a very important parameter. And just add to that to say the whole of India, from Kashmir to Kanyakumari, we have seen overall 0.55.
Right.
And
I have to clarify one thing is that in this presentation, we focus on low SDR treatment. Of course, we know in terms of making a lesion or in terms of achieving the therapeutic temperature, still SDR is the most dominant factor, but still also, as you know, Professor Zhang published a very wonderful paper describing that in addition to SDR, skull volume, incident angle is also played a role in terms of energy efficiency. But I have to just clarify that in this presentation, we just focus on the low SDR. But yes, in addition to SDR, skull thickness, skull volume, incident angle, or just like Dr. Vijayan mentioned, that maybe skull shape may be also related with the energy efficiency. Yes. Thank you.
Thank you, Dr. Kevin Soy, for the exceptional session of the MRGFS. We sincerely appreciate your time and contribution to today's session. Thank you.
Tea is always a great idea. Let's resume the inaugural function within 10 minutes. All are requested to have tea and resume the function within 10 minutes.
Suresh, Royal Care. Royal Care.
நான் இங்க மைக்ல பேசிட்டு இருக்கேங்கண்ணா. சரி சரி
பேசிட்டு இருக்கேன்.
சரி
ஸ்பீக்கர் திருப்பே. ஏய் போடா. ஸ்பீக்கர் பக்கத்துல திருப்பே.
சரி அண்ணா கேக்குதுங்களாண்ணா?
ஓகே மெதுவா இன்னும் இருக்காங்க உள்ள.
ஓகே ஓகே
ரைட். ஓகே உங்களுக்கு எல்லாம் ரெடியா?
அண்ணா வந்து பேசண்ட் உள்ள கூட்டி வரலைங்க.
ஓகே
எல்லாம் ரெடி தான்.
ஓகே ரைட். ஆடியோ ஓகே, வீடியோ ஓகே. ரைட்.
ஓகேங்கண்ணா.
Designed state-of-the-art multidisciplinary ICU on par with international standards of care and safety. Let me introduce Dr. M.N. Shivakumar, a renowned critical care professional head who heads this critical care unit, ably supported by a well-qualified team of specialist doctors. Seminar room. Doctors and allied health professionals utilize this facility to undertake regular training and updates essential in delivering up-to-date advanced care to patients. In-house nutrition preparation area. Patient feeds are prepared under hygienic circumstances here. It reduces the need for transportation of feeds from outside ICU. Thereby, infection risks are reduced. We do have the in-house blood gas analyzer. An essential day-to-day testing facility for critically ill patients is available within easy reach. Welcome to Royal Care Hospital Intensive Care Unit. So, what exactly is an ICU? ICU is a specialized care unit where the sickest of all patients are treated for. In ICU, the staffing level is different to the normal wards. Usually, there is one-to-one nurse taking care of the patients in ICU. Specially trained intensive care doctors are physically present caring for the sick patients on a 24/7 basis. Let's look at the individual bed space area. As you can see, it is very spacious, more than the stipulated norms, and it is well lit with daylight provision. Let's look at the provisions within this. The unique feature of the bed space area is the ceiling mounted pendant. The ceiling mounted pendant has the monitor, the ventilator, and the syringe pumps mounted onto it. The advantages of it are it has got the medical gas hosings that goes through the pendant and the electrical wiring that goes through the pendant. So it is less of a congestion so that the nurses and doctors can reach the patient from all sides easily. Apart from the basic monitoring systems, we do have advanced monitoring systems like the cardiac output monitor,
bedside echocardiography, the EEG, the transcranial Doppler, ICP monitoring systems, and capnographic systems as well. Each of the bed spaces comes with a bedside provision for dialysis, plasma exchange, and ECMO specialist services as well. Another unique feature of this ICU is the electronic charting of patient data. It is called ICA, which stands for IntelliSpace Critical Care and Anesthesia System. It is basically a software system which integrates the monitors, the ventilator, and the syringe pumps and creates an electronic chart of patient data. By this, it helps in patient safety, reduces the amount of work for the nurses so that they can spend more time with direct patient care. This kind of a facility has been introduced within this ICU for the first time within the whole of South India.
You can look at the isolation rooms, which are aptly designed to isolate infected patients with negative pressure monitoring systems. The positive pressure facility helps treating patients at
a simple thing that you take for granted, like pouring water into a cup. I cannot do it with one hand. So even this, I have to hold it with both hands and take it to my mouth, or preferably bring my mouth to the glass. It was, on the whole, frustrating.
Tremors may be genetic problem. Familial tremors are there. Essential tremors you get when you become old. Everyone gets, but some people get into very severe tremors. And there are certain diseases like Parkinson's disease and others which produce tremors. All the tremors are treated with medicine only for the past many decades. Then certain surgical procedures came, but all these procedures are invasive. You have to make a hole in the skull and enter into the brain, but only that was available all these years. So we were forced to use those things to give some sort of benefit to these patients. So when we heard about this treatment, we decided to have it because we have a huge load of neurology, neurosurgery cases inside. So we wanted to give something best to them. The procedure is called MR guided focused ultrasound.
I used to be a writer, incidentally. I used to go on writing, and I could type with both hands on the laptop or the computer keyboard and edit. Maybe I can write from tonight.
The most important thing to remember is this procedure is non-invasive. You don't use knife, you don't enter into the brain. Only waves enter into the brain and create a lesion in the thalamus. That is one of the fantastic things to hear and happen.
I feel like a kindergarten child. Goes and tells the mother, I brush my teeth on my own. I did that today. Morning tea, I said, I will pour it into this mug. Then came the problem. How do you use the mug? My muscles had forgotten, so I had to ask my assistant, how do I hold it? I said, do I hold it like this? Do I hold it like this? So he taught me something. He said, no, sir, you hold it like this. So I said, okay, I'll hold it like this. And I drank the tea. I wasn't sure if this is ever going to reach my lips. Okay. I put this hand away, reached my lips. Today's lunch also, he served me my lunch. I ate on my own.
The best part is the patient recovery. After the procedure, the happiness on the face of the patient.
Thank you so
Yeah,
much.
we are happy. We are also happy. Yeah.
I would say just blindly go and get it done and get on with your life.
Actually, first we never knew it's Parkinson's. He just had tremor on this thumb. Then slowly it started increasing.
Before these tremors, he used to travel a lot related to his business thing, and he used to socialize a lot. He goes out with relatives, friends, and all. So once this tremor started, he started avoiding traveling or going out for functions.
I was an exporter, government exporter. Now all stopped. I can't go in the crowd. I can't stand for more than 5-10 minutes. So many things. I feel a little ashamed when I go into the crowd.
All the tremors are treated with medicine only for the past many decades. Then certain surgical procedures came. But all these procedures are invasive. You have to make a hole in the skull and enter into the brain. And we insert some foreign body inside the brain, and which is there always. As you know, any foreign body can create any problem anytime. Now you have a procedure which is non-invasive, no foreign body, and it gives you permanent relief. And it is very simple. Day care, no major complications. I would say no complications. The procedure is called MR guided focused ultrasound.
When I go into the crowd or go into the public areas, my shake will be more. I stopped attending marriages because of this. When I go to the crowd and other thing, everybody is looking at me. That I feel very uneasy. It's like I'm going to get out of the jail. Bonded jail. As soon as I entered, I closed my eyes and started praying. I found it's very comfortable. %80 at over, then they pulled me out. And in between once or twice, they asked me to put the circle under. Left hand making circle is not easy. I made it somewhat. Then they pulled me out. Then when I came out, it was perfect. The sad slight thing is that is because I'm in the new place.
The most important thing to remember is this procedure is non-invasive. You don't use knife, you don't enter into the brain. Only waves enter into the brain and create a lesion in the thalamus. That is one of the fantastic things to hear and happen.
It is like a miracle. It's a miracle.
Dear dignitaries, we are honored by your presence. Today, we welcome our beloved respected on the stage, Dr. K. Madheshwaran, Chairman, Royal Care Super Speciality Hospital, Dr. Arul Selvan, President, FIICU, Dr. Parandaman, Medical Director, Royal Care Super Speciality Hospital, Dr. Vijayan, Organizing Secretary, FIICU, Professor Jin Woon Chang, Dr. Raul Martins Fernandez, Dr. Ronald Dominic, Professor Deepankar Nandi. There is a slight change in the schedule. Ladies and gentlemen, it's our great privilege to welcome Professor Ronald Dominic Jamora, who will be delivering a keynote address on MRG Fuse Philippines connection. Professor Jamora is a respected leader in the field, and we are honored to have him with us today to share his valuable insights and experiences related to MR-guided focused ultrasound in the Philippines. His expertise and contributions to this cutting-edge technology have made a significant impact in advancing patient care and treatment outcomes. Please join me in welcoming Professor Ronald Dominic Jamara to the stage with a big round of applause.
Okay. Okay. Is it working? Okay. Thank you very much. Okay. Good afternoon, everyone, and thank you once again for the kind invitation, and congratulations on the inaugural meeting of the Focused Ultrasound Society of India. So I was invited to talk about our experience in Parkinson's disease and X-linked dystonia Parkinsonism. Some disclosure, I am a neurologist. No? So a lot of you guys here are neurosurgeons, so I'm a neurologist. So this is the government hospital that I work in. It was created in 1907. It's the Philippine General Hospital. It opened to the public in 1910, and 1,100 service beds, 400 private beds, with about 4,000 employees. So the basic outline would be this one. We did a review on the movement disorders that we see in Manila, in two medical centers. So, of course, number one would be Parkinson's disease. And as you can see, X-linked dystonia Parkinsonism, being that I'm based in Manila, there's not a lot of XDP. So the Philippine General Hospital acquired the system, the InsightX system, in 2020. And from 2020 to 2024, 201 patients were referred for possible MRG FUS. 65 patients underwent initial screening. 16 had low SDR. 5 patients were ineligible due to based on neurologic evaluation. And 2 patients were diagnosed with depression, and 8 patients were good candidates, but eventually refused treatment. So 30 cases were done up to February of 2024. As of September last year, additional 4 cases were done. So as you can see, there have been 7 XDP patients, 25 tremor-predominant Parkinson's, and 3 essential tremors. SDR range mean would be about 0.46. So you're all familiar with this one. So 6 patients had low SDR as low as 0.22 to about 0.3. 14 patients had HIFU or MRG FUS, all with Parkinson's disease. 3 patients passed but decided not to proceed. 9 patients were advised to start oral medications first. And 8 patients have not yet been seen, but they did the initial screening for CTs for the SDR. Intraprocedural events: headache, dizziness, right-sided numbness. Post-procedural events: right-sided weakness, 2 patients, and right-sided numbness, 1. So number of with follow-up would be just about 5 out of the 22, or 22%, or 23%. For XDP, 100% follow-up. So these are the cases. Again, as mentioned earlier, 91% exhibited improvement post-procedure. However, 2 tremor-predominant Parkinson's disease had unsuccessful treatment. One had severe headache, and he would repeatedly push the stop button during sonication. And one had weakness and numbness post-procedure. So some videos, as you can see, immediately post-op, post-HIFU, the tremors are very much controlled. However, this particular patient actually had very early recurrence, no? Just 1 day. This is 1 day post thalamotomy. The tremors are still very well controlled, but 9 days later, the right hand tremors are back, although not as severe as before, but still, it came back. The tremors are back. And this is 7 months post HIFU. Tremors are practically back to pre-HIFU state. No? So we've been asking whether we need to do another treatment, or the patient is a physician, so he knows his options. So we've offered DBS as well. So this particular patient had severe movement, especially on the head, and there was a breakage of the stereotactic frame post due to the tremors. Some swelling that we see. There was a transient leg weakness post-HIFU. Follow-up, again, 3 had tremor recurrence, 2 had transient leg weakness, 1 had numbness of the contralateral extremities and the lips. So let's talk about X-linked dystonia Parkinsonism. It's a generalized dystonia that's only found among Filipinos. So the nomenclature is DYT-PARC-TAF1. It's an adult-onset severe progressive movement disorder with a high degree of penetrance and a high frequency of generalization. So in about 5 years, these patients would generalize. In about 10 years, the Parkinsonism would predominate. So 99% are males, and we do see female XDP patients. So these were the original drawings of the local neurologist in Rojas. So that's the Philippines. So majority of the patients are from Panay Island, especially Capiz, because that's where we usually go to see patients. In the last 2, 3, 4 years, we've seen a lot of cases as well coming from Mindanao, the very south of the Philippines. And on further investigation, a lot of these patients were actually migrants from Panay. That's why we're seeing a lot of, or, you know, we're seeing patients with XDP as well in Mindanao. Initial presentation would be focal dystonia in about 90–80%, with or without Parkinsonism. Parkinsonism as an initial presentation would just be about 6% initially, but by now it's up to 17%, and that's probably due to, you know, better recognition that these patients can present with Parkinsonism as well. Age of onset has not changed, and as you can see, they can present with different types of movement. You have oromandibular, cervical, limb dystonia, blepharospasm as well. And this is how the disease would progress, no? And for this particular patient, in just about 2 years. And medication-wise, you know, it's very limited. Botulinum toxin would work for a short period of time. This first patient I saw, he came from the north part of the Philippines, and he was referred to me for tremors. And he did have some tremors, but he was also, he has some dystonia as well. And on further investigation, the mom was actually from Panay Island. His parents were separated, and he lived with his dad, who's from the north of the Philippines. And towards the latter part, then you can get some resting tremors, but you do see the left foot dystonia, the left toe dystonia, the mask fasciae, and the stoop posture as well. So the Parkinsonism can predominate. And we do see it among females. No? So the first two are more sort of severely affected. This other lady, the last one, is the daughter of an XDP patient of mine. And recently she consulted because of some slowness and some gait problems. And as you can see on the left foot, there's that inversion, there's that foot dystonia as well. No? So one possible reason why females are affected would be the X chromosome inactivation. We had one case report of a patient who had Turner's, an XO, hence the XDP manifested. There are non-motor symptoms as well. Mood and cognition problems occur. High depressive rates, cognitive impairment, some other anxiety, social phobia. So for memory, it's basically the general intellect, episodic memory, attention, and executive function that are affected. A lot of patients would commit suicide because of the nature of the disease. Outcome, 25% would be bedbound, but this is an old data. 2/3 would still be ambulant but not working. 2% would be non-ambulant but somehow able to take care of themselves. Medical management, as mentioned earlier, is limited. You know, they've tried anti-seizure medications. We've tried levodopa. It does not work. Zolpidem helps for a bit, you know, but there's tolerance. We would usually start patients on Zolpidem at 10 milligrams 3 times a day, and they're still up and about and not sleepy. Botulinum toxin would work, but, you know, as with the nature of botulinum toxin, then they would need repeated injections. And we would not be able to inject all of the muscles that are affected. DBS works for XDP. In these 3 papers with long-term follow-ups, about up to 84 months, there's improvement in dystonia, but variable response in the Parkinsonism, but overall improvement in the functional and clinical state of the patient. So let's see this one. So craniocervical dystonia has a peg very thin, cervical as well as oral dystonia, some upgoing toes on the right, difficulty walking because of the foot dystonia. This was pre-DBS. Post-DBS, 6 months later, he gained weight, he had his peg removed, and he's practically back to his old self. No? This was 36 months later, he's gained more weight, still doing well. 72 months, some hesitation with walking, difficulty turning, and partly I think, it's really the Parkinsonism that predominates at a later part. I saw him in 2022 and just 2 weeks ago. So now the battery actually has been off for about a year now, and he hasn't decided yet whether he would want, a replacement of the battery. So he's lost weight from the 2022 video. So in terms of functional outcome, the higher the stage, of course, the worse the condition of the patient is. And on last follow-up, there's less of those in stages 3, 4, 5 compared to pre-op. No? So definitely DBS works. So I got this email from Professor Chang of Taiwan, and that's where I met Kevin. So he was asking about a possible collaboration for, about XDP and focus ultrasound. And I met up with him because I was in Taiwan that November. This was July. So we met up and decided that, okay, we'll be sending patients to Taiwan and we'll start working on the IRB approval. So this was one of the patients that was done in Taiwan with Professor Chang and Kevin. And as you can see, there's really improvement. No? And on walking, okay. However, pandemic happened, so we were only able to do 4 patients in Taiwan. This was in 2022. He had the HIFU on the left in 2019, and the disease has progressed. No? So we offered to do the other side or the DBS for that matter, but the patient was no longer receptive. No? So these were the papers that came out of that for patients. So while we cannot compare directly the results of the DBS and the HIFU, because number one, there's just 4 patients who underwent HIFU, and the scales that were used were different. At that time, we didn't have the XDP MDSP scale, so we were still using the BFM and the UPDRS. But definitely, there's improvement. No? So 12-month data for HIFU are encouraging. The dystonia, the Parkinsonism, the behavioral non-motor, and the activities of daily living actually did improve, no? Except for some of the non-motor non-behavioral part. Biggest improvement would be in terms of cognition, apathy, anxiety, depression, and irritability at close to 2/3, no? 67%. Dystonia at about 40%, and Parkinsonism at about 30%. So this also highlights that, we need to look into the non-motor aspects of the disease. So this was one patient that I saw way back in 2023, and as you can see, there's that right leg extension and some difficulty with walking. By the time that we did the HIFU in October, he could hardly sit still for our neurosurgeon to actually put the frame. And immediately post HIFU, he was able to sit still for a long period of time, and the right leg extension actually disappeared. He's an overseas Filipino worker. He actually works in the Middle East, so he flew back to the Middle East to resume his work. And I got an email that, you know, he's worsening again. So this was day 1, and after a few months, by January of 2024, practically he couldn't sit still. There's that pelvic thrusting, and now the left leg is the one extending. So we offered again to do the other HIFU because it's under a clinical trial, but the patient opted to have a DBS in another center. So I haven't seen the patient since then. So definitely there's improvement in the XDP scores, and the protocol for that trial has been published and it's registered with clinicaltrials.gov. And these are the people involved in the HIFU and the MRG-FUS program of the Philippine General Hospital. So what are the challenges? Basically, we started during the lockdown. So there's that problem with the travel restrictions, the delays, the training for the staff, problems with infrastructure, patient recruitment. It's an out-of-pocket expense, if ever, for the patient, although for MRG-FUS, it's being offered for free by the Philippine General Hospital. So lack of manpower, no dedicated MRI for just the HIFU, and in a way, poor patient follow-up. So it's a viable treatment option, especially with government support. It looks like patients are more receptive to MRG-FUS versus DBS, probably because of its non-invasiveness. But as mentioned earlier, it's sort of limited by the SDR, the low SDR. For XDP, we need more rigorous studies, no, to look at the long-term efficacy and utility. And we need a multidisciplinary team, no? Medical, allied medical, nursing, the admin staff, etc. So with that, these are the people I'd like to thank. So thank you very much. This was during the first MRG-FUS workshop in Manila way back in October 2023, and I think Professor was there. So thank you very much.
Thank you, Dr. Jamora. Now I request Dr. Vijayan and Dr. Arul Selvan to felicitate Dr. Jamora. Now the session is open for Q&A.
Thank you, Professor. Great talk, and I want to thank you for this trial, because sometimes, this is a comment and then I have a question. Sometimes when we show videos of essential tremor patients, this is astonishing. You know, they change their life, they have nothing. But these diseases, and I include PD, but this is far more complex. These diseases are much more diffuse and involve many other symptoms that cannot be treated. So even if the videos might not be as astonishing as essential tremor, we don't know how this patient would have been without the treatment. So I think this is very, very important to keep doing trials with these relatively rare diseases. So thanks for that. And my question is, how do you see the future of of this approach in this population? I mean, how many patients could be treated? What's the general outcome that you expect once you refine the technique and have more data? Thank you.
So we've only done 7 patients, no? 7 XDP patients who had MRG FUS, and 2 of them we actually did the opposite side. The first 2 patients that were done in Taiwan. So 7 patients with sort of minimal follow-up. So it's a little bit hard to generalize. And there's also that factor of the disease progressing, as we can see in the video. There's always that overflow dystonia that we see among patients. So even if the treated side should be quiet, we see overflow dystonia as well. So which somehow leads to patients being a little bit, disappointed in the treatment and everything. So as we always tell them, it's under a clinical trial. So yeah, so we need more patients.
Also, I think it's something related to patients' expectations as well. Maybe they expect something, but you mentioned one point that I think is very important, that one of the patients went back to work, which means that functionally he improved enough, and that's very, very important in my opinion. So,
yes.
Thank you.
Thank you.
Thank you, Professor Jamora.
The target you chose is a pallidothalamic tract, isn't it? Have you tried the double lesioning, globus pallidus interna and also pallidothalamic tract? It seems to be very complex dystonia. It's not purely dystonia also. Some patients do have dystonic tremor.
So the approved target for the trial is actually the PTT. So we haven't done double targeting with, let's say, with the GPI together with the PTT.
Right. That could be the potential explore. You can do that in the forthcoming cases. We can do the double lesioning also. One in the globus pallidus interna, another one is the pallidothalamic tract.
Yeah. Thank you.
Just one thing. We have a similar disease in India, specifically in one particular community, especially northern India, which is spinocerebellar ataxia type 12. They have predominantly tremors, a lot of ataxia, and a lot of peripheral neuropathy. And it's always asymmetric. We have treated 9 cases of spinocerebellar ataxia type 12. And we, of course, due to disease progression, we are finding difficulties. But there are a few patients whom we have had remarkable success, sustained for almost 2.5 years now. But some patients we fail on the table. We are not able to get any response on the table itself. And some patient, it comes back immediately. Yes. So nowadays, we are targeting the Vim Vivo plus the posterior subthalamic area. Of course, it does produce some ataxia, but the tremor goes off completely. So dual lesioning of PSA and posterior subthalamic area. And then chairman wants to know, if you have targeted only PTT, why not include the Vivo also in your cases? Because a lot of dystonia, both distal and proximal.
So, yeah, maybe the other patient with a very good response, the one initially with a right leg extension, that was very, very early in the disease. Even for DBS, the recommendation is actually to do the DBS early on at the time where there's no caudate atrophy yet on MRI. So maybe the disease progression is always a big factor in terms of the response to the MRG FUS or the DBS. Thank you.
Thank you, Professor Jamora, for your insightful session on the MRGFS Philippines connection. We are sincerely appreciate your time and expertise. Let us give him another round of applause.
Let's move on to the auspicious session inaugural event. Dear dignitaries, we are honored by your presence today. We welcome our beloved respectees on the stage. I would like to welcome Dr. K. Madheshwaran, Chairman, Royal Care Super Speciality Hospital. I welcome Dr. Arul Selvan, President, FIICU. I welcome Dr. Parandaman, Medical Director, Royal Care Super Speciality Hospital. I welcome Dr. Vijayan, Organizing Secretary, FIICU. I welcome Professor Jin Woo Chang, Seoul, South Korea. I welcome Dr. Raul Martins Fernandez, Madrid, Spain. I welcome Professor Roland Dominic Jamora, Manila, Philippines. Please join with me in welcoming all of them with a huge round of applause.
இருப்பதும் போவதும் யாவரும் செய்வதே, இதுபோல் இருப்பதும் போன பின் நிலைப்பதும் யாருக்கும் வாய்க்குமோ. உம்மடி பொடி குவிந்து குன்றமாய் உயர்ந்தின்று வாழ்வாங்கு வாழ்வு வாழ்ந்திட வாழ்த்தும் இவ் அரங்கிற்கும் அரங்கேற வைத்த என் ஐயனே அப்பனே உனக்கும் என் வணக்கங்கள் என இறைவனை வாழ்த்திட இறைவணக்கத்திற்காக அனைவரையும் எழுந்து நிற்கும்படி தாழ்மையுடன் கேட்டுக்கொள்கிறோம்.
To please stand up for the Irai Vanakkam. We request you all to continue standing for Tamil Thai Valthu.
We'll start off with the prayer song. The conference theme is Soundarilagari. So we'll recite a verse from this composition. So just 1 minute for the prayer song. Shivashatya yukto yadi bhavati shakta prabhavitum nachedevam devo nakalu kushalastambitumapi atastvam aradhyam harihara virinchati pirapi pranantum stotum va katam agurta punyaga prabhavati. Thank you.
We request you all to continue standing for Tamil Thai Valthu.
காலங்கள் கரைந்து யுகங்களாகின, சொற்கள் அனைத்தும் கற்களாகின, அக்கற்களும் கல்வெட்டுகளாய் என்று கவி பாடத் தொடங்கின. எனினும் என்றும் இளமை மாறாது செழித்தோங்கும் செம்மொழியாம் விண்ணை அளந்து எம் அன்னை தமிழை உம்மை வணங்குகிறோம். Thank you all. Please take your seats.
Officially welcome our distinguished guests, faculty and delegates. It's my honor to invite a visionary leader in the field of healthcare, our esteemed medical director, Dr. B. Parandaman Sethupathi, to deliver the welcome address.
Good evening, esteemed colleagues and friends. It's a great privilege to welcome you all to the first international conference by the Focused Ultrasound Association of India. It's truly a pleasure to see so many dedicated medical professionals gathered here today united by a shared interest in advancing patient care through innovative technologies. On behalf of Royal Care Super Speciality Hospital, I extend a very warm welcome to each and every one of you. We are very proud and very happy to host this landmark event, which promises to be a valuable platform for sharing knowledge, discussing best practices, and exploring the exciting potential of magnetic resonance guided focused ultrasound. This technology represents a paradigm shift in how we approach certain medical conditions, offering non-invasive alternative with remarkable precision and potential for improving patient outcomes. I think you guys have been witnessing all these cases and information that has been shared in the last few hours. We believe that by coming together and sharing our experiences, we learn from these leading experts in the field, we can definitely accelerate and adopt these refinement to make this groundbreaking technique reach even more number of people. This conference is designed to provide you with a comprehensive overview of the magnetic resonance guided focused ultrasound, covering everything from the underlying principles to the latest clinical applications. And as you have seen, we have very distinguished faculty amongst us, international and national, who will share their expertise, who have also been sharing their expertise in every range of topic. We encourage you to actively participate, ask questions, and engage in discussions with your peers. The exchange of ideas and perspectives is crucial for driving innovation and ensuring safe and effective implementation of this technology. In the last few hours and the coming for few hours and also tomorrow, I hope you will find this conference inspiring and informative. We are confident that the knowledge and connections you gain here will be invaluable in your practice. Thank you for joining us, and I wish you a very productive and enriching experience. Do not hesitate to reach our organizing team if you have any questions or require assistance. We are here to ensure that your time in the conference and in Coimbatore is both valuable and enjoyable. I welcome you all once again. Thank you.
Thank you, sir. Let us now proceed this prestigious event with a traditional and auspicious start, the lighting of the lamp. Light is a symbol of knowledge, wisdom, and positivity. It dispels darkness and paves the way for enlightenment. We kindly invite our esteemed dignitaries to come forward and grace the occasion by lighting the ceremonial lamp. Dr. K. Madheshwaran, Director, Focused Ultrasound Association of India, Chairman of Royal Care Super Speciality Hospital. Dr. S. R. Manohar, President, Medical and International Affairs, Royal Care House Super Speciality Hospital. Mr. Srinivas Sundarraj, Vice President of Marketing, Royal Care Super Speciality Hospital. Dr. Parandaman Sedri. Dr. Paul Martinez Fernandez, Madrid, Spain. Dr. Roland Dominic Ferreira, Manila, Philippines.
இருள் நீக்கும் ஒளி விளக்கு, ஞானம் பெருகும் நல் விளக்கு. அத்தகைய ஞான விளக்கினை ஏற்றி வைத்ததற்கு பொறுப்பிலே பிறந்து தென்னம் புகழிலே கிடந்து சங்கத்து இருப்பிலே இருந்து வைகை ஏட்டிலே தவழ்ந்து பேதை நெருப்பிலே நின்று கற்றோர் நினைவிலே நடந்து மரபிலே பயின்ற தலைவர்கள் அனைவரையும் நம் இரு கரம் கூட்டி நம் கைகள் இணைத்து இசையினை எழுப்ப செய்யும் நேரத்திலே இந்த வண்ணமயமான அரங்கினை ஒளிர செய்ய இவ்விழாவை விளக்கினை ஏற்றி வைத்ததற்கு நன்றிகள். As the flame rises, let it be a beacon of learning and discovery throughout this conference. May this event enlighten us with the new insights and advancements in ultrasound technology. We request our chairman, Dr. K. Madheshwaran sir, to deliver a speech on our chief guest, Professor Jin Woo Chang. To felicitate the function. To felicitate the function, I request Dr. Madheshwaran sir to deliver a speech.
We are happy to arrange this conference in Coimbatore, first Indian International Conference on Focused Ultrasound. We are very happy to have Professor Chang, Jamora, Fernandez with us and with many neurologists and neurosurgeons from all over India. I welcome you all. I think we have very decent experience now on focused ultrasound. We will continue to improve on this with the knowledge spreading from all over the world. I welcome you all again and enjoy your stay here with our hospitality. Thank you.
Next, we have with us a dynamic leader. We have with us a dynamic leader whose expertise, dedication, and strategic foresight have played a pivotal role in driving operational excellence at Royal Care Super Specialty Hospital. Through a strong commitment to efficiency, growth, and continuous improvement, he has been crucial in shaping the success story of our institution. To do the honors, we invite our Chief Operating Officer, Dr. K.T. Manisendal Kumar, to introduce the esteemed faculty members. Let's welcome him with a big round of applause.
A very good evening to one and all gathered over here. It's a privilege to introduce our guests and the keynote speakers for this wonderful conference. So I wish to introduce Dr. Roland Dominic Jamora. He is a practicing neurologist, a prolific researcher, and
who has been the board of member in number of international journals and who has a credit of more than 100 research articles on his name. So currently, Dr. Jamora is a clinical associate and he is continued to associate with University of Philippines College of Medicine. We are very thankful for your presence over here, sir. We welcome you once again. Next, we wish to introduce Dr. Raul Martinez Fernandez, who has been instrumental in carrying out this technique, and he is currently the neurologist and the clinical researcher at Sinac Hospital, University of Puerto at Madrid, Spain. His main area of interest and expertise is mainly on the movement disorders, especially in Parkinson's disease, and he is well versed in techniques in high intensity focused ultrasound programming. And to his credit, he has a lot of papers in the journals like Lancet and NEGM. We welcome you, sir. We have Jinwoo Chang, the professor from Department of Neurosurgery, Seoul, Korea. So he is the pioneer to design the focused ultrasound research for the neuropsychiatric disorders. He is a pioneer who has been conducting a lot of studies in this field, and he is the first one to perform the focused ultrasound pallidotomy for the patients with Parkinson's disease. We are privileged with all your presence over here, sir, and we are being honored by your presence. Thanks once again for your gracious presence. Thank you, sir.
We are happy to present the international faculty with our traditional dhotis and shirt. I request Dr. Jinwoo Chang to receive the traditional dress. I request Raul Martin to receive the traditional dress. I request Ronald Dominic Chamara to receive the traditional dress. I request Dr. Kevin Sai to receive the traditional dress. Request Professor Jinwoo Chang to say a few words.
Once again, thank you for your invitation, and I learned a lot. Initially, I thought because of the first meeting, I thought the topic is very simple, but you cover the all aspect of the focused sound, including from the basic to the clinical controversies, and also I also experienced very fundamental. It's fundamental. It's Indian cultures at this moment. Thank you very much for your hospitality and invitation. Thank you.
It's now time to honor our guest. I request Dr. K. Raguraj Prakash to deliver a memento to Dr. Jin Woo Chang. Request Dr. Parandaman to deliver a memento to Dr. Ronald Dominic Jamora.
We request Dr. Arul Selvan sir to honor Dr. Raul Par.
I request Dr. Kanagaraju to honor Dr. Kevin Sai.
We request our beloved Dr. Arul Selvan sir to receive the presidential address.
We have one more presentation coming up by Dr. Arul Selvan. Live case is going to start in another 40 minutes. We conclude inaugural function now. Thank you. Thank you. Thank you very much for coming. Thank you.
Arulselvan, sir.
Moving to the next session, we request Dr. Arul Selvan sir to deliver the presidential oration.
Good evening, everyone. My respected teachers, colleagues, friends. On the outset, I would like to thank our chairman and Dr. Vijayan to give me an opportunity to share our journey of MRGFS in the Royal Care Hospital. Two important persons who brought this innovative technique to India and subcontinent is Dr. Madheswaran, happened to be a neurosurgeon. So he understands this could be a potential future of the movement disorder treatment. And so Dr. Vijayan, who was the main pillar in coordinating, seeing the patients. And we work as a team. That's a wonderful team. This is Apollo 11 members group. We started the MRDFAS program. This was the first case. Professor K.S. Srinivasan, who was in a wealth of knowledge. In the 1960s itself, he has done stereotactic lesioning in the Madras Institute of Neurology. And Professor Mahendra Datta, our well-wisher. We have a team. The team consists of neurosurgeons, neurologists, neuroradiologists, of course, anesthetists. Parkinson's disease, we all know it's a common neurodegenerative disorder. It has a characteristic triad, but now the triad has been extended to tetrad. Postural manifestations and imbalances are also included, apart from the tremor, bradykinesia, and rigidity. Equally, the non-motor symptoms are also important, like constipation, cognitive disturbances, depression. That needs to be dealt also. It brings immense psychological and medical burden to the family, especially for the developing country like India. It could not tolerate, could not adapt. Various modalities of treatment are available: pharmacotherapy, non-pharmacotherapy like yoga, meditation, and of course interventional treatment like deep brain stimulation, MRGFES. I was a deep brain stimulation expert. I've done first time in Coimbatore more than 25 to 30 cases. But the shift of paradigm is happening more towards MRGFS. Patients themselves, they are asking, they don't want invasive treatment. The treatment options, apomorphine pump is nowadays available. It's easily available in Western countries. But in Indian subcontinent, it was very difficult to obtain and also fill up the pump every day. And transgastrostomal digital dupa gel, and another option, radiofrequency lesioning, deep brain stimulation, gamma knife surgery, and of course MRGFS, gene therapy and cell therapy. DBS was the only treatment of choice till now for the motor fluctuation of Parkinson's disease and refractory essential tremor. Lesioning surgery has been there for some time, for 8 to 10 years, but it didn't really pick it up because of the ultrasound did not penetrate the skull, so they had to keep trying. Radiofrequency ablation of the BEM nucleus of Thalamus has worked wonders for the essential tremor, but I said it didn't take it up further. MRGF is a new novel technique to treat the movement disorders. Essential tremor was approved by FDA in 2016 and tremor predominant Parkinson's disease in 2018. And recently they have approved advanced Parkinson's disease with mobility, significant mobility restriction, rigidity, or dyskinesia symptoms. We know all that ultrasound has been mainly used for the diagnostic purposes, but not the therapeutic purposes. Focal ultrasound can produce a discrete lesion in deep tissues of the brain also. Grützmacher, a German physicist, a brilliant physicist, he designed a quartz plate which could concentrate the ultrasound beam at specific point. We can modulate the joules, energy, current, strength, volume, duration, depending upon the clinical response and the conditions. Collimator ultrasound is a big boom for the movement disorder patients. The first appearance of the randomized control trial in New England Journal of Medicine in 2015 have been treated all over the world nowadays. The basic procedure, the lesioning is performed in 3 Hexablate 4000, which consists of multiple arrays with 1024 sonic elements. The stereotactic frame is fixed. A silicon membrane acts as a barrier so that it contains a cold water, good interface to reduce the heating. CT and MRI brain has been co-registered to plan the target. Planning and target localization will be done in advance, and then around 10 to 30 sonications will be given, ranging from 10 to 25 seconds. As the temperature is increased gradually, 40 to 64, but none of our patients received more than 56 or 58. To add these advantages, you can see the results on the table itself. The patient himself are very happy. They can see the tremor stopping immediately on the day itself, unless otherwise in DBS, where the patient has to wait for the programming again and again. But here the instantaneous relief, instantaneous results, that really makes the patients very happy. And of course, it's non-invasive, no anesthesia, the patient will be awake, aware during the procedure throughout. Skull density ratio has been discussed in detail, but 0.4 to 0.6 is an ideal. After the planning, several subthreshold sonifications are delivered to the target area. High power sonication is done with higher temperature. Whole procedure has been done when the patient is aware and awake. This is a mobile unit table with helmet-shaped transducers, helmet-shaped focused ultrasound transducer, and a mechanical positioning unit. This is the helmet-shaped array which contains 1024 elements. Ultrasound frequency is usually 620 to 720 kilohertz. The pulses range from 5 to 60 second duration that are delivered to ablate the target area with multiple sonications. This is the programmable power module that shapes and drives the acoustic boom, as well as a water system that is used to cool the head. Otherwise, the patients will feel the thermal energy. External unit, water storage. This is the schematic representation. More important target, the anatomical landmark in all movement disorders is anterior commissure and posterior commissure is very crucial. And then we make it target calculation, as Vijay and Professor Chang was mentioning, that it's 6.5 to 9 millimeter from the lateral border of the third ventricle, roughly around 13 to 14 millimeter lateral. Homunculus of the thalamus, you could see the VA nucleus of the thalamus. That's what we calculate. We mark the internal capsule very carefully so that the lesion will not happen in internal capsule. Various calculation has been done, the target has been localized, and then the final STR has been recalculated again. This is the MRI thermography. We could see that where exactly we delivered the joules on how good the lesion is and how good is the spreading into the thalamus. There are 4 phases: align phase, verify phase, treat low, and treat high. Each phase is very crucial because we don't want to, because it's a lesioning surgery, we do not want to make a permanent lesion which might potentially cause weakness. Unless otherwise, we have to be very cautious, careful. Repeated clinical examination is done on the table to make sure the patient do not have any sensory symptoms or patient do not have any motor weakness. We recently had a patient who had a transient facial weakness. The face has gone a little bit, the angle of the mouth is pulled. And then we had to wait for 2 days to give steroids because of the vasogenic and cytotoxic edema. On the left-hand side, you could see that the patient was trying to do a spiral. Writing the name, you could not able to do that. The left side, the right side, you can see that the improvement. For the essential tremor, American Movement Disorder Society has formed guidelines. The confirmed diagnosis of essential tremor is very crucial, seen by a movement disorder neurologist. Failure to respond to the first line of therapies. Disabling appendicular score, the tremor score of more than 2. Unilateral treatment has to be done in the first, and then after 6 to 9 months, the next side can be done. It is approval for tremor predominant Parkinson's disease, advanced Parkinson's disease. So far, the targets are VAM nucleus of thalamus, globus pallidus, pallidothalamic tract. I'll keep showing some videos. This is a gentleman who had left hand predominant. You could see that tremor, increase on posture. He had a foot tremor also. The left hand and left foot tremor. After few sonication, you could see the tremor is coming down. It's not completely gone, but the tremor has come down. Another patient, tremor predominant Parkinson's disease, 62-year-old gentleman. He had comorbidities of old stroke and hypertension. For the 11 years, he had this disabling tremor. And then the UPDRS score is very high, 119. The PDQ score is 60. PET scan shows asymmetrical reduction in the dopaminergic activity, especially the posterior putamen. And we've done the target localization. You could see that again. Left hand tremor. Obviously, the tremor has come down now. Gentleman who had a severe dopa-induced dyskinesia, young onset Parkinson's disease on the right hand. He has a chin tremor also, right hand tremor.
How do you feel today, sir? Okay.
This is the post-procedure 10 months follow-up. We have done only on the right hand and right leg. We have yet to do on the left side. You can see the left hand tremor is there, but the right hand is doing well. So we could conclude that treatment is long-lasting and it's also improving. This is one of the gentlemen who came from Pakistan, via Dubai, working in Dubai. He had a very severe dopa-induced dyskinesias, even for a minimal dose. Some Parkinson's patients are very sensitive to the dopamine or dopamine agonist. He had a very severe dopa-induced dyskinesia. And then we made a beautiful lesion. You can see that in all the axial, coronal and sagittal, with the central coagulative necrosis. After many years, he can able to use hand. He can bath himself, he can dress himself. And then jogging in a corridor, hospital corridor. So the dopa drugs have been weaned off, reduced. But on reintroduction of this syndopa, he did not get any dyskinetic movements at all. He is doing well. 10 months follow-up. His UPDRS score was 169. Post-procedure it was reduced to 72. And then PDQ score was also much better. 65-year-old gentleman, right upper limb and lower limb tremor. UPDRS was 37 and the score is PDQ score was 12. Right hand tremor. Right foot tremor also. When he has a significant resting tremor on the foot, not able to walk, not able to put the shoes as slippers. On the table, it's very crucial that you examine and re-examine again and again Until you and the patients are convinced that the patient is doing well, they do not have any significant complications, so that the permanent sonication can be achieved. A 54-year-old male who had a dyskinesia, unfortunately is not focusing very well. Immediately post-procedure, rigidity has come down. The dyskinesia has improved much better. You can be able to do the fisting movements. I'm checking for the cogwheel rigidity. It is almost no rigidity at all. The beauty of the technique is you can see the results on the table itself. Lesioning has been done on the left VAM and PTT. That's there and that. Post-procedure, you can be able to walk well. There is no foot dystonia. The tremor has come down. The gait and balance are also much better. The right hand tremor has disappeared now. In 10 months, he can be able to walk well. UPDRS curl has also come down. A 58-year-old male, left upper limb tremors and lower limb tremors, severe rigidity and bradykinesia. UPDRS score is 97. You could see that he walks with the stumbles as if he is going to fall, and then marked bradykinesia, decreased facial expression, not much of tremor, but he has significant rigidity and bradykinesia. The rigidity has come down on the table, bradykinesia is also improved. Very good lesioning in all the MRI section. Post-procedure day 1, he walks well. There is no need for rushing up. The previous video showed he was rushing to walk here as if he is going to fall. Day 5, finger nose coordination is much better. He walks well. 10 months down the line, he is a happy guy. He smiles, and then the procedure is, scoring is also has come down. 45 years old male, hypertension, left hand tremor, resting tremor. Lesion was done. Can be able to do well in the post procedure. Ten months down the line, the results are sustained, the benefit is sustained, it's not declined. The UPDRS score is keep coming down. Lesion is persisting even after many months. 77-year-old female who had a significant comorbidities of coronary artery disease, and then she had tremors in the both upper limb and not able to write. Hardly she could be able to hold the pen. I was asking to write her name. She could not be able to do that. She has tremor. Resting tremor, lesioning done. You could see that hand movements are much better. Further follow-up, she is doing well. She is writing well. UPDRS score has come down from 151 to 89. 2 months follow-up, it was further 68, and then 10, 12 months, it's keep further coming down to 54. A 74-year-old female has a diabetes, tremor in the left upper limb, shuffling gait and freezing. You could see the left hand tremor. Left hand tremor, postural tremor, resting tremor. You've done the lesioning night in the VAM with a very good central coagulative necrosis. The UPDRS has also come down. Post-procedure score was markedly reduced, 98 to 35, and then the tremor has also disappeared. She is doing well.
And her arm swing at
13 months later, total score keep coming down, the UPDRS score. PDQ score is also better. She is again a 72-year-old lady, severe dopamine dyskinesia. You could see that she could not. She was taking fairly decent dose of Syndopa, dopamine, but her main problem is the peak dose dyskinesia. Within 1 hour after taking the Syndopa, she gets these unwanted movements.
Try பண்ணி பாருங்க மாமி ட்ரை பண்ணி பாருங்க குடிக்காம நடந்து பாருங்க
இல்ல கொஞ்சம் இதுவா இருக்கும் இல்லையா ரிஜிடா இருக்கனால.
When she gets dyskinesia, it affects her walking. Right foot also developed dystonia component. Both upper limb dyskinesias. She is not able to do her routine activities without any dependence. Truncal dyskinesia also. Lesioning was done, and this is a post procedure.
Do like this fast.
We have re-challenged her with the Syndopa and did not get any dyskinesia. She could reduce at least 50% of her medications from the original one. She was taking about 11 to 12 tablets of Syndopa. She has come down to 3 times a day now.
Do both hands simultaneously, ma'am. Both hands simultaneously. Yeah. Wide, open, and close. Open it wide. Yeah. Do it, do it.
We have done on both sides on her, and she is
Now
doing
get up,
really
ma'am.
well.
Now get up, get up. Okay, and make her walk till the door and come back.
She could able to walk well. And then I've recently seen her follow-up. It's almost about 10 months after the procedure. The improvement is sustained and persistent.
கை தூக்குங்க ரெண்டு கையும் தூக்குங்க ரெண்டு கையும் தூக்குங்க.
There's another patient.
இந்த கை தூக்குங்க. கை மடக்கி மடக்கி விடுங்க. ட்ரை ட்ரை.
You see the marked bradykinesia is very impressive. The rigidity is also there. Again, we have done the lesioning on him. Another patient, when you increase the dose of Syndopa, he developed hallucinations and dyskinesia. You can see it on the hand. The video is not projecting well. 13 months later, the UPDRS has come down markedly. He can able to walk much better. "67-year-old male, significant comorbidity, diabetes, coronary artery bypass has been done. A tremor on the right hand. You could see the tremor on the right hand.
Super.
Tremor has markedly has come down now.
திரும்ப நடங்க.
This is 10 months follow-up. He is doing well. Lesioning is still persisting, the lesion has not shrunken. 65-year-old gentleman who had a tremors in childhood. There is a strong family history. The tremor score, CRST score was 86, quest score was 82. We were asking him to write his name and he can hardly able to hold the pencil. Whenever he tries to hold, it drags him. Severe essential tremor. He's been suffering for this for the past 25 years.
No chance.
He was trying to spiral for us. Not able to do that.
Take this.
That's the way he takes his pills. He throws in his mouth and gulps it.
Not the tablet, sadam.
Sadam is also.
It is asymmetrical, more on the right hand than on the left hand.
Usually left means we have more.
He can able to write. This is the writing he wrote on the next day. Can able to drink it with a cup of coffee. We cannot able to do that for the past 20 years. With very minimal tremor. Spiral within the spiral, and then spirals has been drawn on him. Leg tremor has also disappeared for the gentleman. In addition to that hand and limb tremors, he had a chin tremor also. This is another patient we are asking him to write. And able to hardly hold the pen and come to the contact with the paper. He struggles. During the procedure, he can able to draw a spiral. The tremor has completely vanished. This is a patient who had a spinocerebellar ataxia, which Vijayan was talking about. He had a strong family history. Comes from the Agarwal community. I was asking him to draw a spiral. Cannot be able to do that. Can you try to write your name, please, sir? Just give a try. You know that it will be difficult. I was asking him to write a name. Okay. Can you sign the check? No. Try to hold it and then try to drink it, please. You cannot do that, he spills. Spread your fingers, please, for me. After the procedure, the right hand tremor has disappeared. The left hand, we have not done that. Okay, keep the left hand down. Right hand. Okay.
For someone who was finding it difficult to write, look at the precise coloring which he is doing.
This is James gentleman. He sent us
Doesn't
a picture.
this look beautiful? It took him some time to start getting used to the small tip of the pencil, and he does get tired after coloring a little, but that precision is very much there.
Okay. So to conclude our experience, only center so far in India, although the new centers are all opening up in due course. We've done really number 141 patients. The numbers may be a little bit high. We have done few in the last week and before the week. Majority of them seems to be Parkinson's disease, unlike in states and other countries, where they do have a predominant numbers of essential tremor. Our cohort is mostly with the Parkinson's disease. Essential tremor is only number 13, SCA, spinocerebellar ataxia. Distinct ataxia, progressive, we've done 5 patients. Unfortunately, 2 patients, there was significant relapse of tremor has come back after the lesioning. 12 patients were operated on both sides. In comparison with the DBS is reversible. If you don't want to take, you can switch off the machine. It's a well proven over the randomized control trial for many years. Then it can be done on bilateral on the same sitting, unlike in MRGFUS. But disadvantage, there is an invasive procedure. The patient has to stand up with the risk of anesthesia and anesthetic complications. Chance of infection is 5% because the foreign body is placed, the hardware is placed inside the STN nucleus of thalamus. ICH will be there for 1 to 2%, hardware complication 10%. Patient needs to come for often programming. But in MRGFUS, we don't need to do any programming. We do video like consultation, and then we don't need to come all the way from their home. What about the maintenance and the clinical benefits? The meta-analysis of 21 studies in MRGFUS, 61% improved the hand tremor significantly from 19.2 to 7.4. There could be a minimal decrease at the period of 3 years. Chang and Halpern demonstrated persistent benefit up to 36 months, and he showed us a nice figures. The tremor score still was very low. Possible loss of clinical benefit can happen, but it can be attributed to shrinkage of the lesion over the period of years, as we seen in the MRI. Miller reported also clinical benefit over the period of 2 years. The future direction, diffuse tensor imaging based target localization, safety of bilateral lesioning in Parkinson's disease, the trials are all started now. Explore the different anatomical targets. The indication is vastly expanding, not only the tremor and Parkinson's disease, blood-brain barrier breakage can happen, the tumors, Alzheimer's dementia, intractable epilepsy, post-stroke pain, and psychiatric disorders, especially OCD. So to conclude my talk, MRGFUS lesioning is safe and effective treatment for Parkinson's disease, especially tremor-predominant Parkinson's disease. Effects are immediate and they are long-lasting. There is a significant reduction in the dopa dosage over the period of months and years. Dyskinase disappear after PTT lesioning and do not reappear on syndopa challenge. Dual lesioning and sequential bilateral lesioning is also safe and effective. The craving for dopa is substantially reduced. Of course, the quality of the life tremendously improves after the procedure. Very important novel technique. As I said, it's going to be the future of movement disorder intervention treatment. It's well proven, effective treatment in essential tremor and tremor predominant Parkinson's disease. Non-invasive, no anesthesia, no blood loss. Most of the time is done as a daycare procedure. So hospital stay and mobility is very less. Tremendous improvement. But the patient selection is crucial like any other procedures to achieve a good outcome. Thank you very much.
Thank you, Dr. Arulselvan. Now it's time to felicitate the speaker. I request Dr. Manisandil to honor the speaker with a memento. Thank you, Dr. Arulselvan, for your inspiring presidential oration on MRGFUS. Your pioneering work in neurology has truly been innovative, and your insights into the journey with MRGFUS are valuable. We deeply appreciate your time, dedication, and contributions to the field. Let's give Dr. Arulselvan another big round of applause.
In this beautiful evening, we are now at the most awaited moment of this day. Welcome to this special live streaming session of Magnetic Resonance Guided Focused Ultrasound, MRGFUS, broadcasting to you live from Royal Care Hospital. We are delighted to have you join us for this groundbreaking demonstration of non-invasive medical innovation. It is an exciting day as we witness MRGFUS in action right here at Royal Care Hospital, a center of excellence and advanced medical center.
After 10 minutes of break, we assemble again for the live streaming session.
Go ahead. Hello. Check. Hello, check.
Okay.
Ladies and gentlemen, please be seated.
அந்த லைவ் பேசும்போது நீங்க பார்த்து போட்ட வீடியோ போட முடியுமா? நீங்க எடுத்த வீடியோவை அதை அப்படி ஸ்கேன் ஆரம்பிச்சிரு.
நம்ம இது போடணுமேங்க சார்.
ஸ்கேன்
லொகேட் பண்ணுங்க. லொகேட்
ஆரம்பிச்சுக்கலாம். நம்ம ஆரம்பிச்சுக்கலாம். அவங்க ரெடி பண்ணும்போது டக்குன்னு ஆரம்பிச்சு ஸ்கேன் டைம் முடிச்சிடலாம். டக்குன்னு வந்தாச்சா?
நீங்க ஒரு உட்காந்து போடணும். நீங்க இல்ல ஸ்டூல் போட்டு உட்காந்து.
ஹலோ,
குட்டி ஸ்டூல் இல்லை. சரி, ஆர் போட்டாச்சா?
ஹலோ,
Sir, just a second, we'll just get somebody to coordinate with you.
Hello.
Sir, Vijayan sir, can you hear us?
Yes.
Sir, just a second, Dr. Aruchelvan will do the coordination from our end.
Yeah.
Vijayan, can you
Hello,
hear me?
Sir. Yes, sir, I can hear you. Can you hear me, sir?
I can hear you well.
Okay, sir.
Can you hear me?
Yes, sir. We hear it.
Okay.
So we've
So first
recorded
of all,
a video. Yeah. Yes, sir. Please go ahead.
First of all, you explain what was the patient,
Yes, sir.
how long he had the symptoms, what is the indication to do the MRG FUS.
Yes, sir.
You tell us and then I'll take it forward.
Okay, sir. Now, this is Mr. A. He's 56 years old and 62 years old, I'm sorry, and he's a retired army personnel, and he has been suffering from Parkinson's disease for the past 5 years and 4 months to be exact, and he's on about 1000 milligrams of levodopa equivalent dose per day, and he's taking multiple medications, and he develops moderately severe dyskinesias, which are hampering his day-to-day activities. He's not able to socialize, he's not able to move outside. Without the dopa, he becomes rigid and stiff. He's not even able to walk. Even with support, he finds difficult at times. He freezes totally. His right upper limb and lower limb are almost, he says in his own words, feels like a log, cannot move. Tremors are very minimal in this patient. In fact, we selected this patient predominantly to show that fuss lesioning of the pallido-thalamic tract has remarkable benefits for rigidity and bradykinesia also. And again, the tremor of Parkinson's is slightly different from the tremor of essential tremor. Here, the tremor predominantly responds to pallido-thalamic tract lesioning, and we have some innovative approaches here. We shoot the uppermost dorsal and lateral part of the subthalamic nucleus, the pallido-thalamic tract, a medial target, a lateral target, and we grow the lesion dorsally up to the thalamus. And if necessary, we also make another lesion in the vim vivo region, the region straddling the vim vivo. In this patient, we have marked few targets for him. The pallido-thalamic tracts, medial and lateral target. Apart from that, as we had already told in our procedure, we are going to start with the RC2 or Royal Care 2 target, which is approximately 12.5 millimeters away from the midline. We are going to target the lateral, we are going to target the left side of his brain to give his symptom relief on the right side. We have recorded a small video of him. I think we'll play the video now. Please play the video we recorded. Yeah, that's the video. You can see the foot dystonia also.
Right,
He's not able to walk. He's not able to take one step forward. You can see I'm giving a cue. You can see the foot dystonia. In fact, he's been having painful foot dystonias, especially off dystonias, severe painful off dystonias. You can see the significant bradykinesia in the right upper limb. You can see sequentially, in fact, he's not even able to move. In spite of repeatedly asking him to do that, he's not even able to move. He's not able to stand. He's asking him to do repetitive movements. You can see the significant bradykinesia, so predominantly unilateral on the right
more
side.
than left.
The left hand is relatively free. We've done an MRI. The MRI shows significant loss of swallowtail on the left side and severely thinned out swallowtail on the right side. Correlates with his clinical symptoms.
Okay, Vijayan.
Not able to move.
Vijayan,
Sir.
can I interrupt you for a minute?
Yes, sir. Please, sir. Please.
So you've shown the signs of bradykinesia,
Yes, sir.
rigidity, but less tremor.
Yes, sir.
Although we have seen both, the tremor component is very, very minimal.
Yes, sir.
Rigidity and bradykinesia was very prominent, asymmetrical, right hand side only, not much on the left hand side. Do you think that is going to work well? Because we focus more on tremor predominant Parkinson's disease, Parkinson's disease.
That was the initial thing when it came. It was initially approved for tremor-dominant Parkinson's disease,
Right.
with the VIM being the recognized target. We talked a lot about the VIM, VIVO lesioning. We also talked about drug-resistant MS and dual lesioning for VIM and PSA. But once we have switched on to the paradothalamic tract, we find remarkable benefits with the bradykinesia and rigidity. We find remarkably the bradykinesia and rigidity improve with the PTT lesioning.
Okay.
Yes, sir.
And you are not going to do the lesioning on VAM on this patient. Is that correct?
This patient, I think we will avoid the VIM, sir. We'll do PTT, medial, lateral, and we'll try to grow the lesion dorsally up to the thalamus. From subthalamus up to the thalamus, we'll grow it dorsally. We'll try to grow the lesion dorsally.
Okay. For my understanding and audience understanding is, since there is no significant tremor component, we are avoiding the VAM target. We are focusing only on PTT, pallido-thalamic tract, lateral and medial. Is
Yes,
that correct, Vijayan?
Yes, sir. Yes, sir. Absolutely right, sir.
Okay, sir. Thank you. So go ahead.
Yes, sir. The scan is being done now. We've got 6 more minutes left for the scan to go, the live scan. We've already uploaded the planning. You can show the screen. Raghu will explain to you the targets which we have made. I hope you are able to see the screen.
Yeah, we can very well see the screen, yeah. That's right. So Vijayan is showing MRI which was done recently, pre-procedure MRI brain scan.
Sir, இது பண்ணதுக்கு அப்புறம் தான் வரும்.
Scanning, yeah. The scanning is...
Now it is on scanning.
So
we can't see the fiducial which we marked earlier during planning.
The live scan is going on.
We'll show you later, sir.
This is the image you're seeing is the fused CT and MR images.
Yeah.
The MR planning image, which is called as Bravo white matter null image, so that the white matter appears black and the gray matter appears gray or slightly less intensity on this image. It gives a very good resolution of the basal ganglia and its structures, so that we are able to identify the structures and mark them.
Vijayan, you have done CT and MRI
Yes, sir.
co-registration.
Yes, sir.
Yes, sir.
We are taking MRI now and then we will be doing MRI and MRI co-registration. Is that correct?
Yes, sir. Yes, sir. Now you can see on the screen the internal capsule, the thermal boundary for the internal capsule. You can see on your screen also the mammillothalamic tract. That is, you can see the pre-AC and PC which we have marked on the planning MRI. You can see the mammillothalamic tract and you can see the tip of the subthalamic nucleus. We have coordinates for the subthalamic nucleus. We have standard coordinates and also we go by the image. If you want to see the
In coronal.
In the coronal view,
Can I add a word, Vijayan?
yes, sir.
We are tend to avoid 1.5 to 2 millimeters away from the mammillothalamic tract because recently
we go at least 3 millimeter to 4 millimeter away from the mammillothalamic tract, because mammillothalamic tract traditionally is associated with memory, and we've seen that even when the edema, thermal lesion, the edema extends up to the mammillothalamic tract, we have problems. The patients become severely drowsy.
Yeah. There was one patient, we remember that probably the edema spread on the mammillothalamic tract, and then he was sleeping for 12 to 14 hours.
Yes, sir. Yes, sir.
We were really worried. Next day morning, he is still sleeping.
Yes, sir.
So we cautiously avoid the mammillothalamic tract. We move away from 3 to 4 millimeter, minimum 3 millimeter from the mammillothalamic tract, 1.5 to 2 millimeter away from the internal capsule.
Yes, sir. 1.5 to 2 millimeter away from the internal capsule. You can see the images on the screen in the coronal view, and you can see the marking for the subthalamic body, subthalamic nucleus there in the coronal view, and soon you will be seeing the mammillothalamic tract also. That's the mammillothalamic tract
and internal capsule
in the coronal view. So you can see the mammillothalamic tract and the coronal view. This is the internal capsule, and this is the space where we are going to work on.
Thalamus.
Fairly pretty much narrow space, and then that's the subthalamic body here, just above dorsal and lateral to the red nucleus. You can see the same thing on the sagittal images also.
Yeah.
Yeah, you can see it on the sagittal images also. This is the
mammillothalamic tract.
Yeah, that's the mammillothalamic tract. This is the internal capsule. This is the subthalamic body. That's the subthalamic body. And that's the pre-ACPC, and this is the pre-midline.
The MRI scan is over.
Raghu will show you the targets, sir. The targets are appearing on the screen. You can see, yeah. Raghu, please explain
so now
the targets.
we can see the midbrain level cuts. I will zoom it a little bit.
Okay, yeah.
So here you could
the cross sign is a target. You explain
yes,
to them.
target. Yeah. So here we have marked
Raghu, 1 minute. You explain the target. What is the target? And where is the target? What is in relationship with the anterior to posterior commissure?
Usually we mark medial pallidothalamic tract at the midbrain level, 1.5 millimeter below ACPC plane, and this would be the lateral pallidothalamic tract at the level of ACPC plane. So now I am showing you below ACPC plane, 1.5 mm below ACPC plane. Here the midbrain. Here you could see the red nucleus. Dorsally, here we can mark the subthalamic. And here the mammillothalamic tract, a hypodensity. And here we have marked the internal capsule structures. Usually you can see a triangulation, sir, between the internal capsule, mammillothalamic tract and subthalamic area. And it should be in between this three triangulation. And at least with the tools I will show you, sir, we need 3 to 5 mm away from mammillothalamic tract. So here I think we have adequate space, 3.8 millimeter away from the mammillothalamic tract. And with respect to capsule, 5 mm away from the capsule, and with respect to subthalamic area, it's nearby.
We are perfectly safe because we are 4 millimeter, 3.8 to 4 millimeter away from the internal capsule, 3.8 millimeter away from the mammillothalamic tract.
Yes,
so
sir.
potential complications will not happen.
Yes, sir.
It's very crucial. We calculate the target. If the target calculation goes wrong, the sonication might end up in unwanted places or in eloquent areas, which could result in deficit. So each millimeter is very crucial, so that's why they are planning and targeting again and again. Make sure that the target has been correctly localized.
However, during the procedure, sir, we might go a little more inferior also to touch the dorsal and lateral aspect of the subthalamic body, because of late we are also including the subthalamic body also, nucleus also in our lesioning, and we found fairly good results with the subthalamic body lesioning also. We have not encountered any case of hemibalismus as of now, touch wood. And then we'll now show the lateral. This is at the ACPC plane. This is at the ACPC plane. And again, it is usually 6.5 millimeter away from the lateral border of the third ventricle. But in this case, we have marked it slightly a little more lateral. It's I think it's about 8 millimeters roughly from the lateral border of the third ventricle. It's 2.8 millimeters away from the internal capsule and 3.8 millimeters away from the mammillothalamic tract. As we showed you, we respect the mammillothalamic tract, this target distance more than the internal capsule target distance. But of course, we have to respect those boundaries also. Usually our lesion is around 3 to 4 millimeters in the lateral aspect. I think we are safe. We are very safe at this level also. And we are expecting to grow the lesion dorsally, that means superiorly, one cut Malcolm. When we grow superiorly, as you can see, the internal capsule moves away from the target. So we will get a lesion somewhere here. And we are planning to, this is the Royal Care target 2. If necessary, we will go up to there, or else we might stop with this.
I would like to add one more point. The pallidothalamic tract from, this is a midbrain level, minus 1.5 millimeter below ACPC plane. From here, it will go laterally from medial to lateral. So as it grows, we are moving the target laterally. From here, again, it moves laterally. So we try to include all the regions from medial to lateral so that all fibers are included during ablation procedure.
Okay, the next question, the scan is over.
Yes, sir.
MRI,
I think
MRI.
we are going to load.
Yes, sir. Scan is over.
Okay.
We are going to archive the live scan. The image accepts only 150 images, so it exceeds, so we are subtracting images from above and below, 25, 174.
Right.
And we are continuing. It's not different patients. We've added 0 to the number. So there we have loaded the live image now.
So they've reduced number of slices little bit,
Yes,
so
sir,
that we
have
can
reduced the
accommodate.
number of slices. So that machine accommodates 150 slices. And now we'll remove these overlays. These are the transducers overlays we are removing. And Raghu is now just adjusting to find out the exact ACPC, mark the ACPC in the sagittal view. One more.
So in the sagittal MRI, they are marking a anterior commissure and posterior commissure. As I said, in any movement disorder surgery, anterior commissure and posterior commissure landmark is very crucial. That's where to calculate the target. So they are marking the anterior commissure and posterior commissure, and also midline. So they mark the AC and PC, anterior commissure and posterior commissure.
We are zooming so that
we'll be able to identify
exactly
the PC exactly.
Lower border of PC we are marking and exactly at
This is okay.
This MRI they call Bravo sequences.
This is an intra-op sequencer.
24.24.
24.
Vijay, can you please tell us what is Bravo sequence?
The Bravo sequence is in the GE machine is a white matter null sequence, so that it nulls the white matter, so that the white matter becomes dark here, black, and the gray matter remains gray. Now we are marking the midline. We mark the ACPC. The pre was 24 millimeters, and this is also now 24. We first pitched the PC. That's the line which we pitched the PC, and then we pitched the AC also. Now we see to that the midline actually cuts through the tectum, exactly cuts through the tectum and the midline. making finer adjustments.
What was the baseline ACPC? The pre-plan?
24 millimeters. 24 millimeters. It's here 24.04.
Okay, we are the same numbers.
Yeah.
Yeah.
Midline is
The live
perfect.
MRI and the planning MRI. And we'll have to mark the ACPC midline. I think you can see it on your screen, sir. Is this satisfactory for you?
Midline, sir.
The aqueduct is exactly
lying in.
Are you able to see, sir?
Yes, we are able to see. We are dissecting the rectum in the midline. Aqueduct is on the.
We are now showing the upper images also.
Okay.
Upper cuts
So our
also.
midline is perfect.
The midline appears to be perfect. We'll reformat it so that in all the planes, axial, sagittal and coronal. And then once we are done with it, we are going to do the MRI registration. We have already done the CT and the planning pre-MRI registration. Now we are going to do the MR registration, MRI and MRI registration.
This is also very crucial, MRI and MR registration.
Yeah, MRI registration.
Because it would have been done a movement artifact, we could have missed the target. As I re-emphasize again, few millimeters will make a potential mistakes. So we want to completely avoid any millimeter precision.
It's an
is very
automatic
crucial.
registration being done by the machine. Sometimes we may stop it early and we may go for a manual registration also. I think we should stop and go for a manual registration. We are stopping it in between and we are going for a manual registration. Manual registration.
So the MRI registration, co-registration is done on all the planes. So they will be doing it axial, sagittal and also in coronal to make sure that the anatomical landmarks slides well, fits well, so that both MRI looks almost identical.
What we try to do basically is we pre-marked AC and PC, we try to superimpose on the new ACPC which we have marked on the live MRI, and then from that we will take it forward. Going to the next section, the coronal view, and we'll correct the midline in this view. So we have the pre-midline as you can see, and we try to fuse it exactly with the live one. We have to keep repeating it again and again in all the three directions till we are satisfied. We'll go to the this one and we'll slightly bring it down. Bring it down. Go here.
Orbit.
Rotate it.
Midline correct.
Rotate it or bring it down.
Down
to the sagittal. Bring it slightly down. Slightly down. Slightly down.
It's going away.
Little more.
It's going away, sir.
Yeah. Yes, if you see, you got this.
No, it came.
Yeah, it got it. Now you got it. And they should go to the
again coronal.
Correct it. You can rotate it. Rotate it so that we've not got it in the sagittal plane yet. No, a little more. This way. This way. This way.
Vijay, you keep doing the registration.
Yes,
I'll show some of the videos to them.
Yeah, please continue, sir. Please show some of the videos. Once the registration is over, we'll come back.
You will come back to us. Okay,
Yeah.
thanks. Can you switch the laptop? Okay. This is a lesion, olden lesion looks like. This is a chronological order of how the MRGFS is developed over the period of years.
So, Dr. Selvan, the MRI and CT co-registration means the pre-frame MRI, which was done which was acquired much earlier.
Yes.
You are registering that with the frame-based CT and MRI both. That's what you are talking about?
No, we didn't do CT. We are doing MRI and MR registration again.
That's it. There's no CT in between.
No, CT in between. We do have a CTs, but we'll look for the calcifications. They'll show it to us.
The 1880, the piezoelectric effect has been demonstrated. It took about several years until the MRG FES has been come on the line after finding out the quartz by German physicist Gutzmacher.
And as for, and on the two targets that they mentioned, like the on the PTT, the medial and the lateral one.
Yeah.
The medial target is like 1.5 mm below the mid of ACPC line from the MCP.
Yeah, correct.
Okay.
Mid of the ACPC lane.
The MCP.
Plane.
Middle commissural point.
Plane, and then we're going down 1.5 millimeter down there. So the first randomized control has come on 2015, I think so. The new FDA is approved. We already talked about the Helmus system, focus ultrasound transducer system, so it's all repetition. The cooling unit, cooling water is very, very important. When they come to the live, I'll show them. The temperature has to be minimal 18 degree. It should be that cold. If it is warm, and then the patients will feel the warmth. The water system acts as an interface so that the ultrasound waves will not be discarded or will not spread upon, will directly focus on the focal plane. So it acts as an interface system. We talked about the pre-procedure planning, complex calculation. This is the internal capsule, and then roughly around 14 millimeter from the internal capsule to the midpoint of the ACPC line. Again, planning is very crucial. We talked about the 4 phases, align phase. In the align phase, we check the shape and temperature of the location, and then verify phase, we again do the clinical assessment. Once we are satisfied, there is no desired side effects, only the desired effect is happening. There are no unwanted side effects, no capsular effect, no pins and needles, no numbness, and then we'll move on to that treat low because it's going to cause permanent lesioning. And the treat high also permanent lesioning. Each one has got a specific temperature, align phase. We cannot cross more than 45 degree. In the treatment low and treatment high only, we can cross a 50 degree mark, because when we cross the 50 degree mark, there could be a potential lesioning. This is the MRI thermography, we have done that. Exactly size and shape of the ultrasound sonication has been delivered. That's very crucial. This internal capsule is well away from the internal capsule. This is the lesioning. We discussed already about that lesioning surgery, radiofrequency of PM, nucleus of Thalamus. I'll just skip side. The advantage of the MRG FUS is very important, that the sub-millimeter precision, no major complications, because we are not using any anesthesia, we are making the patient awake. Real-time monitoring is very, very important, very, very crucial, and then we can monitor on the table itself. No anesthesia, no incision, no blood loss, almost 100% effective, and it's totally non-invasive. You can see instantaneously the effects on the table. The tremor vanishes immediately, and it's non-invasive nature. Very complex anatomy of the thalamic nucleus we already heard about in detail. Professor Martin is mentioning about this thalamus and its various connections. We use a Hassler classification and corresponds to the inferior aspect of the ventrolateral nucleus in the Hirai and Jones classification.
Hello, sir, am I audible?
Yes, Vijayan, you can go ahead.
Sir, we've just finished the manual registration, sir.
Okay.
Raghu will now tell you the bony landmarks.
So actually we have to check in all three axes, axial, sagittal and coronal. So for example, in axial plane, you have to check the bony landmarks at the level of orbits, petrous bone, internal IAC, jugular bulb, sinuses, so everything you have to see. Here you could see.
You can see that the internal auditory meatus is well aligned. We can see the jugular bulb, you can see the sinuses, and you can see the orbits also well aligned. In the axial plane. In the coronal plane.
Now we are going to coronal plane.
In each plane we have a set of anatomical targets as they clearly mentioning.
Yes.
Axial we will be looking at the optic area and also the internal acoustic meters.
Coronal plane we are looking at the orbits. You can see the sinuses are well demarcated, the orbits are well demarcated. And then in the sagittal plane will be predominantly focusing on the clivus, the sella, and also the sphenoidal ridge, anterior sphenoidal ridge. You can see that he is showing you. So it's well aligned. So once it's well aligned, we reformat it again.
So everything perfect. So we'll go for reformat
It's
again.
all perfect. And then we go on to mark the targets. We're going to mark the live targets now. We'll start off with the medial PTT. Raghu, it's minus 8.5 from the midline. And it is 8.5 millimeters and it's 10.5 millimeters anterior to the PC, and it's minus 1.5, that is it is 1.5 millimeters inferior to the ACPC plane. Now you've entered it.
We have entered. Now it is giving
and you can
discrepancy
see,
between the transducer.
You can see on the screen. Yeah.
So now we have given the values for ML, medial lateral, AP, anterior posterior, SI superior inferior. So after giving the targets, it is showing some discrepancy with respect to the patient head and the transducer.
This was the pre-marked target and this is the new target. Now it's well aligned. It's another internal verification assessment. Internal verification saying that our target is well aligned with the superimposition MRI registration has been perfect. So we get this is the cross is the pre-marked target, and you can see the round target area, which is the new values which you have entered in. Yes, go on, Raghu.
So now it is showing some discrepancy with respect to right to left and with respect to anterior posterior and superior inferior.
The discrepancy what Raghu is telling is if you want a good lesion, the target should be at the center of the transducer. You know that the transducer is a curved structure, it's a dome. If the target is at the center, all the incident angles would be perfectly aligned and we'll get a very good lesion at that point. So to align the target to the center of the transducer, we'll have to correct these values. You see the right side, the right, left, the transducer, we'll have to go mechanically inside and correct the values. We'll have to adjust the right, left orientation, right +8.
+8.
Antero-posterior, it shows 5.7, we'll do +6. And superior, yes, it shows 4.3, we'll correct +4.
So now we are going to correct this.
Can you go in the MRI console? Can you follow the camera can follow it? Can the camera follow it? So they are going into the MRI console. As I said, very important that so they are doing adjustment. The AP, medial and lateral, superior and inferior. So as Vijayan and Ragraj said, that there should not be any mismatch in the target area. It has to be clearly focused. So they are adjusting millimeters. This is what the silicon membrane filled with the cold water. It will be circulating. and then they are adjusting a few millimeters. Make sure there is no discrepancy. This is stereotactic frame, and the patient is lying there. There will be monitoring, pulse oximetry, blood pressure monitor will also be there. So they have adjusted it. A patient attender can also be inside the MRI room because there is no radiation exposure.
Yeah. Actually, nowadays, can you hear me, sir?
Yes, I can hear you, Vijay.
Nowadays, we are allowing the patient attender to be with the patient, hold the patient's hands and talk to him during the procedure. So most of our patients are very happy during the procedure that their attender, now in this case, his wife is there with him. She is there and she is talking to him.
Okay.
So he is more comfortable. Now we are going to locate the transducer again.
Can you locate the transducer
Yeah,
and show us?
Raghu is locating the transducer again now. And then we'll have to wait for the scan to be done. It will be done in a few minutes. And then you will see the new numbers, the new realigned numbers on the screen.
This will take a couple of minutes. You can see the cooling of the temperature should be less than 18 degree.
It's
and then
already 16 degrees, sir.
The oxygen, dissolved oxygen should be less than 1.5. Is that correct?
It's 0.82, sir. It's 0.82 here.
Okay.
Papers say that less than 4 itself you can produce a good target. We target at least less than 2. In this case, it's 0.8. It's very good.
Very good.
And the cooling we have reached 16 degrees. And you can see the new numbers on the screen. Left is 0.9 millimeter. Anterior is 0.6 millimeter. And inferior 0.1 millimeter. We accept this. This is less than a millimeter. And then the stop sonication button is being pressed, and then we'll go on to the protocol, treatment protocol. Before that, we'll identify the calcification. What Raghu is doing is to bring the CT on your screen. The CT is on the screen and he is now adjusting the contrast so that we see calcification image. The system automatically marks the calcifications. We don't allow ultrasound waves to pass through calcifications because it may produce local heating there and thermal damage. So these red circles which you see are no pass zones for the ultrasound. So the ultrasound waves do not pass through these red circles so that these calcifications and overheating in unwanted places is avoided.
So it is a choroidal
what
calcification. The
Yes, sir.
ultrasound waves can be scattered so that
Yes,
we are
sir.
marking the areas to avoid ultrasound.
Most of it the system automatically marks. If we have any doubts, we can also mark new ones as what Raghu is doing now. He is marking the areas which he feels could be calcifications.
So now it is okay.
And that's okay. We are satisfied with that.
Now we are going to the
We're
MRI.
going back to the MRI and we're going to mark the movement detection fiducials. Though the system can detect automatically movement, we do have fiducials marked, and we mark the fiducials in the maximum contrast areas between the CSF and the brain, where we have maximum contrast, so that in case there is a movement, we can go back and verify if there is a movement or not.
This is absolutely crucial because if the movement happens, we need to change
Now
it
we are
all the
checking
target again.
Membrane folds.
Now Raghu is checking the membrane folds. Sometimes membrane folds can be there within the transducer. The membrane folds contain air, and so we don't want ultrasound to pass through the membrane folds. A little small membrane fold there, so we are again marking no pass regions in that region, and most of it is free of membrane folds. So we
So
now
we are okay with it.
we'll be proceeding to the treatment protocol. We applied the treatment protocol. We'll have to wait for the numbers to come on your screen now. The database is being updated. That is the, yeah. And now we got the
treatment panels scheme.
Now, it's the new calculation. The skull score or the SDR, you can substitute that for that. It's 0.48. It's a very good skull score, SDR. The skull area is 364 centimeters square, through which, that is the area through which the ultrasound waves pass. We have 942 elements on. It's a very good number of elements out of 1,200 elements. Okay. Now, he will show you the elements. You can see the elements on, and you can move it. As he moves, you can see this is how the ultrasound waves are going to reach the target. And he is also going to show you the elements off now. These are the no pass zones for the ultrasound waves. So these red lines are the no pass zones for the ultrasound waves. And we have very good SDR in this patient. So we're going to do the first sonication. We're going to do the alignment phase now, 0.48. So we have previous experiences with this. So we start off with, we say 3000 joules.
Okay, sir. Yeah. We'll start with
3000 joules in this case. 11 seconds and 300 watts is the power. We are checking the axial, we are checking the RL, so we are checking the right-left orientation of our sonication. So we're going to sonicate first for the alignment.
So we have 4 phases: alignment phase, verification phase, treat low and treat high. So now we are in the alignment phase.
Here you can see the temperature, it do not go beyond 46, and then expected temperature delivery will be around 41 degree. We will see how much it delivers. This is the first sonication done in aligned phase. We will be seeing shape, size of the thermography to make sure that it goes into the target. The cooling temperature, the temperature is about 16 degree. Dissolved oxygen is I can't see the numbers, 0.86 is it?
The sonication is started. You can, this is an artificial sound produced.
It updates movement detection images.
Detection images are being done every time. And the update, again, updated movement detection, it shows that right 0.4, anterior posterior 0.2, and inferior superior 0.4. So if there is not more than a millimeter of movement, then the system allows you to start the sonication. Sonication is now in progress.
We'll be giving at least 9 to 10 sonications like this before the end of the procedure. So we started with the first one.
You can see the graph, and you can see the average temperature rising gradually to 42, and we have touched 44 degrees Celsius. The average temperature, the maximum temperature is 47, and the volume of the lesion, estimated volume of the lesion is less than 40 cc.
How much temperature you achieved, Jain?
44, sir.
44.
Average temperature 44, maximum we have achieved 47, so we'll reduce it to 44 and we'll see the lesion. The lesion is bang on the target, and I think this is a perfect lesion, but we'll also reduce the temperature and see how the lesion is expanding. It's a very beautiful lesion, and it's expanding very nicely, and there is no smearing of the lesion. I think we will accept this. Is it okay, sir, with you?
It's perfectly fine.
Yeah.
It's very well in the target.
We are continuing.
It's not going into the internal capsule or MCT.
Usually we'll have to do alignment in all the 3 planes. Because of our experience, we straight away move to the verification stage. Here still we don't go above 50 degrees. So we got a temperature with 3000 joules of about 43. So I think we'll go up to 5000 joules now. We've seen that in axial plane we can see two levels of verification. One is in the anteroposterior direction and also in the right-left direction. Since we were satisfied with both the anteroposterior and right-left, we are now going to coronal plane where we can again check the right-left, as at the same time you can check the superior-inferior extent of the thermal lesion also. So we fixed it at 4,500. I thought 5,000.
Okay. So we'll
go to 5,000, 500 joules, 500 watts.
11
the
seconds.
coronal RL we are doing. Usually when we start off, we always have to check the alignment in all the three planes and then go on. But in this case, we got a very perfect lesion. We are satisfied because of the experience we have with more than 144 procedures. We are proceeding to the verification phase straight away. Sir.
We are seeing the target temperature above 49 and 51. We are achieving to probably by 50 degree we can come this time, isn't it?
The estimated temperature it shows at 49. I think we will be able to achieve somewhere between
48.
48. Raghu is betting on 48.
Yes.
Predicted temperature 48. We will see. Generally, the temperature goes up beyond 50, we can expect potentially the lesioning has happened. So 50 degree, above 50 degrees, very close.
We are safe. We are always safe, less than 50 degrees. And since this area is a very safe area and we got a very good thermal image in the ACPC plane, in the axial plane, now we are moving on to the coronal plane and I think we will get somewhere around 48 or 49. That's what we expect now. Let's see.
So less than 50, irreversible damage.
The sound is not coming.
Any side effects happens, we can recover again.
That sound is not coming, Vijayan.
The sound is, am I audible, sir?
No, you are audible, the sonication sound.
Yeah, sonication sound. I don't know, sir. Now we got an average of 47 degrees Celsius and a maximum temperature of 49. It's still reversible. Now we are going to see how the lesion has been made. And we are more bothered here in the superior inferior plane. So the lesion is slightly superior. Now we can do two corrections here. We're going to do a correction here because it's shooting superior. If Raghu is placing
the center of the lesion.
The center of the lesion, you can see the coordinates here above. This is minus 0.3. So we actually kept it at minus 1.5. It's shooting slightly above. So we got to correct this. So we are correcting in two ways. You can correct it in two ways. We're going to correct it both ways. We're going to first place the target in between. So the correction is there. You can see, you can accept or reject the correction. We are accepting. Raghu is accepting it. We continue. At the same time, I feel that we can go down by 0.5 millimeters. Raghu?
Yes, sir.
We can go to -2 in the, so we open the spot coordinates, we are going to -2. Here we are still safe, I believe we are still safe, so we're going to -2 now.
The second sonication did not go as planned very well, so that we are just adjusting the targets now.
2.5.
We're going to -2.5. And then we are going to do one more verification in the sagittal plane because we have made a correction in the superior inferior direction. So we are going to shoot in the same thing. We'll change we'll slightly, because we are shooting at the same spot, we are making it 6,000 joules and sagittal,
yes, sir.
AB please, so that
yes, sir.
AP please, so that we are going to see SI.
Yes,
we are going to measure the SI dispersion of the lesion again because we made a correction in the superior inferior direction.
Expected temperature around 50 degree. After doing the sonication, they will go and verify the patient to see whether any improvement or any complications has happened. So after this sonication, you will go and examine the patient. Is that correct?
Yes, sir. We are planning to go in and examine. I think we expect something around 49-50 this time.
This is the third sonication, On average, we will be giving around 10 to 12 sonications.
Yes, sir.
And then the temperature above 50 degree, one could expect the potential lesioning could happen.
The green circle you're seeing is the estimated area of spread of the lesion there. And you can see it occurring one plane below also. That's what we want, one plane below, so that we touch the dorsal most part of the subthalamic body also.
The sonication has started now.
We got 51. I thought we'll get 49. It's okay. We'll see the extent of the lesion now.
Okay. This is we achieved 51, is it?
Yes, sir. We
Okay.
got an average of 51. We'll check the lesion in the superior inferior direction now. I think it's perfect, sir. We've got a
No,
very
perfect
perfect
alignment, yeah.
alignment. It's almost where we intended to. The center is minus 2.2. We are comparing it with the RAS coordinates, with the MRI coordinates.
It
So
is a 0.22.
I think we've got perfectly this one. We can proceed, but before proceeding, we'll go and check the patient and come.
So they are going the MRI console, clinical examination will happen. You can already see a lot of improvement on the hand. The rigidity has markedly come down. Bradykinesia component is improving. Repetitive movements has increase in exertion, amplitude, and coordination is much better. They are testing the right leg rigidity. It's almost floppy now. The tone has come down markedly. He is testing for the weakness and numbness sensation because it's very close to the internal capsule. Just make sure that there are no inadvertent weakness might have happened. The patient's wife. So the attendants are very, they are inside the MRI console also. There will be a continuous monitoring.
Sir, am I audible?
Yes, Ajay, you are audible.
I think you would have seen the remarkable improvement already.
Exactly, yeah.
The patient has himself said there is a 50 to 60% improvement. I felt it was even more. Even previously he wasn't even able to move. You can now see on the screen, Raghu is showing you on the screen the lesion that has been made. This is what Kevin showed you during his talk. 18 CEM or cumulative equivalent minutes at 43 degrees Celsius. Actually,
that's correct.
We've got a small lesion. I mean, this is not a thermal lesion we've got. If you see this, it is 50% of the time you have made a lesion, you are sure. Now we are not satisfied with this. We are going to make a full lesion here. So Raghu is moving on to the treat low phase. And since we got 51, we would try to achieve something around 54 to 55, even 56.
55.
So 5 degrees more, we're going to double the, yeah. We're going to increase the duration to 18 seconds. We're going to increase the power also.
How much energy?
Sir, we are keeping a little, we are being generous here. we are delivering 11,000 joules, but since we have a duration of 18 seconds, we can stop it also anytime. And we are going back to the axial plane, axial AP. So we're going to see the right-left dispersion of the image.
Okay.
Raghu is sonicating now.
Now they enter into the treatment part because there were no side effects, no anesthesia, no weakness. So increasing the joules energy to 11,000.
55.
Expecting the temperature to be delivered around 55
Yes.
degree.
Now you can see Raghu's hand is on the stop sonication button. Here we can also stop the sonication anytime. So we have 18 seconds to go, and if we reach 54, 55, we are going to stop. We are going to stop.
Okay.
Suppose if we reach it early.
Okay.
The movement detection images are again getting updated. So it is, yeah, go ahead.
It also no need to worry.
Yeah. What he says that there won't be much of a thermal spread. The lesion is, we're getting perfect lesions in this patient.
Okay. Everything going well so far.
Yes, sir. Touch wood.
Yes.
We'll be having a close look at the volume of the lesion also. If the volume of the lesion is well below 50, estimated volume, we will allow a higher temperature at that region. Okay. That's been our experience till date. Yeah, we've achieved 54 degrees average, maximum temperature has been 58 degrees, and the volume of the lesion is 51. I think we're going to get a very good lesion there. We'll wait and we'll see the accumulated dose at that level now. Okay. I'm sure we'll get a 240 CEM.
Yeah.
Yeah, at 54, and you can see the lesion. As planned, we have touched the dorsal part of the subthalamic body also. We'll press the continue button and we'll see it in all three directions now. We've got a very beautiful lesion there. You can see it on your, sir. Is it visible on screen, sir?
It is visible. We could see the dark blue.
Yes, sir.
Lesioning. So the lesion has already happened.
So dark blue corresponds to CEM of 240, sir. Maximum which is possible.
Possible. And we've made a very good lesion there. The light blue one around corresponds to 18 or 17 CEM or cumulative equivalent minutes at 43 degrees. 50% sure that there's a lesion there also. Just touching the dorsalmost aspect of the subthalamic nucleus. Since he is remarkably benefited, we'll go and check in again
and we'll come for next sonication.
Okay, they're going to go to the MRI console.
One more sonication to make a bigger lesion in this area.
Okay. They're checking again to see the improvement. So at 55 degrees Celsius, you had a lesion. There is a further improvement. You can able to see the bradykinesia component is markedly improved. Supination pronation is reasonably good. Finger flexion is very lucid. The stiffness is gone. It's almost very floppy. There is a tremendous improvement in the leg also. We are asking him to go to right because he cannot able to write the pre-procedure phase. He's drawing a spiral. He's nicely shown. Oh, beautiful, fantastic. So, he's written the name, signature, and spiral perfectly. He could not able to do that. Vijayan was testing for motor weakness and plantars. There is no obvious weakness or sensory loss.
Sir, no sensory loss. No sensory impairment. Motor power is normal. And
Yeah.
sir, did you appreciate that the dystonia is gone in the leg?
Exactly. Can you show the foot again?
Yes, sir. Please show the foot again.
You can focus from there.
And the foot coming.
We can see that. The
The
right
dystonia
foot
is
was
totally
dystonic at start with. You see the right foot dystonia has markedly come down. We'll see further as we go along. Okay, sir. Are we moving to the different target now?
Yes, sir. We are going to the lateral target.
So now we are satisfied with this lesion. We'll move to lateral
Lateral
target.
target. Lateral is 10 millimeter away.
So we have first targeted the medial PTT, medial pallidothalamic tract. We made a satisfactory lesion. We made a clinical improvement. So we are moving slightly to the lateral part of the PTT, pallidothalamic tract, and then we'll see the lesioning again.
Is okay, sir? 10.
Okay. We are moving on to the lateral target. We'll again start on with 3000 joules.
You point out where is the lateral target here?
Sir,
Is this one?
this is the lateral target.
Right, okay, okay.
We are starting with 3000 joules again as we did in the previous.
So lateral is 1.5 millimeter superior, anterior, and lateral.
Okay, we are not doing only lateral, we are going a little bit superior also.
Yes, sir. 1.5 millimeter superior, 1.5 millimeter lateral, 1.5 millimeter anterior.
Right. Vijayan, while you are on the line, can I ask our distinguished members of the audience, we have some of the experienced
Please,
in
sir.
ultrasound. We'll ask Dr. Pradeep, Dr. Asogan sir.
Yes, sir.
Okay. Give a mic. Anand. Mic, Doctor. Dr. Pradeep sir, you have tremendous experience in ultrasound. You are a very good neurosonologist. What do you think about this one? Angarkar, red color t-shirt.
Question, please.
Do you think the technique is going to replace other movement disorder surgeries?
Yeah. Thanks, Dr. Arul, for asking me to give an opinion. See, ultrasound has been my passion for so many years, you know.
Exactly.
Anything related to ultrasound is very passionate to me. And, you know, what is the beauty of this is, I'm answering your question, this is going to revolutionize the management of movement disorders. Anything in medicine, it is the primary intention is primum non nocere. That is, you should not, by your this thing, create a problem. And ultrasound is such a non-invasive thing. And it does not create, you don't, as has been discussed in the previous lectures, as well as in your presidential oration, you told, there is no surgery, nothing is happening here. So, now by what human beings need is a procedure, non-invasive, which can correct the problem. Any such problem, procedure will be welcomed by the whole world. And I think this is a fantastic thing, and this is going to be I feel this is going to be the future of movement disorders. And for that matter, for any disorder, even in any disease, if it can be corrected by high frequency, ultrasound, high energy focused ultrasound, will be going to be the futuristic management of these disorders. Excellent results, as what you're showing now is really great, actually, as far as the thing is concerned.
Thank you very much, sir. Thanks. Thanks
So
for
good.
coming all the way. Thanks, sir.
So now we are going to verification
Thank
phase,
you,
sir.
Sir, 1 minute.
Okay, sir.
Okay.
I'll come. No. First of all, I should congratulate you for introducing this novel technology. That's what we have been taught, this focused ultrasound causes permanent lesion. DBS is not so. Is that correct? Number one. Number two.
Yes, sir. It's not lesioning. DBS is stimulating.
Stimulating. This only difference, main difference is permanent lesion. There is we are only stimulating. We are not making any lesion permanently.
Yes, sir. Yes.
And thing is, this permanent lesion, how long it is going to last, and will the symptoms recur after some time? Probably need follow-up. But what it may be, the results are very obvious and very satisfying, very gratifying. Thing is, if that is so, without surgery, non-invasive, no surgery, should do well. Satisfying both for the physician and for the patient.
That's correct.
Thank you. Thank you.
Thank you, sir. Thanks.
Sir, congratulations. It is shocking. See the results. It is highly appreciated for your team. So, all the way, thank you, sir. I want you to open the more centers in India so that to facilitate around India.
Definitely.
Thank you.
Definitely.
I am from Hyderabad. We look forward to a joint venture with your team.
Yes.
Thank you.
Definitely. Thank you, sir. Vijayan.
Sir, we are doing the verification in the coronal section, coronal plane now.
Yes.
Ashwan sir is my teacher's batchmate, so he's also like my teacher, so I'm little jittery in his presence. Even if he speaks, I am spellbound.
Yeah, he appreciated this. So this time was on the lateral target, and then we achieved how many temperatures? Celsius 44.
46 we have achieved, sir. It's again shooting little superiorly. I think we will accept this because we want to grow the lesion dorsally. We want to grow this lesion dorsally. You can put it at the center. Okay. Now we'll accept this, and we're going to go to the, we're going to again do a verification, one more verification at this level. So we go to 6,000 joules, 12, 11 here. So we're going to 6,000 joules at this level and do one more verification in the sagittal AP.
Yes, I will.
So we'll see again one more verification in this. We have 12 seconds estimated tissue cooling time. Luckily in this case, we are having very short cooling times, expected cooling times, and we are able to sonicate, and we are also, in this patient, it's not always so rosy. Sometimes, as you mentioned in your talk today, we've gone up to 1 a.m. and all. We started at 7 p.m. and went up to 1 a.m.
Yeah, in between we had dinner also.
Yeah.
Patients on the MRI console, cooling.
In another 10 to 15 minutes, I think we'll be finishing.
I think we'll be finishing the procedure in 10 minutes.
While you are sonicating, can I ask my younger neurologist, what do you think?
Yes, sir. Yes, sir.
Please.
Okay. Dr. Sambat Kumar. Mic. He's a very good, brilliant neurologist. He's trained in Christian Medical College, Vellore. He's a busy practitioner in Erode. Thanks for coming, sir. Please share your thoughts.
It's a wonderful result, sir. It's actually very satisfying for the patient and family. We have been treating Parkinson patients over the years with only drugs, and patients asking for, is there no permanent cure? I think this is going to be a great opportunity for the Parkinson patients with disability, who couldn't who are dependent, who couldn't go for their work. So this is definitely going to be very useful method of treatment.
Okay, sir. Thank you very much. As you correctly said, it does increase the quality of life. importantly. We know that we cannot reverse the disease process. We cannot also arrest the progression of the background deterioration of the Parkinson's disease. We offer symptomatic treatment. We are offering only thing we don't know how long it's going to last. The available data in the States is only for a period of 5 to 6 years. In the 5 to 6 years, 70 to 80% of them maintain their benefits and sustaining their benefits up to the period of 5 years. Beyond that, we don't know. So only the time will decide, time will tell us. Vijayan. Sir, Michael.
Disorder registry. That is very, very important.
Movement disorder registry.
That is very important because the number of cases all over thing is increasing, and young Parkinson's patients are coming more and more.
That's correct.
That is the thing. One thing, because I am involved in so many things. Stereotaxis started in MMC.
Definitely.
That's the thing. Movement disorder registry, and that is you have to motivate the neurologist. The patients are coming mostly to the neurologist because neurosurgeons partly involved the thing. Most of the cases are managed by neurologists. Being a neurosurgeon, my aim is to spread all over thing. Especially in Tamil Nadu, it is possible.
Oh.
See, I request the few government doctors have come.
Yeah.
They have motivated the government. The government will do it immediately. There is no financial constraint for the government, and we can talk to them. And this is a non-invasive thing.
Definitely.
See, my question is only one question. See, 5 years follow-up, 6 years, it is repeatable. See, you can do the ultrasound once again, you can repeat. That's what I think. Whether any experience of the foreign delegates they are doing for so long time,
Yeah.
what is the time in which they have repeated the same procedures for the patients with some...
Theoretically, it is possible to repeat the
yes,
procedure.
that's what there's a
We can do the
repeatable-
deep brain simulation
Yes,
once the patient has done this one also.
Yes, that's the thing.
And
Second-
how long after, we don't know. We have a follow-up only 6 years, 5 years. The sustained benefits is lasting for about 4 to 5
I
years.
congratulate for the initiation of doing this thing, Royal Care Hospitals and
Thank you, sir.
all the members of the thing. Thank you very much.
He is Professor Sundar. He is the first neurosurgeon in Tanjavur Medical College. He is retired as the director of neurosurgery from the Madras Institute, and then he served further in Omandurar Medical College for many years. A very distinguished neurosurgeon, Professor Sundar, sir. Thank you, sir. Thanks.
I think this will be the final sonication.
Sir?
On to the trade low phase.
Oh,
And as you can see, we have covered the entire target.
Hit the mic.
And we have also reached the thalamus. From the subthalamus, we've reached the thalamus also. Let's see how the lesion comes. Maybe this is the last but one or the last.
Dr. Selvan, the lesioning is really dramatic, like compared to the DBS thing. Like, I mean, the procedure is much faster.
Yes, sir.
So we do kind of 2 cases of DBS. Now it's much more very impressive. The long-term results are good, definitely, like it's going to replace this in majority of the cases. My only concern is like when the patient has symptoms on both sides.
Yes, sir.
So are you going to lesion on both sides at the same time, or can we do it later? How are you going to plan the treatment part?
We are licensed only to do unilateral so far. Bilateral lesioning can be done after a period of 6 to 9 months, but not on the same sitting. A sequential lesioning can be done once we have done now, so we need to wait for 6 more months to do the other side lesioning. We cannot do bilateral simultaneously. But there are trials which is going on currently, bilateral lesioning. As Professor Chang said, bilateral lesioning do have a potential risk to develop ataxia, dysarthria. So we have great concern. And sequential, we have done about 10 patients so far, except 2 patients who had a marker ataxia. None of them did have any significant complications. The one patient ataxia was really worrying for us. because he came with walking, he cannot able to walk. It was lasted for 4 weeks. And it was a potential serious complication. But after 4 weeks, he slowly improved and now he is fine. So simultaneous lesioning is really worrying. So we need to wait for the more results to come. At present, we are doing only sequential. Do it, wait for 6 months, and then do the another side.
So, do you, in any patient that you have done lesioning, like, did you ever have to do one-sided DBS and the other side lesioning kind of treatment plan? For
No, we did not experience so far. But we had some more inquiries from the patient who had a DBS, and they found it had improvement, whether they can have it done this procedure. We don't have any much experience, but we said we'll give a try. But Professor Chang has showed one patient who had a deep brain stimulation with the electrode in situ. He got able to do that MRG a few years. So it is perfectly feasible, but we have not come across any patient. We don't have experience on that one.
Sir,
they can be complementary, like in some cases, probably few cases.
Yes, yes, it could be potentially complementary.
Okay, thank you.
Thank you.
Sir, can you please ask Dr. Chang whether, what was the electrode? Was it the latest Percept RC? Was there any difference in the electrodes? Is there any difference in the electrodes between the Percept RC, which is the latest one, and the previous generation DBS leads? Hello, sir, can you hear me?
Yeah, I can hear you. I didn't understand. I thought you were answering the question. I'm sorry.
I thought Professor Chang, when he showed that in situ, electrode in situ, he said it was a Percept RC, the latest one from Medtronics.
Exactly, yeah.
Yeah. The previous versions also, can we do, are the electrodes the same for both these?
The electrodes are same, but Percept RC is a loop system. Are we sonicating now?
Yes, sir. We're waiting for the cooling, tissue cooling. We're going to do the last sonication. We thought we'll make slightly bigger lesion. We'll grow the lesion a little more dorsally up to the thalamus so that, and we're not going to go to the Vim Vivo today. We're going to finish with this. I think he's experiencing a remarkable benefit. In his own words, he said 90%. So I think we're going to stop with this.
Okay.
But for us, clinically, it seems 100% better.
Yeah, we feel it's almost 100% is better, 100%. We're going to stop with this sonication. Even if we achieve slightly more than 50, we're going to stop here. We're not going 50 ml on that. 52. We've got 1 more minute of cooling time.
Any questions from the floor? One.
Dr. Guru Prasad from Bangalore.
Nice to see you, Guru.
Thank you.
Thanks for coming.
Thank you. Excellent work. Congratulations to the whole team from bringing this technology to India and Coimbatore being spearheading this campaign of MER.
Thank you.
Did you see any opposite symptoms, ipsilateral symptoms? You do left-sided lesioning, focal ultrasound. In disease like Parkinson's disease or essential tremor, did you also see benefits on the same side?
Yes,
Dyskinesias definitely disappear, sir. The dyskinesias sometimes even with unilateral PTT lesioning, they disappear on both sides. Of course, in certain cases, we had to do the opposite side also. But dyskinesias, yes, they can benefit bilaterally. In some cases, we have seen reduction in the tremor, but we are not able to explain how.
We cannot understand the physiology, but clinically we felt some improvement on the contralateral side also.
The lesioning, earlier generation lesioning also, some of the studies have shown bilateral symptoms. That's the reason why a lot of patients probably would have done better only on unilateral lesioning.
Yes.
Only if required, they do the an opposite side. So
Yes, sir, you're right,
that way-
absolutely right.
Some of our patients did not want the other side to be done because they are perfectly fine. Why do you want to come? I'll reserve it for later stage of the life. So as you correctly say, unilateral lesion also produces improvement on the bilateral symptoms.
Right.
So unless otherwise patient insists, we don't do that routinely.
Right. So now it's been 2 years. In your experience, is there any recurrence of either tremors
Yeah,
or bradykinesia?
we do have recurrence in handful of patients. As Vijayan was mentioning, the spinocerebellar ataxia 12 type, the hand tremor was markedly improved, but after 2 years the tremor has reoccurred. So SCA12 is not doing very well.
Right.
Whereas the essential tremor, they have done very well. In one patient, he was a chronic alcoholic. Then the tremor has improved well. Then he consumed the alcohol again and again. Continuously, the tremor has reoccurred. We had to do the re-lesioning again. In the Parkinson's patient, we found an improvement, majority of them in 70 to 80% patients.
Okay.
We did not see any recurrence except in one patient. Overall, our recurrence relapse rate is only less than 5% in selected individuals. Spinocerebellar ataxia, we know that it's a progressive disorder. There was a transient improvement for 2 years and then tremor reoccurred. Ataxia was worse because of the background deterioration. So we did have recurrence, but it was very handful.
Thank you, sir.
Sir, as you can see, we have grown the lesion dorsally from the inferior most part. This is 1.5 millimeter to 2 millimeter beneath the ACPC, almost 4 millimeter beneath the ACPC plane, and then we've gone here, and then we've gone laterally, and then we've got a 17 CEM in the dorsal most aspect of the thalamus, which is 3 millimeter above the ACPC plane. So we've done a large lesion, you can see, and I think we're not going to make any further zonification. You can see this on coronal images also. You can see on coronal images the lesion, the medial and the lateral targets, and also grown up to the thalamus dorsally, and this is in the sagittal plane. So we are completing the sonication, sir, and we are going to do a scan now to verify the extent of the lesion produced. 10 millimeter. 10 slices, 1 millimeter.
We have 6 minutes cooling time, isn't it?
Sir,
But scan can be taken.
we finished, sir. We're just doing a scan. We're just doing a post procedure scan now.
All right.
One is Sach Buddha. Sach Buddha, Sach Buddha.
And how about the how much the drug dosage of Syndopa that we are going to bring down, like after the lesioning? Is it much better than what we observe, what we are able to do with the post DBS?
Yeah, it is the results are similar. We can reduce up to 50% of the dosage, but not immediately over a period of months. We do not want to immediately to cut off. So we will wait for a few months, a few weeks, few months, and then gradually reduce it. Generally, we can able to achieve up to 50% reduction.
Okay. So
For example,
compared to post DBS, like is it any better or it's by and large the same?
The results are similar only.
Okay.
Results are similar only.
We are doing the scan now, 3.5 minutes, and then we are done.
Okay. Kevin, can I ask you a question? Kevin? Okay. You've seen several centers all over the world. You've been in the Taiwan, Japan. Do our results are very comparable to that Southeast Asia, or do you find it any different?
So first of all, I really appreciate your work and your team's work, and I see a very successful treatment. And I think for Southeast Asia, this modality is also compatible. But one of the things we see from the technical standpoint is still the SDR. But just like today, we share some of best practice of low SDR treatment. So in general, this modality is very feasible to be implemented in Southeast Asia.
Okay. Yeah. Thank you very much.
Thank you.
So I understand the results are comparable.
Yes.
Okay, thank you. Vijayan, are you there?
Yes, sir. Can you hear me?
I can't hear you, sir.
Sir, I'm ready to go in. Raghu will show you the final scan now.
Okay.
I think we are done.
2 more minutes, sir.
I'm going in. 2 more minutes. The scan is on. We are doing only 1 millimeter slices and we place the center at the ACPC plane. And we are just taking 10 slices to shorten the time. So the total scan takes only 3.5 minutes.
Okay. It is a team effort. Each team member has got a significant role, so one cannot underestimate. So neurologists, we examine the patient independently, and then we formulate a plan which side it needs to be done, and the neurosurgeon do have a role to examine again and then to target the localization. Neuroradiologists have a role to calculate the SDR, and an anesthetist to give a local anesthesia. And also during the procedure, some patients, the blood pressure shoot up, and then they are in, if they are in discomfort, we try to give them paracetamol or injection. So each member of the team is very, very crucial, important to us. So we work as a team, and we formed a very good team. So each one of us understand our limitations, understand our roles. That's why we could be able to do the 150 patients seamlessly with excellent results. And then also we take a video consent to make sure the patient and the patient family understand what to expect, what not to expect. Because they is investing and they are expecting sometimes unrealistic expectation. We clearly tell them the appendicular symptoms like dysarthria, ataxia may not improve much well with either DBS or this MRGFS lesioning. Whereas the limb symptoms, bradykinesia, rigidity, tremor will all significantly improve. But speech difficulties, ataxia might not improve at all. And also the freezing episodes. We explain to them, we take the video consent and only we go for the procedure.
Contrast. Contrast. Contrast.
We are re-examining the patient. I can do that.
And here we have the images, sir.
Can you show me the lesion, please?
Sir, at the level of midbrain, you could see at the superolateral aspect of the red nucleus, you have a small lesion here.
Can you adjust the contrast? We cannot see clearly, Raghu.
Yes, sir.
We could see faintly, but yeah, that's
Yes.
coming up.
And above this level, you could see a lesion.
All right.
At the level of midbrain.
Can you please still adjust the contrast?
Again, yes, sir.
All right. You can see the lesion very
Here.
well. It's come down.
And at the level of ACPC plane also, you could see the lesion, small lesion.
Right.
And above the level of ACPC plane, you have still lesion.
Okay.
Still there.
So we achieved the lesion, we achieved the clinical improvement, and then patient
Actually, we
is
should achieve a central necrosis, good coagulative necrosis, but today we have not achieved, but still the lesion will grow within 24 hours. If we take a
Very well.
scan tomorrow, we will have a central necrosis also.
So we can see that there is a central coagulative necrosis, perilesional edema.
All 3 layers should be there, but today we didn't achieve it.
Then the procedure is over, the MRI showed a lesion, we are dismantling, we will bring the patient, and then he is ready to go home. He will stay usually tonight, And then tomorrow morning, day after tomorrow morning, we'll do the check MRI to make sure that the lesion is persisting, the lesion is growing well, and then we'll discharge them. Usually 1 or 2 days. Since these patients are all come from long way, we don't want to send them home on the same night. We'll be discharging them tomorrow. Nice lesioning. Can you focus the MRI console? All right. Thank you. Generally, we are restricting the patients to take any anti-Parkinson drugs on the same day of surgery. We ask them to not to take, to make sure that the patient has got a significant symptoms and signs, so we can re-examine them. And after the procedure, they can go back to their normal medications, and then we'll try to reduce after a week or two. Can you show the video of them? Okay. 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 We'll try to make him walk. You can see that dystonia component is markedly reduced on the right foot. He could be able to hardly walk before, or now he can able to walk now. When I examined him, the dystonia was so painful. He is almost every day, at least 3 or 4 times, he gets this painful dystonia, which will be lasting for about half an hour to 1 hour. The beauty of the procedure is he can see the immediate benefits. We generally place an indwelling catheter or a condom drainage because the procedure may last for about an hour and a half. They cannot go to the restroom. That's why we encourage them to wear some pads or condom drainage. Audio connect. Vijayan, we are not audible.
Sir, we are taking off the frame, sir.
Right, okay.
He's fine. I hope you saw him walk.
Yes, we did. It was wonderful.
His dystonia is gone. He's happy. I'll just ask him to talk.
Yeah.
Sir, எப்படி ஃபீல் பண்றீங்க?
நல்லா இருக்கு சார்.
ஆறுமுகம் சார், என்னென்ன வகையில் நல்லா இருக்குன்னு சொல்லுங்க. எது எதெல்லாம் பெட்டரா இருக்குன்னு சொல்லுங்க.
சார்,
எந்தெந்த வகையில் நல்லதா இருக்குன்னு சொல்லுங்க.
ஸ்டிஃப்னஸ் எல்லாம் இல்லை சார் சுத்தமா.
உங்களுக்கு ஸ்டிஃப்னஸ் வலது கை வலது கால்லாம் இல்லை.
இல்லை சார்.
வெரி குட், வெரி குட். அப்புறம் எழுதி பார்த்தீங்க இல்லையா,
எழுதி பார்த்து நல்லா நல்லா ரைட் பண்ண முடியும் சார்.
நல்லா எழுத முடியுது. நாங்களும் பார்த்தோம். இந்த காலில் வந்து வலது காலில் உங்களுக்கு அந்த பெயின்ஃபுல் ஸ்பாசம்ஸ் மாதிரி இருந்துச்சு இல்லையா?
ஆமாங்க சார்.
அது எப்படி இருக்குங்க?
அது இல்லை சார், சுத்தமாக இல்லைங்க சார்.
அது சுத்தமாகவே இல்லை. நல்ல இம்ப்ரூவ்மெண்ட் இருக்குது. நாங்களே பார்க்குறோம். வலது கால் வந்து திருகிட்டு இருந்துச்சு, பட் அது மாதிரி இல்லை இப்போ.
ஆமாங்க சார்.
உங்கள் பேச்சில் ஏதாவது மாறுதல் இருக்கா?
இல்லைங்க சார், மாறுதல் எதுவும் இல்லை சார்.
பேச்சில் மாறுதல் இல்லை, நார்மலாக தான் இருக்குது. நடந்து பார்க்கும்போது ஒரு தள்ளாட்டம் இருக்கிற மாதிரி இருக்கா?
லேசாக இருந்ததுங்க சார்.
லேசாக இருந்துச்சு. ரொம்ப நேரம் படுத்தே இருந்தீங்க, மாத்திரை வேறு இன்னைக்கு சாப்பிடல.
ஆமாங்க சார்.
உடம்புல பகுதியில் ஏதாவது மறுத்து போன மாதிரி உணர்வு இருந்துச்சா? வலது பக்கம் முகத்தில், கையில், காலில்?
நத்திங் சார், இல்லை சார்.
இல்லை. ஸோ he doesn't have any sensory disturbances. Generally we see in the capsular effect. கை காலெலாம் நல்லா பிடிக்க முடிஞ்சிச்சா?
பிடிக்க முடிஞ்சு சார்.
பிடிக்க முடிஞ்சது. ரைட். நடுக்கமும் இல்லை, நல்லா ஃப்ரீயாக பண்ணுறீங்களே மூமெண்ட்ஸ்?
ஆமாம் சார்.
வெரி குட் சார், வெரி குட் சார்.
That's it, sir. We are signing off from Royal Care. Myself, Raghu, the team, the whole team, Sabari, the anesthetist, Mohan, our staff nurses here. We are signing off from Royal Care Hospital. Over to you, sir.
Okay, it's wonderful. Congratulations.
Thank you.
Thank you, team. Thanks, Arumugam sir. Thanks for your consent. நீங்கள் பர்மிஷன் கொடுத்ததுக்கு ரொம்ப நன்றி. தேங்க்யூ. ஓகே சார். Any questions? We are ready to answer. Sir, Professor.
To congratulate you on this excellent procedure which saves so many patients' lives. I just like to ask you, I hope you will not take it as embarrassing question. What is the cost of treatment for this procedure?
Sir, cost is really expensive because it charges about 20 lakhs.
20 lakhs.
For the procedure.
Okay, sir.
Because we had to import all the consumables either from Israel or USA. That silicon membrane alone itself cost about 5 lakhs to 6 lakhs.
The secret of the success of your treatment, as you already said, it is in the dedicated teamwork.
Thank you, sir.
That is the secret, sir. Because this dedicated teamwork may not be, it's doubtful whether it will be available in the government setup, even if such infrastructures is provided. So I request you to maintain this dedicated teamwork in future also, and to do a follow-up study, because you've got a wealth of cases.
Definitely.
To do a follow-up study regarding the
outcome,
immediate and late complications.
Okay.
And further studies also.
Okay. Thank you, sir.
Thank you very much, sir.
This is Professor Rajakuru. He is head of the department in Madurai Medical College. He is a senior neurologist.
Dr. Arul, congratulations. Here.
Oh, sir.
Yeah.
Hi, Vikas.
Yeah,
Sir, I
hi,
didn't see you.
hi.
Thanks for
Yes.
coming.
Thank you for inviting. And I am Dr. Agarwal from Chennai. I have been doing DBS since last 2019, and I'm a movement disorder specialist. So congratulations to the Royal Care Hospital. Thank you for bringing this technology to our country and to our people. Truly the results are very, very remarkable what you have showed in the case today. As a DBS specialist, my concern will be to amalgamate this into my referral base so that, but I don't think that, I think that these two technologies should, help each other rather than, fight with each other or compete for the cases. That is one point I would like to make, because the concerns are always there for especially younger PD, like the case which you showed at 43 years of age, lesioning, because we are yet not clear with what is the long-term results. Number one. Number two, DBS, when we do, we are also, all the trials have proven about the motor fluctuation benefit and the on-time benefit. So what is in your cohort of cases of 109, I think, PD cases, what do you think the benefit in the motor fluctuations have you got? Have you studied it, or what is your outcome on that? Because that is one important benefit what we get from DBS. Whether the same benefit you are getting from the lesioning, because this is like one 4L H1 palidotomy like that. The lesioning has been there for a long time, but very well ease of doing, safety, and the patient acceptance, I would say, is much greater, and that is remarkably. It's a congratulations to your whole team.
Thank you. To answer your question, because it's not going to replace. There will be a definitive role for DBS for some patients. As you correctly say, the younger patient will try to prefer the DBS because they do have a longer day outcome, and then they need to live for another 20, 25 years, 30 years. So doing the lesioning surgeries at a younger age is not advisable, so DBS may take a better option. Whereas when you have a significant comorbidities, hypertension, diabetes, coronary artery disease, asthma, and where it's a risk for anesthesia.
True.
So the patient prefer to do a non-invasive procedure like MRGFUS.
Yeah. Because Arul, if the cost would have been less in this, like in the lesioning, so definitely this would have been, because we can do DBS after that also. But in our clinical Indian situation, the cost is equivalent to the DBS.
That's correct.
So then we have to choose one among the two procedures very seriously. That is what my take on it. And I think we have to be more careful with the younger patients and with the genetic PD cases. That is one thing I think we have to think about.
Over the period of years, more and more centers are opening. Obviously, the cost will come down.
That's a way forward, I guess.
Yeah.
Congratulations. Very well done.
Thank you, Vikas. Thank you very much. If there are no questions, we will conclude this session. We have dinner served, and we will meet again tomorrow morning at 8:30 for Professor Dibankar Nandi's lecture. Thank you for patient listening. Have a wonderful evening. Thank you, sir.
What an incredible demonstration. A huge thanks to our expert team for showcasing this revolutionary procedure and sharing their expertise. We hope this session has provided valuable insights into transformative power of focused ultrasound. We request you all to have the delicious dinner which was arranged. Thank you for joining us, and we look forward to seeing you tomorrow at 8:30 a.m. Good night, everyone.